Thank you. I think that should be done.
Good morning, Rohit sir.
Good morning. Good morning.
Hi. I'll just be home in 5 minutes. आप start करा दीजिए.
But don't rush.
No, I'm not rushing. That's why I logged in to tell you that just go ahead and start the session. ये वैसे भी आप ही का thought process है ये वाला session.
Nani, but it's I think it sounds a very interesting session because you have a very good panel here, a very good speakers, bunch of speakers.
Yeah.
It's a beautiful weather. It seems out there, sunny out there.
Yeah, it's very nice and sunny. Although the temperature was 5 degrees today morning, but now it's our sun comes out quite well, so it's nice.
But here it's all foggy, you know.
Dehradun mein na, we have clear weather all through the winter. We never have fog.
That's the best part.
Although it gets really cold, but we are lucky in that sense.
Good.
Because Namrata was in live surgery, so she called me up that she may not join till later. So I said that I'll anchor it, but I got late on the trek. So then I thought,
please, I think as the connection is, you seem to be perfectly fine as far as the transmission and everything is concerned from your side.
Yeah. So another 5-10 minutes, I'll be home. Then I'll be logged in.
Okay, done.
आप start करा दीजिएगा. What time is it now? It's 9:55. So I think people will start joining. Who are the first two speakers, sir?
Dr. Praveen Krishna, and second it's myself.
Yeah, perfect. That's great, sir.
Yeah.
And both of you are chairing the session anyways.
Yeah.
Praveen's topic is very interesting. I was very keen to listen to his talk. So
his is totally refractive sort of, So
So admin can please check if somebody has joined and it needs to be upgraded as panelist. So please do that.
Yeah.
Morning, Gaurav. Morning, Rohit.
Good morning.
Morning. Gaurav, you're the only one who has a real background. All of us have all these artificial backgrounds that we've set up.
Absolutely. So I think Dr. Gaurav is on the way back from trekking and he has got late. So we'll get the session going in that small interim period when he would be, trying to log in when he gets back.
Certainly, sir.
Yeah.
Hello, good morning, Dr. Rohit. This is Neha. I'm here to help you out with the managing the timing.
Yeah, absolutely great, Sneha.
Good
morning, sir.
Good morning,
Dr.
sir.
Ashok.
Good morning.
So, sir, it is already 10. We can start the session. 8 minutes for each talk has been mentioned here.
Dr. Gaurav, would you like to?
Yeah, a
please.
very good morning to everyone, and thank you so much for accepting to be on this session on behalf of Dr. Lalit Verma, Dr. Namrata, and the executive of the SAO. And they were kind enough to give us this session to think differently and to tell what we are doing differently this year as it comes to a close. And and we look forward to the new year. So I'm handing over to our chairpersons for the day, Dr. Rohit Om Prakash and Dr. Praveen, who will take this forward. And we'll try to have short discussions after each talk if time permits. And when it does not, then we'll just go through and try to discuss a little bit towards the end. So all yours, Praveen and Rohit, sir.
Yeah. Thank you, Dr. Gaurav, for the privilege of chairing this session. So I have with me Dr. Praveen, who needs no introduction. He's from LBPI, so he would set the ball rolling. He would be talking first on reimagining anterior segment imaging. Over to Dr. Praveen, please.
Thanks a lot, Dr. Om Prakash, and thanks a lot, Dr. Gaurav, as well, for having me on this session. And to all the SOA planning committee as well for planning such a wonderful session and conference as well. The topic, or at least the theme of the session, is what did you do differently in 2021? And I thought that since the last year has been a follow-up of several challenges that we've had, let's talk a little bit about thinking differently and doing things a little differently rather than pure surgery or pure medical advances. So the topic of what I'm going to be talking to you about is called staying connected. And this is a journey that we actually started in middle of 2020, and it came to fruition in the whole of 2021. So let's see what I really mean by the topic about reimagining anterior segment imaging. Well, again, the reference point here is the COVID pandemic that we saw last year and which still seems to haunt us in several ways. And what we used to do before it struck and what we do right now and what we hope to do in the future as well will form the crux of my presentation. Well, talking about anterior segment imaging and what we can visualize from a patient and the information that we get from a patient, I think we are all actually very blessed because of the number of devices that we have access to and the amount of information that these devices can actually give us. But then after COVID, where we had lower numbers of patients and where we're trying to reduce non-essential visits of the patients to the hospital, we started to think about how we could actually enhance the amount of information that you get from a patient when the patient is not in your clinic. And so the goal that we set out for is to reduce the physical footfalls of follow-up patients, that is patients that we've already seen, by about 20% across the network of our hospitals. And in our network, we see about 4,500 follow-up patients every day. So that goal was to see about 700 of these patients online rather than bringing them to the hospital and risking exposure for infection. So what we did right in the beginning of the lockdown period of 2020 was we set up a very simple teleconsult system by just getting the doctors to call the patients to find out how they were doing. And then we transitioned into a more robust system where we had a telecounselor set up over the next 3 months, where patients were called actively to actually find out how they were doing and also to solve their problems online. Following this, we set up another system, which was a web-based system for teleconsultation using our electronic medical records and by booking appointments for patients. And the current version that I'll show you today is version 4, where we set up a mobile app to enhance teleconsultation for patients as well as for doctors. Actually, this journey is published in IJO and about how we set up the teleconsult system, but I'll be talking about what we did after that. And in fact, several of us think that we might not solve the patient's problem during teleconsult, but when we queried patients, 95% plus patients actually felt that their patients were solved on the teleconsultation instead of coming to the hospital. So right now, what we have is we have a mobile app called Connect Care that we built ourselves, which has a patient-facing version as well as a doctor version, where the doctor can see the number of patients and the number of appointments that they have, and they can also look at the medical record of the patient because this is linked to the electronic medical records of the patient in the hospital. So we saw that this sort of took off pretty well in 2020 and then hit a plateau. But then when we started to continue to do this, even after COVID went away, we realized that this system has a lot of value. And as of now, we see about 2,700 patients every month completely online. And we have, as of now, about 50,000 consults that we've completed since June of 2020. Here again, we've been able to see patients who can pay for their care as well as patients who are seen completely free, showing that mobile phone penetration in India actually is not limited to urban areas, but also to rural areas as well. The maximum number of consults we did was actually from cornea anterior segment, followed by retina and uvea, which is quite interesting, and several of the other specialties like pediatric ophthalmology and plasty as well. And we also saw that the patients came from all over India. All over India, patients were actually consulted online, and we were able to solve their problems in the majority of cases. So how did we do this? We set about trying to get information about the patient by asking a good history, by asking them about the right eye and left eye comparison, asking them about reduction in vision, their symptoms, and other clues that would help us arrive at a diagnosis. Ask them to assess their eye themselves by looking at a mirror or asking a relative how the eye looked, and also by testing several visual acuity apps. In fact, we had 2 rounds of testing of visual acuity apps, and we recently published the fact that the validation of our results of visual acuity, and we found that Peak Acuity, the visual app, seemed to be the closest to the in-clinic experience of visual acuity measurement. So now you can also measure visual acuity offline for these patients as well. Now, the next stage was to get more information from the patient about their eyes. And when we asked patients to send in images of their eyes, this is what we got. Either these images had very good resolution depending on the kind of phone the patient had. And sometimes with modern phones like the iPhone, the patient was able to capture images which were almost as good as slit lamp images. But then there was a lot of variability as well in the kind of images that we got from patients. And we were trying to diagnose several corneal and anterior segment conditions using these images. Well, we already had a setup in our rural centers where vision technicians tend to send images of patients and also do a consult with the doctor who is sitting in the tertiary center. So we tried to use the same model using a tab attached to a slit lamp. But because a patient does not have access to a slit lamp, we had to build something different. So when we asked patients to actually get more instructions and send proper images, again, we found that there was trouble because there was a lack of frame of interest, lighting was not standard, and there was no focus. And when we looked at the images, only 16% of the images that the patients sent were acceptable to clinicians for them to make a diagnosis. So this is where we set about trying to build a solution to get better images from patients as well. And this little device that you see here is the result of all those efforts. So this device, which we call Grabby, is a device that can go onto any smartphone that the patient might carry with a standard distance and rest on the forehead. And it comes along with an app which helps patients to actually capture image. And the app also makes sure that it changes the camera settings to ensure maximum illumination as well as focus on the area of interest. So what we are doing right now is we are doing a demo for patients, dispensing this to the patients along with the app. Patient takes the image and shares the image before teleconsultation. And some of the images that are captured on mobile phones using the app are so good that you can rival slit lamp images by these images as well. And in fact, for a small segment of patients, we also incorporated a blue light into this imaging device. And we were even able to look at contact lens fit and also fluorescent staining enabled information from the eye. And when we compared how these images were compared to slit lamp photographs, we found that these images, clinicians rated at least 75% of these images were almost as good as slit lamp photographs, which is fantastic considering that you're getting images from a patient's phone. All of these images are captured by patients on their phone using this device. Then we went through several iterations. You can actually see the number of iterations that we went through. And the one towards the right is a final version that we have. And this is now attached to an app. You can see the app in action right here, which allows the phone to turn on the illumination and take a great picture with focus as well as area of interest. One of the advantages of all of this is the fact that we were able to create more space in the hospital for patients. That is, we reduced the number of patients who needed to come for follow-up, and we saw a 10% increase in the footfalls of new patients for cataract, as well as for diseases like retina and uveitis as well, which is, in addition to the benefits to the patient, great benefit to the hospital as well. And in fact, what we've done is we've moved all our refractive surgery post-op consults online, so we don't have to see these patients in the post-op visit, but then see them after some time. And we found that when we compared the visual outcomes of patients who were seen online versus completely offline, we found that there was no difference in the outcomes of refractive surgery for these patients as well. We've also set up a peer-to-peer teleconsultation platform where we have vision technicians in the small rural centers who take images and share them with the doctors sitting in the tertiary center. And along with this, what we've been able to do is we've been able to get very good images of these patients' eyes. And these images, including a fundus photography system that we've also set up at these vision centers, we've been able to triage patients into 3 levels. Red referral is patients who need to go right away. Yellow referral is within 2 weeks, and green, they can be treated at that center itself with advice by the doctor remotely. And we were able to find that of all the patients who came, 84% of patients who came to these rural centers, total of almost 40,000 patients, were consulted remotely, and they did not have to travel to the main hospital in the city, which is a significant saving both for the patients as well as for the environment as well. We've also created a web portal for doctors to access the electronic medical records of their patients so that on the go, they can do teleconsultation from wherever they are, if they're traveling to the airport, if they're on a train, anywhere. And the consult is also available for any external doctor to book a time or an appointment with an LVP doctor, or also consult them for their patients, and also create slots when they want to refer a patient in as well. The next step of that is our home care portal. We have also set up home care services where patients who are not mobile, now we are able to carry several devices that we've designed in-house using a mobile topographer, a mobile visual fields analyzer, and a pupil measurement device that the technician carries to the patient's home, does all the images, and then shares these with the doctor sitting in his office, and the doctor is able to consult the patient with all the information that he has. So to summarize, the remote eye examination is the sort of difference in the way we look at the anterior segment and how we image the anterior segment. It is not like an in-clinic exam, but then we should understand what we can take care of and what we cannot. But with a triad system determining the urgency of visit, you can reduce non-essential footfall and get a lot of information about the patient's eye by not having the patient come into the hospital. But for this, it is also essential to collaborate with others and set up a great system so that in the end, the beneficiary is the patient. Thank you so much for listening to me and for your time as well.
Excellent presentation, Dr. Praveen. I think adversity brings in the best, and so it has. I think what you have shown, I think it's very relevant for South Asia, because in South Asia, it's very difficult for patients to travel. The means are not there. Even in a village, if they have one app per village, that can really help. The non-essential and the red, yellow, green is out of the box thinking. Well, Grab's Light is what you said. Is it available? Is it an app which is freely available? Any ophthalmologist in the South Asia can use it?
Yes, anybody can use it. It is not available for purchase yet. We are trying to reduce the cost so that it is so low cost that any patient should be able to afford it. It should be available for purchase in the early part of next year. So the device comes with a version of the app. So both of them will be available together. For vision care specialists, ophthalmologists, optometrists, we are creating another version of this one, which is called Grabby Pro, which actually will have its own illumination and gives even better images with a magnification macro lens as well. So that will be available somewhere around the end of next year for usage by anybody.
So in other words, any ophthalmologist, if he has this, can he use it for his practice also?
Absolutely, absolutely, absolutely.
I
These images can be shared by the patient on WhatsApp or any portal that they would like to export them to, and the ophthalmologist can access them. It is not locked into any one single portal.
I think we have to thank COVID for that. For being,
Absolutely,
absolutely.
absolutely.
I think
It was amazing, Praveen. I mean, fantastic work that you've done, and it really relates to. What we can we can relate to how you guys improvised, and fantastic. I mean, we tried our own version of the similar thing, but this is just amazing. Yeah. Thanks for sharing.
Thank you.
so. Now, should I start with my presentation, Dr.
Absolutely, sir. And I think Rohit sir needs no introduction. He's the pioneer of, phacosurgery in the country, and he loves innovations. So he obviously does things differently every year. So let's see what he did differently in the year gone by.
Thank you, Dr. Gaurav. So I would be talking around for what all did I do differently in 2021. Am I audible, and is my screen visible?
Yes, sir.
Yeah. So just a sec. So the first thing which I did in this year was that I started using trocar for fixing subluxated IOL bag complex. So when the trocar was used, as I would show, there was no corneal tissue entrapment, and there was an easy maneuverability, which I personally believe would go a big way in making it easier for everybody to do it. This is basically the idea of Amar Agarwal and Dr. Priya Narang's technique of fixing iridodialysis repair. So I just used it to take care of the bag IOL complex subluxation. You can see now the trocar has been fixed at the limbus, and I am a lefty. So you can see how easily there is no problem of the tissue getting entrapped, corneal tissue getting entrapped. And I've left it, and I've used in my non-dominant hand. And the rest of the procedure of going behind through the for rail loading, the needle is there. You can see how this is all an unedited one, just to show how easy the maneuverability becomes for fixing the bag IOL complex. There is no instability in the anterior chamber when you are going in. It fixes, it gives you a good maneuverability, and there is no corneal tissue entrapment. Once that is there, you can see now I'm doing the second one. Once that goes in, so this trocar assisted IOL bag complex fixation. I personally feel we have to give credit to Dr. Amar and Dr. Priya for bringing out this concept, but this will have so many applications in using these needles to do railroading, which becomes at times very cumbersome for surgeons. You can see how easily I was able to maneuver all this. So trocar assisted was one thing which I did. The second thing which I did was use chopper as a shield in dense cataracts. What happens in dense cataracts is whenever the nuclear fragments are being emulsified, so they just rebound and hit the endothelium. So there is no physical barrier to protect the endothelium from being hit by these hard dense nuclear fragments. So it's a big add-on to the existing corneal endothelial protection techniques. This is a hard cataract, black cataract you would see that I'm trying to take up in this case. And here you would see what I'm doing is, after separating, see how diligently I am placing the phaco chopper anterior to the nuclear fragment. So it is keeping the nuclear fragment away. And I'm just shielding it. I am going right after it, maneuvering. It's a normal chopper which is being used. And I'm doing all, you can see there's hardly any nuclear fragment which rebounds off. Yes, they do occasionally, but then with this chopper shield in your armamentarium, I personally feel if you add it, you will find that the endothelial cells are less traumatized and the cornea appears pristine clear. Not to forget, we have to use different techniques. It's just an add-on. we have to do deep plane phacoemulsification. A viscoat or a corneal viscodispersive has to be used. Nuclear fragments have to be small, and they have to be totally separated. So when all these things are done in conjunction with a small maneuver which I started using in the late 2020, which has become a norm in my technique nowadays, I have found that, to my surprise, and that the corneas are much, much clearer with this small change in the technique. So this you can see in all this video. Now, this is, you have to recoat the endothelium with viscoat for that matter. And this takes care of, this is the second thing which I did differently in 2021. Uh, this calcified subcapsular plaque, I would like to give credit to Deepak Magur, who brought out this concept, because these subcapsular plaques calcified, they have difficult management with plaques, and the adherent plaque causes difficult completion and at times can cause capsular extension. So in this video, what is the plan is that you create a small rhexis central to the subcalcified plaque where it is adherent to the anterior capsule. So I'm not going in the periphery, as you would see. I'm creating a small rhexis right in the center. Mark my words, it is central to the adhesion with the subcapsular calcified plaque. Now with this spatula, a flat spatula for that matter, I would be going in 360 degrees to separate the calcified subcapsular plaque from all the sides from 360 degree. So once that is achieved, lately there was a case in which I was not able to, because at times it becomes a long drawn case. The adhesions become too difficult to maneuver. So once the separation is complete in these patients, if you are able to, then the calcified subcapsular plaque can be easily taken out. So you will see I'm using different ports to achieve total separation. So this flat spatula is also very important in this. Now, once that is done, then you can enlarge the rhexis to the normal size, as I would be doing here. And once the rhexis is completed, here it becomes very easy now to complete. The staining was not adequate somehow, so I was having some bit of difficulty, because in these at times you do not have a good, and then ultimately the emulsification was adequately completed. Another important thing which has happened is that, so the plan is initiate right in the center, small rhexis, flat spatula, totally separate 360 degrees, the plaque is removed and the rhexis is enlarged. Calibrated side port incision, I came out with the concept in 2020, and now I'm using it in 100% of cases. It was just only for IFIS, but now with addition in all the cases, it has really helped. In this calibrated, what I'm doing is, I found that this was a 500 micron 25 gauge needle which I was using. The chopper was 400 to 450 microns. So this 50 microns and 100 microns at the proximal and distal end allowed maneuverability of the chopper, so that the emulsification and the chopping could be easily done. With this long tunnel calibrated one, it at times is a self-sealing one, as you will find it is there in 30% of the patients. With this side port incision being calibrated, there's less efflux of fluid, less touching of iris, and it makes the chamber consistently deep. So this is the nuclear emulsification. You will find that I'm using the calibrated chopper with the incision, and you would find that despite using high fluidics, in these patients, the IOP no doubt is on the lower side. The maneuverability in this patient with who was on tamsulosin became easier. And there's another trick which I was using. I was emulsifying in the proximal part so that the iris didn't get emulsified. So these were the things which I did new in 2021. Thank you very much, Dr. Gaurav, for the opportunity. Thank you very much.
Thank you so much, Rohit sir. Your you're always amazing with your new innovations, and it's always great to see and I learn so much every time I listen to you. So thank you so much. In fact, that chopper shield, fantastic, and even the first presentation. So I think anybody else who would like to quickly comment, Praveen, any thoughts? Harshul, any thoughts?
No, I mean, a lot of times you do things without thinking about them. And I think all through the 4 videos that Dr. Rohit sir showed, I mean, these little nuances that help improve the outcomes of cataract surgery that a lot of us would just like miss. But then the way in which Dr. Rohit sir thought about them and is using them to benefit the patient to have better outcomes, I mean, that is just amazing. So fantastic videos, fantastic thought process as well. Thank you.
Great. So I think with that, we'll go on to the next presentation, and I'll quickly check. Praveen, you would probably know because I just logged in and I'm still getting into order.
So next up is Dr. Pooja Kamar.
Okay, perfect. Yeah, Pooja has joined, I think. Yeah.
Yes. Pooja is, again, probably one of the brightest, smartest young ophthalmologists that all of us have been listening to for the last several years. And again, generally, Pooja's work speaks for itself. Pooja works in the cataract and refractive surgery service at Narayana Vatsyalia, and she has been spearheading several innovations over the last several years. So let's hear what she has to tell us that she did newly in 2020, 2021. Over to you, Pooja.
Thank you. Thank you, sir, for that wonderful introduction. I would like to thank the entire SAC committee and Gaurav, sir, for having me here. I'm going to be speaking about bringing lab on chip to reality in 2021. So now all of us were bombed with this pandemic, and we did not know what to do, what not to do. So it gave us, we have been working on bringing a tier diagnostic kit to our clinic since past many years. But this 2 years gave us a good buffer time to actually concentrate on it and bring it to beta testing phase. So why do we need it? There are many knowledge gaps in refractive surgery when it comes post-LASIK discomfort, inflammation in dry eye disease, pain without stain in dry eye patients, post-LASIK ectasias, progression in keratoconus, haze, scarring. That is when it comes to anterior segment. But now there are conditions like, your diabetic retinopathy patients, they progress from mild to severe NPDR with CSMEs. There is myopia progression. You don't know why is it happening. Glaucoma patients, they are progressing and you don't know, in spite of them being in medications, and you do not know that, why these conditions are happening most of the times. What is the missing link? We have everything in place: clinical signs, symptoms, medical history, systemic evaluation, imaging, everything. But then also we land up in this complication. So what is the missing link here? Of course, 2021 did teach us that the way to go forward is power of rapid diagnostics. When COVID came in, it took 2 days for the test report to come, which made all of us anxious. What is there? What is there? But then it now takes half an hour. Of course, we got to know the power of immunology. Of course, we never thought about it. Being ophthalmologists, for us, it's also only treating the patient condition. But now it taught us that, yes, immunological conditions have a lot of power, and we have to see targeted drops on how to modulate it. So that COVID 2021 did teach us that. So that brings us to the need. So now in your eye, there are a lot of inflammatory cells which are responsible for poor wound healing, dry eye diseases, ectasia, ocular inflammations, in refractive surgery, keratoconus disease progression, and dry eye disease. And there are a lot of trials on potential specific molecular biomarkers in ocular diseases going on across the world by various scientific committees and various companies that bringing different drugs like lifitegrast, cyclosporin, etc., etc. But how do we know that which patient needs which drug? Do you want to just be like a paracetamol, headache happens and you give a paracetamol, or you want to find out the root cause of, from the 100 reasons, you want to find out one root cause of the headache and treat that specific target? So we need to look at those specific ocular molecular biomarkers in ocular diseases as well. So we wanted to see that, like how the COVID-19 RT-PCR kit has come and the other kits which have been there since a long time. Can we also have a point of care diagnostic kit to diagnose these ocular changes? But the challenge was to pick up the right markers. So what we did was we chose some specific markers where it is IL-6 is responsible for itching in your patients, any patients, not dry eye, but your post-refractive surgery patients, your glaucoma intolerant patients who are intolerant to medications, your post-cataract surgery patients who have chronic itching and they come and tell us that, I have itching, cataract surgery messed up my life. IL-1B is related to inflammation again. IL-10 is related to discomfort again in all your patients. TNF-alpha is related to inflammation and scar in your post-PRK patients or cross-linking patients. MMP9 again, inflammation. IL-17A is responsible for pain, and ICAM1 is responsible for inflammation. So, these are the specific markers which are most common in all your ocular conditions, be it your anterior segment pathologies or your posterior segment pathologies. So we decided to take this set of markers and build a point of care diagnostic kit. So these are the diseases where these markers are involved: glaucoma, central retinal vein occlusion, dry eye disease, Sjogren's disease, ARMDs, again uveitis, anterior chamber associated immune deviations, dry eye disease, keratoconus, multiple disease. So we took this set of markers and we decided to build a kit. So we built a point of care diagnostic kit, which is ELISA fluorescence based microfluidic devices, and we incorporated all of these markers in this device. And so all these markers are in one cartridge, and in future more can be added as well. So what we did was, of course, we know that this is working, but we wanted to bring it to clinic. So we started beta testing on 20,000 eyes in our clinic. All the cohorts were included: controls, post-refractive surgery, dry eye patients, evaporative dry eye patients, keratoconus, post-cross-linking patients who are stable and who are progressing, and SJS conditions, chemical injuries, glaucoma patients, diabetic retinopathy patients, and drug toxicity patients as well. So we did all of them. We did the tear collection with Schirmer strip and incorporated them in the point of care diagnostic kit in that cartridge. This is the workflow. You can do it in your OPD. You now don't need to go to exotic labs to analyze it. Just how you do Schirmer's test, you collect those strips in an Eppendorf tube, add 300 microliters of buffer solution, shake the Eppendorf tube for 5 minutes, and then whatever tear proteins are there, you put it in the cartridge here in the slots, and you put it in the kit. And by the end of 45 to 90 minutes, it gives you reading on the screen, and it comes in form of this report. So there is a normative data range, and you can, based on your results for the patient, you can see whether it's higher or lower. So now let's see some case examples. This is just a preamble. This is a dry eye patient. Schirmer's test usually within normal limit, tear breakup time 8. Known case of dry eye disease for 4 years, not comfortable with medication. Screen time, IT patient, IT professional, but screen time is reduced to 2 hours due to dry eye symptoms. OSDI scoring is 47.91. What to do? Should we give him just the routine treatment? We did the tear diagnostic test and we analyzed the markers. If you see here, the MMP9 values are normal of 49,000. This patient has 2 lakh. IL-6 23, this patient has 39 and 81. IL-1 beta, which is responsible for itching, the normal value is for 4.36. This patient has 20.9. So now how do we go about it? There is cyclosporine, which will work on IL-6, and that anakinra drops, which is an IL-1 antagonist, but we do not have this at this point of time in the clinic. And of course, these are going to be ineffective therapies because this the ICAM and the IL-17 are on the lower side. So only one drug I have, cyclosporine, but it's not going to be enough. Then there are this IPL therapies, the intense pulse light therapies in your system, which is going to work on the meibomian secretions. It's going to reduce the secretions and it will give us a normal ocular surface. There's a pathology behind it. I'm not going to go in detail. So, and this work has been published. So, and this works on markers like IL-6, IL-1 beta, IL-4. So we decided to go ahead with a treatment of cyclosporine and IPL therapy plus LLT, which will work on all these 3 markers, and patient will be comfortable. Now, this is one patient who is in early grade of keratoconus, but has progressed over time, over 2 years. Left eye is a little bit higher. Both eyes similar, but left eye is a little bit higher than normal. So again, we did a tear test for this patient, why this patient was progressing. Just for our, of course, we have to crossing, but we wanted to understand what made this patient progress with low grades of inflammatory markers. Again, MMP9 is higher, IL-6 is higher, and all these markers, ICAM1 and IL-17 also are on the higher side. TNF-alpha is normal. So what would be the procedure for this patient? We treat the patient's ocular surface inflammation, because if we do not treat it before cross-linking, post-surgery patient can land up into sterile infiltrates, haze formation or scar formation, or failure of cross-linking, which will lead to progression. So we decided to treat this patient preoperatively with cyclosporin, tacrolimus, and the IPL therapy, and reduce the ocular surface inflammation, and then do the cross-linking procedure to reduce all this consequences. This is again a third patient, high grade of KC. If you see here, the markers are on the lower side. So we just decided to proceed with cross-linking without doing any other treatment. And this is also one of the other cases where biomarkers are on the normal side. So here again, we can proceed with cross-linking without doing anything else. I think this is just the repeat of case. So I'm going to, yeah. So, yes, sorry. It's just repeat, so I'm sorry. So now what are the applications in cataract surgery? Of course, patients come post-operatively with complaints of chronic itching, discomfort, pain without stain, poor wound healing, glare, halos, and even if in post-torical refractive surprise, which poor quality of vision or regression. So if you see here, these are the markers which are responsible for these complaints. So we can actually do the test for these patients. We do not need to stop the surgery, but we just do the tear marker test for these patients pre-operatively. It doesn't take much time. And then if any of these markers are on the higher side, along with our normal post-operative medications, we can add one of the medications which will work on these markers again. And these are the drugs which are available in market right now, which we can give if one of the markers are elevated. So we are also working currently on the retinal conditions. I'm not a retina person, so I prefer not to talk about it, but the kit is being used for the same. In vascular occlusions, diabetic retinopathies, we have VEGF also in our kit. So we will know whether which patients need anti-VEGFs and which patients will need steroid at the first time, and will not keep pumping up different injections without the need. Of course, in ROP babies, whether they also need anti-VEGF treatment or not. Dopamine levels in myopia progression and in glaucoma conditions. So all this work is ongoing at Narayan Nethralaya, and we are collaborating with biotechnic company for bringing it to your clinics. And of course, the FDA trials are ongoing, and we will in future will be adding more markers. So we started this journey in 2010, but however, because of a lot of other work and clinical work, we couldn't do it. Bring it to our clinics. We couldn't even bring it to beta testing, but COVID did help all of us to bring it in beta testing and for mass production of the kits. Thank you. I would like to thank the entire team, of course, without whom this wouldn't have been possible, and the Narayan Nethralaya family. Thank you.
Great work as usual, Dr. Kamar Pooja. And I mean, this is a completely different approach from what we have been used to. That is either published literature or textbook teaching from managing different diseases. So from the point of view of using biomarkers for different diseases, sure, a lot of these diseases are multifactorial and have several reasons why they either progress or they're amenable to certain subtypes of treatment as well. So with time, I'm sure you're also trying to build a subset of patient features that probably would be useful to use certain therapies using these biomarkers as well. But how easily and how affordable do you think this is going to be for access in the future, say like 5-10 years from now, once you've completed your trials and you have this going to production? What's your goal in the future?
So right now, the costing which is coming, like, if you consider all, the staff, the everything behind it, it costs around 100,000 rupees for 2 eyes for a patient. We are trying to build it in India only. So of course, in future, we will be able to bring down the cost further. But right now, both the eyes around 1,000 rupees per patient. So, and it gives you 8 markers. So that's the beauty of Made in India.
Good work. Thank you.
Thank you. Thank you, sir. So, we've got one thing which what you said, sir, is I would like to add here is what 20,000 eyes data we have collected. We have the entire demographics also behind it. So we are putting all the demographics and the molecular biomarker data, and we are running AI on it. And that's how we are trying to bring out which permutation and combination, if your patient has, which treatment to give to the patient. So that is what we are doing along with this 20,000 eye results. So that would be more easier. Tomorrow, when we give the kit for clinicians to use, they'll also have an algorithm on how to go about it. And of course, few companies will be helping. In India also, they started helping us with newer therapeutics, which works on this marker. So that is also like ongoing, but that will take a little longer time.
Great.
Thank you,
Over
Pooja.
to you.
Fantastic work. Yeah. Praveen, should we go on? I have Ashwin's video, so while he's not here, I'll just play that, and then
Today, my topic is the dangling IOL to a dropped IOL management. I am a consultant.
Is it audible?
advisor, but none of it pertains to
Not
me.
much, not much.
Okay.
Let's
let
move
me.
on. Here's a case of subluxated capsular bag IOL complex with an endocapsular ring. The minute I see a 3-piece intraocular lens with a subluxated bag, my tendency is to go towards a glued.
Let me see if I can just do it again. Yeah.
It was fine, in fact. Yeah.
You could hear it?
The reason I put
Yeah.
vertical flaps is because my horizontal white to white is 12 millimeters
Okay.
and I like it lesser than 12.
I'll just take it
Next,
back
I
for
place
15
intraocular
seconds.
lens as a preferred technique of mine. Here I'm making vertical flaps. The reason I'm making vertical flaps is because my horizontal white to white is 12 millimeters and I like it lesser than 12. Next, I'm placing a trocar AC maintainer to have infusion all the time inside the eye. Under the flaps then, I'm making my sclerotomies approximately 0.75 to a millimeter behind the blimbus. Now, holding on to that endocapsular ring, not yanking, I'm performing my anterior vitrectomy and bag remnant removal. Once I've been able to remove enough of the bag remnants and perform enough of the anterior vitrectomy, I grab with the forceps or the glued IOL forceps the haptic of that intraocular lens that is already inside the eye and externalize it used through the sclerotomies. But inadvertently, in this case, I've also managed to break and pull out the capsule tension ring. Once I am now done with a little more of anterior vitrectomy and bag remnant removal, I then externalize the next or the trailing haptic in this case to ensure that my haptic and my intraocular lens are now stable. Making my Gabor-Chariot's tunnel, I tuck these haptics into the Gabor-Chariot's tunnel, thereby stabilizing my intraocular lens. I now perform anterior vitrectomy in the anterior intracameral space with triamcinolone to ensure there is no vitreous in the anterior chamber. This now helps me also denote a problem. Optic capture can happen and with the iris, and that can be avoided in the post-operative period by simply doing one single pass 4-throw pupilloplasty or a pupilloplasty of your choice. My choice going towards SFT, wherein I'm placing a 9-0 or a 10-0 Prolene suture, looping it from one side and passing it 4 times. Again, single pass and 4 throws, and that's about it. I now pull both the sides apart, thereby closing that gap which was present and thereby not allowing that optic of the intraocular lens popping up. I remove my infusion, place my air bubble in place, put some glue under the flaps, and that's pretty much the end of this case. Here are some of the post-operative pictures of the same case for your viewing. The patient achieved 6/6 vision by the end. Moving on to a bigger problem, the dropped intraocular lens. Leaving a dropped intraocular lens inside the eye can cause a lot of problems, such as vitritis, endophthalmitis, and all these complications seen here. What are the procedures that are followed up until now? Let's try and understand that. The first step that people perform when they have a dropped intraocular lens is a core vitrectomy. Next is an IOL lifting forceps is used to lift off that intraocular lens. Different shapes of IOLs, different problems. The third, they might use a PFCL to actually float that intraocular lens into the mid-vitreous cavity and then lift it. Next, they may reposition this intraocular lens into the sulcus, or if you don't have good enough sulcus support, then a glued intraocular lens is then performed. sometimes it may need to be extruded from outside and then a new lens implanted as a glued intraocular lens. What are the fears, risks and complications of doing this? First, the proximity of the forceps to the retina. It might cause an edema, a hole or a tear, and even hemorrhage that aborts the case. Most often, inability to pick up the intraocular lens is a big issue. PFCL has also known to cause their own set of complications. So what's the solution to all of this? Fears and risks. Well, introducing the extrusion cannula assisted levitation technique, better known as ECAL. The extrusion cannula is a simple device that is used in retinal detachment surgery to drain the subretinal fluid. It's got a steel body and an inner silicone tip. It's used to drain subretinal fluid. In ECAL, I'm using the same device without the soft tip to actually occlude on the optic of the intraocular lens and bring it up into the pupillary zone. Just like this, smooth optic of the intraocular lens and the lumen of the extrusion cannula helps me lift this intraocular lens into the pupillary zone for me to externalize or remove the intraocular lens. Again, foot pedal is not pressed until I adhere to the optic. Once I adhere to the optic, it's pressed full swing at 400 vacuum. Positioning. Do not hold it when your occlusion to haptic tip position is long. Hold it in a position where your occlusion to a haptic tip is short. This way, when you supinate your hand and bring the haptic into the pupillary zone, you're able to externalize it very easily and not have to supinate your hand a lot more. Look at this. All I have to do is turn it to an angle where my occlusion to haptic tip is short. Now, externalizing the IOL is a 5-year-old's game. Next, we then include or reposition an intraocular lens with the secondary IOL of your choice. It could be an AC IOL, it could be a Yamane technique, could be a glued intraocular lens, any technique. My preferred technique is the glued intraocular lens, and hence you'll watch me doing the glued IOL technique in these cases. This is the end of the case in a ECAL technique to lift an intraocular lens that has dropped into the retina. Thank you very much and glad you're watching. Keep watching more.
So I think that was nice. I think Namrata has joined us. Thanks, Namrata, for organizing this session. You're muted,
Thank
Namrata.
you.
I think you're in the
Yeah.
OT.
Thank you, Gaurav. Thank you for doing it. We have to thank you.
And Praveen and Dr. Rohit sir actually started it off because I was running 5 minutes late. But and we have had wonderful talks so far. So I was just watching this last video, and I'll take quick comments from anybody who's used this. Just 2 days back, I happened to use this soft tip cannula. I was assisting Saurabh in one of his surgeries. I mean, there was a nucleus drop or something referred to us, and he wanted me to come and put in the lens, the IOL. And there was some cortex which was just under the rim of the capsule. So I was hunting for my bimanual eyes, and the staff had forgotten to put the bimanuals into the set. So I was wondering how to get it out, and I asked for a Simcoe's, and I said, get me something. He said, why don't you try this soft tip? It's quite amazing to use. So, on the Constellation, I just used the soft tip through a side port. And it's actually such an amazing tool. And I'm thinking of lots of applications which anterior segment surgeons could have with that soft tip thing, which Ashwin just showed us. I mean, I can understand now why he's so happy about using that to lift up the IOL. It's quite an amazing thing, absolutely atraumatic. And you can actually go anywhere, and it's, it doesn't break the capsule. So even if you tend to kind of push against the capsule or something, it doesn't tend to break it very easily. It just bends, So I think a lot of applications and a lot of new things that come up just inadvertently. Namrata, any thoughts on that? Are you guys using anything for cornea or
No, I think it's a great idea. I think I've taken the idea from here, but we are not using it, or we have not used it, but I'm sure we are going to use it now. I'm in the OT only, so I can tell my nursing staff to keep it ready the next time if required.
Absolutely. So I think some new pearls there. And I just wanted a quick question before we go on to the next one. What percentage of anterior segment surgeons, like cataract surgeons, are comfortable doing all that Ashwin showed? I mean, of course, going into the retina and everything is totally something else. But I mean, going into the posterior segment, but doing the, different techniques of the Yamane and the SF IOLs and the, the glued IOLs, what percentage of people, are comfortable? Because it does tend to take you into the posterior segment. So just a quick poll amongst all of our speakers here, how many of us are, routinely doing it, or how many of us are referring it off to our retina colleagues or whatever? I mean,
yeah. So long as the SFIOL or glued or Yamane has to be done without lifting the IOL, the dropped IOL. Well, dropped IOL is beyond me, so I refer. But if a secondary or a primary where there is a glued IOL or SFIOL has to be done, for that, yes, I'm for it as an anterior segment surgeon.
Absolutely. So if it happens intraoperatively, I will innovate and I'll do it. But if I have to do it electively, I will many times refer to just the retina guys, because they are doing it every day. So that's my take on it. And I don't know about Harshul and Vardhaman, what
they are doing. My surgeon does it for me. Yeah.
Yeah, no. So I think setups where a retina surgeon is immediately available will be easier to just let them, kind of retrieve these if they have to be. But electively, I think so. Vardhaman, anything, and then we go on to the next one.
The same thing, actually. Even if it is elective, I always refer it to the retina surgeon. But if it is intraoperatively, if we see something, the glued IOL can be done that time.
I think cleaning up the vitreous as well is a very, very important part of this surgery. So I think there we probably, electively, yes, it can be left to them. So I think we'll go on to the next one. And next, I think on our, this thing is Harshul, is it? Harshul is the next speaker, I think. So Dr. Harshul Tuck is going to talk about modified hydrostitch and visco cannula. This is something really I enjoy. And Harshul, please go ahead and share your talk.
Yeah, thank you so much for giving this opportunity, Dr. Gaurav, Dr. Namrata, and Dr. Rohit sir. And we all know that. Can you see my screen?
Yes, Harshul. Yes.
Okay. So we all know that necessity is the mother of all inventions. So let me give you briefly how I came up the idea of modifying the existing viscoelastic cannula and the hydrostitch cannula. So a lot of time we face problem whenever we want to do visco exchange in situations of posterior polar cataract or torn rhexis, where we don't want our anterior chamber to collapse. We need to put visco through side port. So the existing visco cannulas, they are of 19 gauge and they go with some struggle into the side port incisions, which are 1.2 millimeter in size. So that's how I came up with this idea. And this is designed by, this is manufactured by Ovation, no financial interest. And it goes by my name now. It's commercially available. So this cannula. It's you can see it's curved like this, which has a 22 millimeter long tip. And the beauty is that it is tapered at the tip. So, and it's a 23 gauge cannula. It easily fits in the side port incisions. And it has a lever lock because the resistance is more if you compare with the 19 gauge cannula, routine HPMC cannula. So it has a lever lock here. So it's fitted on the lever lock syringe, which comes with the pre-filled syringe of many companies. So if you see it in action, as you see here, this is the cannula. So it goes easily through side port incision. And of course, in few days, you'll get used to the resistance, which is more as compared to the routine cannula. But once you get used to it, I'm using it for last one and a half year. This is the case, posterior polar cataract. I want to do visco exchange. So easily it goes through the side port incision. It has a tapered tip there so that it doesn't damage the incision while we are inserting this cannula. This is the case which had a torn capsular rhexis. You can see here, the cannula is easily inserted through side port incision. And we could also see the flap motility sign, which has been well described by Dr. Rohit Om Prakash. So whenever we have a situation, so I'm routinely using this cannula now in all my cases. And as you see, I'm again want to do exchange. So this irrigation cannula is in the anterior chamber. So it easily goes through the side port incision. You put viscoelastic before turning off the infusion. So this is one small modification which I have done in the this viscoelastic cannula. And the next is, we all do now most of our phacoemulsification cases under topical anesthesia. And many times we have problem in hydrating the walls of the incisions, especially in deep-seated eye or when the cooperation of patient is not good. So that led me to think about how I could modify the hydro-stitch cannula. So I came up with this hydro-stitch cannula, which is a 27 gauge cannula, and it is bent 1 millimeter at the tip, and it has almost 80 to 85 degree of the angle. So whenever I have to do hydro-stitch incision at the end, it becomes very easy. So here is the cannula. So you just need to turn the bevel right or left side. And especially whenever you have a deep set eye and the incisions which are not nicely exposed, it's of great help. Look at the other case. So here you can see the superior incision. So it becomes very difficult to use the normal hydro-stitch cannula which we use. And the flow which I get from this cannula is the same as we get from the normal 27 gauge cannula. So here is one more case. You can see you just need to turn your hand right and left and turn the bevel right and left side. It becomes very fast and easy to do hydro-stitch. So I think these are just two little innovations, but they made my life very comfortable. Thank you very much, Dr. Gaurav, for giving this opportunity.
Rohit sir, your comments.
Yeah, I think it's a beautiful hydro stitch cannula. I think it makes life very easy as it appears, and since it has become commercial, it will be really very helpful to each one of us. As far as the visco dissection is concerned, when you have to do visco separation, Dr. Harshul, can we use it, or do you think with this hydro stitch, will the visco go in through it, or you need a broader one? Because at times you have to do visco separation of the subincisional epinucleus also in times when you are dealing with posterior polar cataracts. Or will you go into it and make something good for us, for that matter, Dr. Harshul?
I didn't get your question, sir. You're talking about visco cannula?
I'm mixing both the things. First is your hydro-stitch cannula is bent.
Yes.
Can we have another one wherein if we have to do, visco dissection, visco separation of the subincisional epinucleus?
Yes.
Because I make a small, a calibrated incision and nothing goes in through it. So
yes.
Can we use your hydro dissect for visco also, for subincisional?
Sir, 27 gauge cannula, it's difficult to put HPMC through that, sir.
Absolutely.
So, yes. So for that, viscoat or that kind of viscoelastic can, if they come with 27 gauge cannula. But for HPMC, you need 23 gauge at least. So if you go smaller than that, it's difficult to push that. So for visco dissection in postipolar and all those, because this is a curved cannula, this visco cannula is totally curved like this. So it has good curves. So you can go on any side and do visco dissection with that cannula, but not through side ports. Yeah.
Wonderful. I think we'll go on because now we are going to be a little bit behind time. Wonderful innovation, Harshul. I'll invite Dr. Shreyas Ramamurthy, again, the young dynamic surgeon from Coimbatore. He's going to speak on unmasking the mystery. Shreyas, are you there?
Yes, sir. I'm very much here, sir. Am I
Thanks
audible,
for joining us, Shreyas.
My pleasure, sir. Thank you so much for having me over. Is my slide visible, sir?
Absolutely. Wonderful.
Wonderful, sir. Thank you so much for having me over and for giving me this opportunity. And I thank all the organizers of this meeting as well. So mine is a couple of very, very simple cases attributing to a new problem that we are facing during this era. And so it started off with a couple of cases. We have found that it does happen more often than we had earlier noticed. So I'll just start with this quick case. A patient, 21-year-old with a fairly low to moderate myopia, completely normal corneal tomography where a smile was planned for both eyes. And the patient had a stable ocular surface, no evidence of dry eye, no MGD. The cornea was clear. And it's important in almost every femtosecond laser that we have a uniform wetting of the corneal surface prior to achieving the dock. Having a uniform tear film over the surface is very important, and that there are no interface debris when we are, as they can interfere with the femtosecond laser delivery. So, sorry. Yeah, so just quickly running you through this video. As you can see, it was a well-centered dock. It had a uniform tear film. There didn't seem any problems, and we were expecting this laser delivery to go off very smoothly. But as you can see here, this huge dark patch which had appeared out of nowhere, and a little unsure of why this had happened. And as you can see, as the laser dock continues, there are a lot of peripheral bubbles which start appearing in this region. So a lot of peripheral bubbles, as well as, I'll just quickly run the video again. So while we were expecting the dock to, while the dock was very smooth, and in the intervening period, we were not really facing any issues. While the laser delivery was happening, a lot of dark patches started appearing. Now, in hindsight, maybe I should have just stopped here and switched over to a femtolaser, because the smile allows you to convert to a femtoLASIK if your lenticule cut is not complete. But being so unsure of what was happening, the side cut had already performed and the procedure had to be aborted. As you will see in the subsequent picture, that this entire patch which had come about here was actually there in the base of the cone. And this was essentially a condensation of the, because of the mask which the patient was wearing, the breathing was causing this kind of opacification at the interface level, which was impeding the laser delivery. We then had a few more cases which had this problem. You can see in this particular case, with every inhalation and exhalation of the patient, you can see this kind of fogging which is happening and which was impeding the laser delivery. Now, this kind of fogging is now a new problem. We were not seeing this earlier, because now all our patients, even in the OT, are wearing masks, that this fogging is tending to happen and impeding the laser delivery, as you can see in this particular case. So we all know that any debris on the interface can impede laser delivery. But with this fogging, the problem is it can happen just prior to dock or sometimes even after a dock, especially in open systems. So whereas in the smile, we have a closed system, there is no gap in the cone. But in intralase and certain other femtolasers, the suction ring is not a complete ring. So even after the dock, there can actually be this interface fogging which can happen and can impede laser delivery. And some patients who might be a little nervous during the procedure can be breathing a little more heavily than they would normally, which can lead to this kind of fogging. And this initial fogging was not visible under the infrared light. So to prevent this, just maybe applying a tight micropore, ensure the mask is snugly fit, covers the entire nose and mouth properly. Or if you don't want to put this tight micropore and you feel the patient is already claustrophobic, it's better to, after draping the patient, just lower their mask altogether. yes, in this COVID era, there is a small concern about not having a mask, but then this is something which we need to keep in mind for successful delivery of the femtosecond laser. So just a quick the case where essentially to highlight that this problem can happen with any form of femtosecond laser, be it SMILE or femtoLASIK. There's this mask-related fogging, though rare, does seem to happen, and these basic steps can be used to prevent this complication from happening. Thank you so much.
Fantastic, Shreyas, and I completely agree with what you're saying. I've experienced it on the Interlace myself and on the Visumax. And on the Interlace, we've started keeping our packs outside the OT because the OT is really cold. And so when these interfaces are cold, they will get this condensation from the patient's breath. And we also now use different drapes which actually stick really well around that. And we are also we started using N95 masks for patients, compulsorily, because that doesn't allow much to escape. So I mean, I completely agree, and this is a big issue. And I think that this may be an issue even with the examiners, because we understand that we don't see it there, but probably it can influence our refractive results because they are so sensitive to everything. And on the Visumax, for that reason, we have, like, sometimes during the summers, if it becomes really hot, we switch on 2 ACs, and one of them is very close to the Visumax comes from the side where I operate. And I've seen dark patches appear within seconds if I'm not careful. So we actually switch it off the moment I start, doing the surgery. So anybody else who's, would like to chip in quickly before we move on? Thanks for bringing this out. It's a very important pearl. Yes.
Yes, sir. This is probably the only unusual problem we faced during the COVID era. So that's what I wanted to highlight.
So I think we'll quickly go on. Excellent talk. And now we have another SMILE surgeon here, Vardhaman, who's always smiling, and our young surgeon from Pune. And he's going to talk to us about something interesting, novel use of Circle software to treat SMILE complications. I think this is equally important. Vardhaman, please go ahead.
Yes. Thank you very much, Dr. Gaurav, Dr. Namrata, and the whole SAC committee for the kind invitation. And it was a pleasure listening to everybody. I'm going to talk to you very quickly about 2 novel applications of Circle software that we have seen to manage SMILE complications. We all know that SMILE has become one of our preferred way of performing laser vision correction today because of all the advantages that it brings in, especially being a flapless procedure. And it is important that we understand if we can maintain this flapless nature of the procedure, even if we actually have complications. But sometimes we have to convert this cap into a flap for managing certain complications. So I'm going to discuss with you 2 novel cases. This was a 35-year-old female patient who was referred to us when she demonstrated a gradual painless progressive diminution of vision in her right eye. Her left eye was doing pretty well, and she was corrected elsewhere for a very straightforward spherical error of -3.50. When we saw her corrected distance visual acuity was 6/36 with very significant mixed astigmatism, and in the left eye the vision was absolutely perfect. On slit lamp, you can see that there is this interface epithelial ingrowth which is seen. All these confluent epithelial cells was seen. An important thing here was that they were completely isolated. They were in the visual axis. They were completely isolated. You can see that there is no epithelial cells that you can see going towards the incision. And we also did a fluorescence staining to see if the incision was having any fistula, if there was any epithelial fistula which was there. But of course, it was a completely isolated epithelial cell nest. We also saw the same on the OCT. You can see these are the epithelial cell nests, and it has, of course, caused a significant amount of topographic disturbance. That's the reason that patient was having a poor corrected quantitative as well as qualitative visual outcome. Epithelial growth after SMILE has been reported rather uncommonly as compared to LASIK procedures. And in majority of these complications have actually shown that this ingrowth is self-limiting. Both Sukhendo et al. And Everson et al. Have shown in their large series of SMILE procedure publications in which more than 1,500 eyes were published, and only 10 out of 1,500 showed small epithelial nest near the incision, but none of them actually showed any progressions, and they did not have to intervene in any of them. When it comes to interventions, there are currently only 2 cases which were reported so far, where there was a progressive epithelial ingrowth. One of them was from Narayan Netralaya, and they had seen such a case where there was a recurrent epithelial ingrowth. They had gone through the small incision. There was an epithelial fistula that they could find out, and they went through the small incision, tried to debride it. There was a recurrence. Then they had to extend the incision, and then again debride the epithelium, use mitomycin C and alcohol. Along with that, they had to now put this time sutures. In spite of that, there was a recurrence, and on the third time they used a hydrogel occlulant sealant, and that is when the patient could be actually settled well. There was another case from France, which was also published with a progressive ingrowth. If we really see in this case, there is this location and the nature of epithelial growth here is very unique because we have a very isolated epithelial cells in the nest. And there are two ways in which this has been described to be treated. One is that we can go through the original small incision, and the second one is that we can use a YAG laser. Of course, YAG laser is out of question because it's in visual access, but going through the original epithelial incision in this case was probably unnecessary because there was no epithelial fistula, and we may induce more epithelial seeding actually if we try to go through that. So it is very important that we know that we understand the mechanism of ingrowth, whether it is epithelial progressive ingrowth through the incision or it is an implantation of epithelial cells which have possibly happened during dissection. So when we contacted the primary surgeon, he informed that the surgery was uneventful, but he had noticed some loose epithelium at the smile incision when the dissection was going on. And of course, we had also noticed no epithelial fistula. And that was the reason that we actually decided not to go through the small incision. And as Thomas Edison says, there is always a better way to do it, and we have to find it. Now, in this case, it was important that we have access to this interface, and we debride the epithelial cells, but didn't want to go through the small incision. Therefore, we decided to use the Circle software. What is a Circle software? Circle software is it's an additional donut-shaped laser pattern which can be created with the Visumax, which converts your smile cap into a flap, and this can give you access to the same interface. So this is a small video which can show you this donut pattern that has been created. You can see the epithelial ingrowth that is seen in the center. So basically now you can see I'm going through the side cuts. This is the smile cap being converted into a flap. And I'm going beyond the epithelial ingrowth now, and I'm going well beyond it towards the other end. And once I lift the flap, you're going to see the epithelial cell nest, which will be seen. So of course, it was just 3 months. So we could actually debride the epithelial cells very well. And it is equally important that you debride it from also the undersurface of the newly formed flap. We used also absolute alcohol to get rid of certain other epithelial cells which must be lying around, and then give a nice irrigation, put the flap back in its place, and the procedure was over. So at the end, as you can see, the epithelial cell nest could be treated pretty well, and the patient actually had a very good outcome, improving to now 6/9 vision. Concurrently, at the same time, we happened to have together in a conference meeting with Praveen, and he also showed that similar case has been also done by him and also by Saeed. So we put all these 3 cases together, and we have recently published it in Journal of Refractive Surgery. So this is a second case, which quickly I'm going to show. Now we all know that suction loss is one of the possible complications of smile procedure. So as you can see in this case, the patient is actually trying now on the verge of losing suction. There is a conjunctival intrusion which is seen. I'm still going ahead because this happened all in a fraction of a second. There was unstable suction which was resulted, but I still thought that I have probably gone through and I have created a small incision, nevertheless with the femtosecond laser, but that was not the case. But what we could actually understand is that the lenticule was created completely, and what was required now to be done was access to the lenticule. So of course, it was very straightforward that we could have actually used the Circle software to convert the smile cap into a flap and then peel off the lenticule. But we didn't want to do that this time. The reason was that because the lenticule was completely formed and we just wanted to have a small access to it and still give the flapless nature advantage of smile to the patient. So what we did this time is that we actually tweaked the parameters of the Circle software, in which usually the hinge of Circle software is about 90 degrees. But in this case, we actually tweaked the parameters to make the hinge of the Circle software to 270 degrees and make the side cut only 90 degrees. So this is almost mimicking a small incision. So as you can see here in this video, this is the Circle software which is being done. But as against the previous video, we have created only a small incision with Circle software this time. And now I'm going in, and actually the rest of the case is as uneventful as a normal primary smile procedure, and we could remove the lenticule in one piece very, very well, and the surgery was completely successful. As you can see, this is the first day. You can see where I have actually tried to open up the unformed small smile incision, and which was not formed, and then we created a smile incision slightly temporally to that. This is the OCD, which shows a nice interface, and the vision on the first day itself was 6x6. We had opportunity to publish this novel use of circle to create a small incision in JCRS also very recently. So these are the two novel applications of circle software that we have seen this year. Thank you again, Dr. Gaurav, for the kind invite, and to all of you. Thank you.
Excellent, Vardhaman. I'll request Dr. Praveen to comment on this. Praveen, are you there?
Yeah, I mean, like Vardhaman mentioned, I mean, this is what happens with collaboration as well. We were discussing or sort of presenting the same kind of scenario, and we realized that we sort of had the same kind of approach. And it was very nice that we could find a similar case with another smile surgeon as well. And we found that the algorithm was the same. And nice to combine experience like this and actually publish together. So really enjoyed that piece of work, and Vardhaman, thanks for driving that. And I think really good innovation about using the circle software, not just for enhancements, but also to take care of other complications. But having said that, the epithelial ingrowth is not very common with smile. Actually, it's quite rare. And that's the reason why you don't see more of these publications out there. So there are certain factors potentially during the dissection that can implant epithelium into the interface. And unlike a LASIK flap, access is difficult, like Vardhaman mentioned. So conversion to circle solves the problem. So it's not a big deal. Thank you very much.
Absolutely, Praveen. And I was impressed with that second case because I had a similar instance where there was that conjunctiva which was coming in, and I was stuck with a situation where although the dissection was complete, the side cut was not, and I had to actually use, it was like partially, it went halfway through. So had I known this, I would have probably used it, but I just used a 11 to complete the side cut a little bit, and I managed to get it. But this is definitely a better way to do it. And I did have a bad epithelial ingrowth, and you won't believe this, that it was amongst the first 3 or 4 cases we did with a pseudo smile, where they insist that you start off with that. And one of them went on to have a bad epithelial ingrowth. And I do realize that, using a 3 mm incision or so is the best way, because smaller is bad. A bigger is not great either, because it kind of gives you more room to move around. So I think a smile with that 3.5 is probably the best way. Of course, you can stay at 2.5 if you're more comfortable giving a smaller one. So I think these two things probably help. So I think we are now left with 2 talks. Namrata is going to, Namrata is already here. So I'll do this in 5 minutes, Namrata, and be ready for the last one. I'll share screen.
Surely.
If you want to go first, Namrata, you can.
It's okay. It's okay. Perfectly all right.
Because you have, your time is...
No, I have finished my surgery. So.
Okay, great. So I'll just try to show something here. Okay. Let's see. All right. So what am I doing differently this year? And Dr. Quresh was making fun of me for having title as what I'm doing differently in 2020, because by mistake it came out like that. But so I wanted to share what we used to do like a few years back, and how Dr. Rohit spoke about it, and I have been working on the same thing. We used to make our incisions, the side port incisions like this. Now you'll realize that this incision can never be of the same size between 2 patients or between 2 incisions on the same eye as well, because when we use this kind of an instrument, you are just kind of making a side port. And I stopped using this kind of a blade 20 years back because it would lead to iris prolapse for me. I was using an MVR for many years, but I never used to have MVRs which were like the standard 20 gauge MVRs, and our instruments are not calibrated to that. So I started looking at this seriously about 2 years back and started working on it. And if you notice that I first started using a smaller finer incision, so moved to a 21 gauge incision, and I started using the special chopper designed for me by Epsilon, which is a little broader here. So it tends to, like, just like Dr. Rohit showed that he calibrates his chopper, I devised this about a year or 2 back and started using this. Yet this was only an evolution in which, you can still see that in spite of my using this chopper, I'm having sufficient fluid escaping from the side port. Now we all pay attention to our main ports and we calibrate them to our phaco hand pieces and sleeves so that, it's neither too tight nor is it too loose and your fluid losses are minimized. and with newer machines which depend a lot on fluidics, and you want a stable chamber. Now it's counterintuitive to have so much fluid leaking from your side port, because it will obviously lead to surge, and it can lead to situations where your chamber may not be very, especially that now we are working on lower IOPs, so you want your chamber to be very, very stable. I operate at IOPs of like on the signature at about 30 and on the Centurion at about 40-45. So you don't want these unnecessary leaks. So what can we do? We went ahead and let's go on to this. Now, what we did was I identified these blades which Money makes, and again, no financial interest, but they make it in the 21 gauge and the 22 and the 23 gauge. And these are especially the side port blades which they make similar to MVRs, but they're different because they are shorter and they will not go and hit the entire capsule very easily, because MVRs tend to be very long. So these special side port blades, which are calibrated to my instruments now, not only my chopper, but also to my bimanual IAs, which are also customized to either 22 gauge or 23 gauge, depending on what I would like to use. And they're high flow handpieces. So even though you're working at very small calibers of incisions, but your fluid losses are minimized because the chopper and your bimanual IA systems are all calibrated to your incision, and the blades are so perfect that you don't have uncalibrated incision. And this has really changed the amount of fluid I use in the surgery, the amount of fluid losses that we have, the clearer corneas that we have, and stability of the chamber, of course, is the biggest bonus that you get. So you can see here that there's almost no fluid loss now from my side port, because my chopper, and yet there is enough room for me to maneuver the chopper, so that there is, obviously it should not be tight, otherwise you'll have overlocking. And now you can see that these are snugly fitting because these are sandblasted. Both the handpieces are customized to my incision size, and also made by Epsilon. Again, no financial interest, but they have worked very hard to give me high flow handpieces, which are both sandblasted. And I'll be showing you a next video where these sandblasted handpieces come in handy, and I enjoy the art of clearing up these cortex. So this was just to show you, and I'll go on to the next video because we are a little behind time. And so here goes, here, we can innovate more, but let me go on to the next video. Okay, so this is another thing which is close to my heart, fluidics, and how you can use fluids to, improve your surgery. So here you can see that while most of us would probably, go and polish this plaque with a sandblasted cannula or something from the side port, what I do is I use my bimanual irrigation handpieces, which are sandblasted, and as I showed you, they were customized from the main port. So what this ends up doing is when you go in from the main port and switch on the infusion is really fast. So what you're doing is you're basically going to the PC or to any plaques which are stuck anywhere and running fluid and using the sandblasted handpiece at the same time. The idea is that, it pushes away the PC, so you'll end up not causing any breaks. When you use aspiration to polish or an aspiration handpiece, you tend to catch the PC at point because you're using suction. Here you're not using suction at all. We are just using this jet hydro polish, as I like to call it, or a jet polish, where the fluid is continuously flowing. And it's important to go from the main port because only then you will set up a fast fluid flow. If you go from the side port, you have to then open up the main port with another instrument to set up that flow. So this loosens up everything, and then you can just quickly go in and, it becomes a breeze too. So I don't waste time on going and polishing plaques now anymore. I just, when I encounter any resistant cortex in the equator of the back, or sometimes you have that really sticky plaques in the equator, just go from the main port in that area and just wash them up. This is another high myope where you just have to kind of go inside and use this to polish. You can see how it polishes up, and towards the end of the surgery you'll see that it's almost completely clear from where we started. Almost like this takes only a few seconds. And another option to clean up these, some of those will not clean up or do what you want. So what you can do is you can go and kind of nibble on the PC. I call this as nibbling on the PC. You can see that with very gentle suction, I'm actually holding on to the posterior capsule with my aspiration port, because I've tried polishing it enough and it didn't come off. So it's kind of stuck there. You just kind of do a vacuum cleaning with very low suction, and you have to be careful, of course. And you can just kind of rub across it with a very, very low vacuum and clear this off. And at the end of the surgery, you'll have a very nice clean PC. But yes, do this with caution. Only if you're very confident with the control on your foot pedal can you do this, and your machine really well. And to finish this off, I'll just show you the last case. this was a vitrectomized eye with a very bad phacodonesis, only eye of the patient. He had been postponing surgery and we had planned a toric IOL if possible. But as we completed the rhexis, we realized that this was a super hard cataract, and getting it out, of course, was, and since we had to put capsular hooks, so we had to be very careful. I ended up getting a smaller rhexis than I wanted because the capsule was fibrosed. Patient was not keen of femto-assisted surgery. Otherwise, I would have probably done a femtorhexis. So frankly, managed to get the nucleus out with a lot of patience. But when I finished off with the nucleus, I realized that all was not over. And there was a bad plaque in the center, which was stuck. It was a vitrectomized eye, so these tend to happen. And the cortex was stuck very badly to the PC. I tried to go in. Now, this bag, of course, was very loose, as you can understand, because there are 3 capsular hooks there. And with all my effort, as I was trying to aspirate, it wouldn't kind of come off very easily. I struggled for about almost 2-3 minutes and realized that I'd only cleaned up almost 20-30 degrees of the capsular bag itself. So I decided to use what I was just showing you before, going in from the main port and doing a jet polish from the main port, and just see how it works for me. Now I've gone in and I'm loosening it up. So see, the fluid flow is built up through the main port. I'm just going there, and you can kind of, bravely go and polish it the way you want. It never breaks the PC. As long as you don't poke through it, you can just kind of go and use this high flow fluidics of the handpiece through the main port and polish them to your heart's content. It really loosens up everything. Now I'm going on from the other side. So you can see I'm now putting fluid from the side port, but I'm opening the main port with my other instrument so that the fluid flow is still built up. So otherwise, if I don't open the main port, the fluid will not flow. And then you can, once you've done all this, you can see it's so loose that now it'll come off very easily. It's very easy to go to even the equator of the bag and remove them. And then once you've done that, now leaves the task of removing peeling this, and you have to be very, very patient. You have to create a plane. And once you have the plane, you can gently peel them. And these vitrectomized eyes, the capsule are not nice. So sometimes it's very tough, but patience pays, I think. And so I've been enjoying peeling these plaques as well nowadays. Sometimes a little dicey, but you can see that you can kind of re-grip and grip and re-grip, and then you can get it out. So I think I'll pass on to Namrata now. I'm done with my presentation. It gives you a good result in the end. So there goes. All yours, Namrata.
So thank you, Gaurav, and I'm going to be just sharing my screen on what am I doing differently this year. So what I am doing differently this year is, actually I had been using the intraopacity microscope, but now I am doing it on a 3D RTView microscope. The capsular rhexis can also be visualized, although it really doesn't make a difference if you do it in a clear cornea, but it makes a difference when you do it in a hazy cornea. And if you do lose the edge of the rhexis there, then you can actually find it out from underneath the hazy cornea. Dissection, and this was again a normal cataract, so it doesn't make too much of a difference, but would make a difference in cases of posterior subcapsular cataract or in cases of posterior polar cataract. Then of course the crater depth, especially when the nuclear when it's a dense cataract, and especially for novice surgeons who wouldn't know at what level they have made a crater depth, it helps you to know at what level the crater depth is there. And then look at the PC, the way it comes up, and as you put the viscoelastic down, it just goes down. And then you have a cortical plate, and the posterior capsular bulge again can be seen here, which is going at the back. And you can see the PC here, and off late we've started measuring the distance between the IOL and the PC, and we've also published the same with different type of IOLs and different designs of IOLs, plate, haptic, 3-piece, etc. It is different. The distance between the PC and the posterior part of the intraocular lens. Then when you actually, this is the distance that we measure, the IOL capsular gap after the IOL insertion. And once you evacuate the viscoelastic out, this gap would further decrease. And notice that this has decreased because the viscoelastic is out. And I think this may make a difference in the effective lens position, which we all don't actually see. but which will help to modify our IOL formulas better. And then when you actually hydrate the wounds, you can see the spindle over here, and there may be small DMDs which may be present at the wound site, which also can be appreciated with otherwise are not seen. And this is the wound hydration which is being done. So the internal lip, whether it is closing or not, or external lip, whether it is open or not, can also be visualized. Then subsequently, small DMDs, for instance, if there are small DMDs which are present just here at the edge, and then you see that there is a small DMD which is present at the wound site here, port side DMD, and these can also be managed by putting the air bubble at the end of the surgery. Then in different situations, it helps differently. For instance, this is a posterior subcapsular cataract, and there's a clear distance present between the PC and the overlying cataract. And then you know that this is not going to rip open. This is, of course, very clear, but sometimes there can be a confusion. Now, this looked like a posterior polar cataract, but as you do irrigation aspiration, you realize that it is not. Now, this is a white cataract which has clefts, these dark areas which have clefts. And so if you do a nick in the capsular rexus, you would know that this is, the fluid is not going to leak out from here. And you can do your rexus as you would do in normal situations, because there are dark areas which are present in between. But if there are no dark areas which are present in a case of a white cataract, then you can know that the fluid is going to come out. So this, of course, was not a problem, but this is just a bang on kind of a thing with no clefts present at all. And just as you give a nick, it's a completely liquefied cortex. As you give a nick, this fluid will come out. So when you see that kind of a picture, then you can expect that the fluid is going to come out, and you have to be prepared for that. Now, this is a case of capsular distension syndrome, and there is a IOL and the PC, and it's a phimotic ring which is there. So this ring, phimotic ring, was excised with the help of the ILM peeling forceps and the scissors. And notice now that the IOL is sitting bang on onto the PC, and there is no gap present between the two. And then you know that the position is now correct. The phimotic ring has been relieved, and the patient is relieved of the myopia as well, which the patient was having in this case. So it helps you to assess the lenticular capsular gap even after the surgery. And of course, this is the hydration of the wound. Then this is the paper that I was talking about, where we have evaluated the distance between the PC and the IOL, and all the events related to the posterior subcapsular cataract also can be seen. Now, in this case, this was a hazy cornea. Pupil hook, nylon hooks have been used. And if you lose the edge of the rexus here on a black and a white cornea, which has been tattooed, then you can actually see on the intraop OCT microscope where your lost edge of the rexus is, and can pick it up and can complete the case. And likewise, even for phacoemulsification, or if there are any nuclear fragments which are being camouflaged underneath the haze. And of course, this is the intraocular lens implantation and the pupil enlargement, which is being done for the patient to see post-operatively. Now, this is what I was talking about. This looked like a posterior polar cataract, but as you, there is no gap actually present between the PC and the this thing, but it is a little dicey here. But notice this is kind of a thing, because the PC is actually intact, and you can see that the cortical fibers are present just above it. But if you look at this case, there is a clear-cut deficiency which is present here, and then you know that this is going to open up. So intraop OCT helps you to gauge these finer kind of things which sometimes you have to guess. And this is again a pediatric cataract in which pediatric cataract in which actually the sorry, this is not moving. So this is just to show that even this is not moving, but when you do posterior capsular rexus and you do anterior capsular rexus, and there is a defect which is present, then you can see it on the intraop OCT microscope. And this is the anterior vitrectomy which is being done. And subsequently, when you do put a 3-piece IOL, you can also see this is the gap of the PC and the AC both after the double rhexis has been done for anterior and posterior capsular rhexis. And here it is showing an intact PC because it's focusing on that area. And once you put the IOL there, you can actually capture it. And once you capture the IOL, the whole anterior capsule and the posterior capsule IOL, and of course that can also be made out with the help of the spindle. Then this is a case of a cataract post PK post DSEC, and the capsular rhexis is being done here. Notice that the graft is not moving at all here. So throughout the surgery, when you do, the graft is not moving at all, and it helps you to know whether the graft is moving or not. And just as you hydrate the wound, in the end, notice that the graft begins to move. So when this gap occurs, and otherwise, if you didn't have the IOCT microscope, you probably would not have been able to appreciate this. So this tool has really changed the way we do surgeries now. And of course, this is a case in which cataract surgery was done after DALC, and the cornea has become hazy. So even after you put the air bubble there, the gap is still there, and the Descemet's is not getting attached to the overlying stromal layers. So you have to give a stab incisions anteriorly, and when you give a stab incisions anteriorly, and then put the air bubble there, then you can see that the Descemet's is now pretty much attached. Something again which may not be appreciated by the operating microscope alone. And this is in fact being done on RTView system, the 3D system, and the resolution of the intraop OCT is far better in that system as compared to the previous generations. This is just to show the capsular rhexis flap, the fluid wave, and this is the MyLoop, and it again helps because when you're using the MyLoop and you introduce it, you actually can make out where it is going, because it has to be just above the posterior capsule and beneath the cortical layers. So once you open it, you can actually see that it is negotiating into the area between the PC and the nucleus there, or the cortical remnants there. And again, this aids in this. And here, of course, the nucleus is broken into 2 pieces. And subsequently the phacoemulsification was done. Now, incidental finding in this case was also the ligament that you see. This you can see the lens and the gap between the lens and the PC, which I was talking about, and then of course the hydration of the wound. And notice that this is opposing, but in the center it is not opposing, and this can also be seen here. So that has to be addressed. And incidentally, we also saw the ligament which is present posteriorly. There was Weger's ligament which can be seen incidentally on the IOCT also. So it helps to see the unseen, and this is now what we are doing with. So thank you very much for your kind attention.
Amazing, Namrata. So many applications. Praveen, any thoughts? And Dr. Rohit sir has recently acquired the same thing, so maybe both of you can.
Only that's all.
I think we're just trying to explore what Dr. Namrata has said, and it sounds very exciting. We just got it, and it's in the period of installation now. It's been working on it for the last 7 days. But I tell you, as it appears, things are going to be very different.
So I think, Namrata, that was really fascinating. It was like I was looking at it and thinking of the possibilities. So I think amazing stuff. And with that, I think we've kind of overshot our time by 2-3 minutes. But thank you so much for organizing this fantastic session, Dr. Namrata. And Praveen, thank you so much for spearheading it. And Dr. Rohit sir. And all the speakers who were all so amazing. And final words from our chairpersons and Namrata.
Thank you so much, Gaurav, for doing it at such a short notice and for doing it so well and so differently, like always. And I would like to thank all the speakers here for this great show. And we have, as of now, about 680 people live on YouTube, Facebook, and Zoom channel. And most of them are from Bangladesh, Sri Lanka, Pakistan, and Nepal. And of course, from India also there are there, but most of the people who are watching us are from these countries. So thanks a lot. Thank you everyone for your time and for your contributions. Thank you so much.
Thank you.
Thank you, Gaurav.
Absolutely perfectly managed. नहीं, thank you आपका कि आपने जैसे yeah, yeah.
What is
Hi, Dr. Murthy. You're muted. You're muted. You're muted. Hi.
Hi. No, I'm just getting the background corrected. So
Yeah, do it. What's your talk on, or are you a panelist?
I'm a panelist.
Don't crush me. I'm speaking from the heart. Okay. I'll be speaking from the heart.
Yeah, no problem. Don't worry. I think my job is a lot simpler. I don't have to do much.
No, as a panelist, you have much more actually. You have to listen to each talk first of all. Otherwise, you can tune out if you're a speaker.
Well, it's okay.
How's things? How's Bangalore?
Yeah, Bangalore is nice, cool. Fortunately, rains have stopped, so I think it's better.
And the work is busy?
Yeah, it's now back to fairly.
Back to almost normal, yeah.
Almost normal.
And in fact, we are seeing much worse cases now because they were not getting treated these 2 years. No laser done. I mean, I initially there was a rush of such bad RDs.
That's
PVR
true.
RDs.
We used to see all of them with PVR. Now it's settled now. Now we are back to.
It's coming back to a little bit.
Yeah,
The PDRs, which we had advised lasers and didn't come back to complete the lasers, and then now they were coming with bad RDs.
So I think, yeah, more or less everyone is now getting into.
Yeah.
Sure, that's good.
I'll join in 5 minutes, okay?
You will join back, huh? Okay.
Yeah.
Hi, Dr. Murthy.
Hi.
How are you doing?
You're not seen. So I think you have to change your background. I think you have to.
I'll pull my curtains. Give me a second. Let me do that.
Yeah.
Bit better, I think.
Yeah, I think, let me see. Slightly better, but I think you are sitting against a bright background.
Yeah, the sun in Bombay is very hot right now. Let me see. As long as you see my slides, you don't need to see me.
Your slides will do your talking.
Exactly. What do we have to do?
Okay.
You can see that, right?
Yeah, that's fine. That's all fine.
Perfect. So that's good. So as long as that's good.
Yeah, you don't need to worry about this. Yeah.
How are you?
All good.
Fantastic. Good. We've got about 5 minutes, I think, to start.
Yeah.
How are things in Bangalore now?
It's good. All quiet and nice as of now.
Good. No,
I think
let's hope it stays that way.
Storm. I don't know whether it's the lull before the storm.
It seems that way, doesn't it?
Yeah.
All over the world, things are getting bad.
Yeah.
Scary.
So let's see. Hope for the best. That's all.
Yeah. No. Last time it was a bit difficult. Last time, but March, April was a tough time.
It was tough for everyone, I think.
Yeah. No matter who you are, there were no beds, no oxygen, no this, no that. It was just tough.
And you realize the value of life.
You realize the value of health. Absolutely. Everything else kind of comes secondary.
So.
And I think last year everyone had remdesivir and tocilizumab. This year I think everyone's got the Roche antibody cocktail in their mind. Ki chalo, ye hoga to theek ho jayenge. But let's hope that it kind of pans out that way and the government is stocked up enough.
That's true. I think there is some.
I think one of the panelists.
I think they have done it. I think. Yeah.
We've got 3 minutes to go. We are also just waiting for Dr. Lalit Verma.
Yeah.
She's the chairperson and the moderator.
Correct.
If any one of you could be kind enough to give him a call so that we could get started on time. Otherwise, we'll have to wait. And
I don't know whether he lifts any phone call. I will try.
as it's rightly said, we shall try and do our part and let.
Yeah, just a second. Let me.
Sure.
Yeah, he's in, I think. Yeah.
Hi, Hemant.
Hi.
Yes,
I was about
there
to
he
call
is.
you. I remind you, you're the boss.
No, we still have 3-4 minutes. You see, I thought थोड़ा sunshine में बैठ गया था मैं जाके.
Oh, Delhi. That weather.
After a long time, we had some sunshine.
Okay.
So,
good.
So I was aware of this. Hi, Nishant.
Hi, how are you? What is the background today? I can't see you. Wait, let me see. You had got palm trees in the background?
Yeah,
He's in Goa. He's in Goa, yeah.
What Goa?
That is perpetually in
He's
Goa.
in the Maldives. कहाँ Goa भेज के इनको downgrade कर दिया आपने?
आजकल इंटरनेशनल ट्रैवल में प्रॉब्लम है ना, तो गोवा चले गए हैं.
अरे प्रेसिडेंट AIOS को थोड़ी कोई रेस्ट्रिक्शन है. प्रेसिडेंट इंडिया, प्रेसिडेंट AIOS.
Nishan, ये feel good factor होना चाहिए लाइफ में. बाकी कुछ भी ना हो. Everything is virtual. ये भी virtual ही है.
And everything is, the point is that, the reality may be whatever, but the impression should be something else,
Yeah.
So.
That's a big statement, Dr. Nishan.
Hi, Dr.
Hi, Darius. How are you doing?
Hi, Darius.
Darius को यार party नहीं करी. Darius उन्होंने कोई party नहीं करी यार.
Darius and me are the only ones who got a boring background. भाई घर पे बैठे हैं. Darius तो फिर भी office में बैठा है.
Darius phone कर देता है. When can I talk to you? When can I फिर उसके बाद phone करता हूँ.
So party.
Thank you so much. Virtual party, sir.
Virtual party कर देते हैं. Hi, Malika. Debulal, how are you?
Fine, sir. Good afternoon, sir.
Hi, everyone. Good morning, sir.
Morning.
Good.
Yeah. Now we can see you.
Okay.
Just a reminder, sir, we are about to get started.
Okay.
Yes, Nikhil.
So we are going live in 5, 4, 3. To get started with this session, can I request the chairperson and the moderator, Dr. Lalit Verma, to please introduce everyone and also let us know the objective of this meeting.
Good afternoon, everybody. I will not waste time in introducing everybody because all of them are so dear colleagues and the entire country knows each one of them. So we will just get going because I think there are two important diseases we have to cover. You see, DME and AMD. Every webinar, virtually every day, we are discussing about these things. And still, I think we are not fed up of discussing. So I think, you see, sometimes there will come a time that, अच्छा भी हो गया यार, काफी DME, AMD हो गया. But the reason I think this session assumes importance, 45 minutes each devoted first to DME and then to AMD, is after having clinical talk, then we have some real world experience and then panel discussion. Aim would be, you see, how to incorporate the knowledge gained on aflibercept. Because aflibercept, in contrast to others, the presumption or the this thing is that it has a prolonged action also. And how can we incorporate the data which RCTs tell us into our real world scenario to the best, use for our patients? And also consider the durability of this. You see, durability means how many patients we can, Q12 dosing or Q16 dosing in this. Also, in AMD session, which will be in the next part, is how can we individualize treatment extent? Because apart from monthly dosing, I think the next best treatment regimen is treatment extent. Because it is proactive. It's not reactive. Reactive means then when fluid comes, then you treat. Proactive means with or this thing you before the fluid comes, because there has been a couple of studies, I think all of you would agree, that if the fluid is allowed to come and then you start treating, which is something like PRN kind of treatment, then the things are not the same as we would like it to be. So treat and extend, even if you see the surveys, ASR survey or VRSA survey, or so many surveys have been done world over, majority means more than 60-70% people after initial, treatment by loading dose and all, shift to treat and extend regimen in ARMD, and so as to have near similar results as the randomized clinical trials. So without wasting much time, because we have to give adequate time to all our speakers and panel discussion, but at the end of it, 90 minutes, we have 1 or 2 take-home messages, both for DME, and 1 or 2 take-home messages, both for AMD also. So without much ado, we'll request first Dr. Nishant Kumar, who will tell us about management of DME insights from DRCR net protocols. Over to you, Nishant.
Thank you so much, and a very warm welcome to everyone who's joining us from all over the world. Actually, it's a great privilege for all of us to be here together, and God willing, next year in person. So I'm going to try and take you through some insights into the current clinical trials, and also give you some new insights on data that isn't really readily available in the public domain about where Eylea fits in diabetic macular edema, and some financial disclosures. I do get research and travel grants from almost everyone. Why should you care about it? If you're attending this meeting as a general ophthalmologist or as a retinal specialist, just remember that 8 to 9% of the population has diabetes, especially in the countries that we belong to and we're talking to today. And out of that 9%, 35% of them will have kind of, some sort of diabetic macular edema, and 7% of them will have DME. And out of that 7% of DME, 40% of them would have already lost some vision because of their disease, which is DME. So it's an important disease to know. Off the bat, you get off that if you don't control the systemic control, which is glucose, blood pressure, blood sugar, and lipids, you're not going to get anywhere. Anti-VEGF, we're going to break straight into them. We know there's a plethora of them available. The big ones available on the market is, of course, ranibizumab, aflibercept, bevacizumab, biosimilars, and there are lots and lots of them, and more of them coming in, and brolucizumab, but not yet approved for DME. So we'll concentrate on the ones that we've got available to us. No matter which study you look at, for the first time, we were seeing a vast improvement in vision with treatment of DME with anti-VEGF treatments, no matter which drug you looked at, no matter which study you looked at. And this was the first time that paradigm changed to improvement of vision compared to the percentage losing vision, which used to be our old paradigm. If you looked at the older laser for DME studies, you notice that in a 3-year period, 12% of people yet lost vision, 15 letters or more, which is quite significant. With the anti-VEGF, that drops down to less than 1.2%. So there's a significant drop in the number of people losing vision and significant gain in the number of people gaining vision. And that's what we want to see. But when you've got so many options and you've got to choose, and there is a difference. There's a difference in mechanism of action, in efficacy, safety, cost. So just to go through the big boys that we have, ranibizumab, bevacizumab, aflibercept. As you all know, aflibercept has the added advantage. It works against all forms of VEGF-A, VEGF-B, as well as placental growth factor, which the others do not. Now, when you start comparing drugs, the best thing is to go back to the laboratory. And in the laboratory, aflibercept is about 71 times more potent than ranibizumab in working on the VEGF receptor 1, and almost 100 times more potent than bevacizumab. So at least in a laboratory, it definitely shows some signs of superiority, which we hope would convert into clinical practice. But when you want to compare something, the best thing to do is randomized double-blind clinical trial, which we're very grateful DRCR network did for us in the protocol T. What they did is they compared 2 milligrams Eylea versus 1.25 bevacizumab versus 0.3 ranibizumab. Why 0.3? Because 0.3 was what is available in the US and approved for DME. And the RIDE and RISE showed that there was an efficacy similarity between both the doses. Just remember, 0.3 was never available anywhere else in the world apart from the US. It's important to understand this because it was a PRN regime. So basically, people got seen every month, and based on certain criteria, they got an injection. Obviously, if they were continuing to improve or they were worsening, they got injected. If there was no improvement over 2 consecutive visits and their vision was normal, which means 6/6 vision, then their treatment could be deferred. But if there was no improvement after kind of 2 injections and the stable vision was stable, if it was less than 24 months, then 24 weeks, I beg your pardon, then they got injected. Beyond 24 weeks, the treatment could be deferred. So if you got to normal with 2 consecutive visits, your treatment could be deferred. But if you didn't get to 6.6, then before 6 months, you continue to get injections. What this basically means is that almost all people invariably ended up getting 5 to 6 monthly loading doses. And that's why pathology for Eylea in Europe is 5 monthly injections and then Q8. That's where this comes from. Let's start off with the results. What do you want from your patients? You want that they start improving very quickly, they continue to improve, and that improvement is sustained. The good news is no matter which drug you use, you do get an improvement, but the orange line is Eylea, and you see that slope of improvement is sharper. It kind of stabilizes at a higher level, and it stays there at a higher level over a year's period. And that was kind of, significantly different than the other 2 drugs. The group that we are most interested in, especially in our kind of country where people have got worse vision when they present to us because they're dilly-dallying, their second opinions, third opinions, cost factors, is people with less than 6/12 vision. In this group, Eylea tended to do much, much better. And this was statistically significant as well when you compared both the treatment groups. What happens on a longer time period? Again, Eylea, all the 3 drugs do quite well. Over a 2-year period, the vision improvement is sustained. That visual difference between ranibizumab and Eylea is not maintained. There's no statistical difference, but you can see they both do very well. And in those people with 6/12 or worse vision, again, you see that there is some improvement and ranibizumab seems to be catching up. And that statistical significance we saw is not maintained. One thing to note is that this is not the best way to look at vision. When you look at vision data at a time point, there are a lot of statistical methods analyzed to get this data. So the last data carried forward, imputation of data. So what happens if one patient has gained or lost vision on one visit because of endophthalmitis or an infection or developed cataract, then that will skew all your results. So a better way to look at data today is area under the curve. Almost all studies are looking at this because what this is looking at is as vision over the whole time period rather than a point of period. And this is what all now studies, whether it's CAT, IVAN, FAME, all of them are looking at area under the curve because it tells you what's happening over the whole 2-year period rather than just a point. And what you notice is Eylea tends to do much better compared to the other 2, 17 letters versus about 13 letters, which is almost 1 Snellen line, which we'll see, and that is very statistically significant. So if you look at Eylea from an area under the curve perspective, you notice that the vision improvement is significantly better as compared to the other 2 drugs available to us. CFT anatomical results are also better with Eylea, and that's statistically significant both at 1 and 2 years as well. Another thing I wanted to highlight to you is the non-responders. If you look at this graph, this is not from the Eylea group, this is from RESTORE study, which is ranibizumab. If you're given 2 injections, instead of getting better, the patients actually got worse. At this time, most of us would start thinking, what should I do? Should I swap treatment? Should I move treatments? But that's in RESTORE, that wasn't an option. You had to continue giving them injections because they were continuing to deteriorate. And lo and behold, what happens is that at 1 year, you notice that if you just keep giving them an anti-VEGF, their vision improves to plus 8.8 letters. At 3 years, that improvement is plus 11 letters. So what you could have done is at that dotted line, that 3-month visit after 2 injections or 3 injections, you said, well, let's swap around. If you do that, you might be doing a disservice to people. Some people are late bloomers, but at the end of the day, the same cohort tends to do very, very well. If you look at the VIVID and VISTA trials, which are Eylea-based trials for diabetic macular edema, if you look at the proportion of people who keep getting better after every injection, so after baseline injection, 60% of people got kind of, 5-letter improvement. After the 4-week injection, another 20% people got 5 letters or more. After the 8-week injection, another 16%. So if you notice that even after the 5th injection, about 15% of people are continuing to improve by 1 Snellen line. So don't stop treating these people aggressively. That's why that posology of 5 loading doses comes into the picture, because a lot of proportion of people continue to improve with a monthly injection. So continue with that, be aggressive unless you've reached 6/6 vision. If you look at kind of the DRCR network and you look at the aflibercept group, what you realize is that there are effectively 3 groups of where your patients will fall into it. If you look at the dark blue line, the first line, they start off very well, they keep improving, and they keep that improvement over a 2-year period. They get about 20 letters, which is 4 Snellen lines. They're your A+ student. That's the student everyone loves to have in class. That's the patient who loves you and you love them back. The light blue line, they start off quite well. The slope is not so high, but they don't do as well. They're kind of the A student because they've yet got 2 Snellen lines, 10 letters, and they maintain that. And that's quite good as well. And then you got the third lot, which is the student that I used to fall into when I was in school. We're late responders, we're slow bloomers, never doing A+ in class, all your unit tests, after the first 2-3 injections, you're stuck at the baseline. And at that stage, people start thinking, oh, should I swap? But in DRCR network, you couldn't swap. So you continued with Eylea injections, and look what happens, that over a year's period, you've improved by 1 Snellen line, and that improvement is continued. So you can divide your patient into 3 real groups: the A+ student who does wonderfully well from the first injection onwards, the A student who does well, but maintains 2 Snellen lines, and the student who's a late bloomer who doesn't really kick off the blocks, but does catch up quite well if you continue with the treatment. So don't be in a hurry to swap around treatments or try another drug just yet. The other thing I want to talk to you about is the disease modifying effects. There's new data from VISTA and DRCR network. In VISTA, what they did is they subdivided the angiogram. They all had a baseline angiogram into 4 components: anything nasal to the disc, anything temporal to the disc, anything above the superior arcade, anything below the superior arcade. So nasal, temporal, superior, inferior. The temporal includes the macula, though this is not particularly of the FAZ. It looks at the whole temporal macula area. And it was binary. It was, is there non-perfusion, yes or no? And if you look at the proportion of people whose non-perfusion improved with Eylea treatment, you see it's quite incredible. So these are all the people who at least had 1 quadrant of non-perfusion. And if you look at the proportion of them who improved perfusion in that 1 quadrant at least, at 1 year, at least 30% of them had improved. And by 2 years, about 44% of people had improved at least 1 quadrant of non-perfusion. That means there was some evidence of non-perfusion, and that was completely perfused with treatment with Eylea, which is the first time we're seeing this kind of dramatic effect. If you look at non-perfusion of the macular area, now remember, this is not FAZ, this is the whole temporal kind of area to the disc, which includes the macula and the foveolae vascular zone. If you looked at people who did have some amount of non-perfusion in this area, with Eylea treatment at 1 year, 30% of them had completely reversed that non-perfusion. And at 2 years, 50% of them had completely reversed that non-perfusion, which is something that we've not seen with other medications. It's something that seems to be quite unique to Eylea. Let's look at what is the effect of the non-perfusion on vision. So if there was non-perfusion noticed at baseline in the temporal area, which includes the macula, compared to if there wasn't, you yet get quite an improvement in vision. So if there was no non-perfusion noticed, or if there was non-perfusion noticed, the vision improvements are yet quite dramatic. And actually, if you noticed, if there was non-perfusion, which is the first graph on your side, you notice the vision improves by about 13 letters, which is quite incredible. If you look at people who reperfuse, so if there was macular non-perfusion or temporal retinal non-perfusion, if there's complete perfusion, the vision improves quite dramatically by about 17 letters. But even if the perfusion did not completely reperfuse, you yet get about 15 letters improvement. So the improvement is really independent of how much reperfusion happens, but it's incredible to know that 50% of people do get almost complete perfusion in the retina with Eylea treatment. If you look at eyes with PDR and DME, which is again something we looked at year 1 and year 2, significantly better kind of results with the DRSS scoring system with Eylea as compared to the other 2. If you look at a meta-analysis of the data, because there have been so many trials, and luckily when you have a Cochrane meta-analysis, it really drills home the point that if you use Eylea compared to any other kind of drug or laser, the chance of you improving vision by 3 lines or more is much higher when using aflibercept. So if you thought laser had a 10% chance, with Eylea, that's 36%. With bevacizumab and ranibizumab, it's about 27%. So the chance of you improving vision is much higher with Eylea than it is compared to Avastin or with ranibizumab. If you looked at the vision improvement at 1 year, it's 10 letters with Eylea compared to 6 letters with either ranibizumab or bevacizumab. So not only do you get a much higher chance of improving, but your quantum of improvement, the number of letters or the number of lines and Snellens is also a lot more. So where does Eylea fit in? Well, I think multiple studies, both in the laboratory as well as kind of clinical studies, have shown it's a potent drug and where the results are a lot better. I think that role of placental growth factor in modifying disease, which is reperfusion and the proliferative diabetic retinopathy, is something we're learning more and more about. And it's something that seems to be unique to this drug, but it's wonderful to see because you want to have a disease modifying effect when you're treating diabetic macular edema. There's great clinical evidence as well as statistical evidence that it may have an edge over the other drugs that are available to us. So as long as the price is kind of, comparable, I think this is a drug which is now becoming the first line treatment for most of us because of the evidence base that there is, and there's great real world evidence, which of course Dr. Goyal is going to share some of it with us as well, which shows you that even in real world, we are getting these kind of results. The impact is happening on perfusion and on the diabetic retinopathy status is something wonderful to have, because we all know that diabetes is just not macular edema, it's the whole diabetic retinopathy spectrum. And if we can affect reperfusion, that's going to be a wonderful thing to have. And of course, Dr. Goyal will talk to us about the real world evidence. When you have so much data, it's always wonderful when somebody looked at things objectively with a meta-analysis by Cochrane that just puts the last screw on the kind of wall. You can hang your hat on this, that if there's a meta-analysis, that too by Cochrane, you're quite comfortable that the data is very, very robust. Just leave you that we started a charitable movement called IBTs, because when your eyes have diabetes, you have IBTs. And diabetes blinds, as you all know that. So we're trying to popularize this term so that diabetes and eyes comes into the common awareness of people. And, we've got 3 Guinness World Records for the charitable work we've been doing. Thank you very much. I think we finished on time, so that'll give us a lot of time for discussion and for the other talk. So very grateful for your time and your patient listening.
Thank you, Nishant, for rubbing this point. I think all of us were enthused once this protocol T came up, actually. So protocol T, I think without any ambiguity, I must say without any ambiguity, established an edge of the Eylea over the other 2 drugs. You see, although ranibizumab catches up by 2 years, but I don't think so in real world scenario, anybody, you see, if I'm the patient, we will wait for 2 years. Okay, this graph will narrow down. The other highlight, I think, which I gained was about the perfusion, because you see, yesterday, I think there was a webinar where we were talking about in fact, I think Dinesh or somebody was speaking about the perfusion of status. In fact, it was said that although the DRSS improves, but the perfusion does not with other drugs. And hence, these eyes are still prone for PDR. I think it was protocol S that was being discussed.
Absolutely.
Yeah,
absolutely.
So here is the beauty of this drug, that what you showed in 3-4 slides, that not only the temporal perfusion or the macular perfusion in around, say, 30% or so, that does improve. That, at 1 year or so, which is a very, very significant factor. Because I don't know whether it's the effect of PIGF or some other unique mechanism, but here is the drug which not only improves visual acuity, area under curve, or OCT and DRSS, but the perfusion. That is one factor. I hope that this improvement in perfusion is a long-lasting thing. It's not just for a year or so. So that is, I think. So I actually do not think that there, as of today, if you do a recent survey again about choice of number 1 drug, majority, because I'm aware of one VRSE survey done a couple of months back or a year back, which got published in Indian Journal of Ophthalmology. So the choice was different. As of now, the more this knowledge is percolated into the masses, that here is the superiority in 5 terms which you last summarized: that visual acuity, area under curve, OCT, perfusion, and as well as the DRSS. So there is, honestly speaking, for me, there's hardly any choice, provided the cost considerations can be taken care of, because Indian market or anywhere on the earth, actually cost is a major issue. Why India? Because majority of our patients are paying patients. Insurance penetration is not very high. And you see in UK, as you were saying, 5 monthly injection is the norm. Here, honestly speaking, a lot of our patients may not. Okay. And since the time the Eylea for You scheme has come by Bayer, and this has become very popular. In fact, our data, Ritesh is here from Center for Sight. You see, since this scheme came, you see, Eylea was like this before, honestly.
Correct.
And since the scheme came, Eylea has jumped like this, and the other anti-VEGFs have taken a backseat. Primarily, all of us feel not only by the data, but also the real world scenario, that it definitely is a superior drug. But believe me, it still has to penetrate into the gray matter of everybody and the masses at large. So I think we will hear Dr. Mallika Goyal's real world experience, and then we will have some more discussion after that. We have a great panel, 7-8 people are there. We will have their views also after this talk by Mallika. Yes, Mallika.
Thank you very much, sir. So I'll be sharing my personal experiences after the excellent presentation by Dr. Nishan. See, first I would like to clarify that I have no commercial intent. Patient and only patient is at the center of anything we present and discuss. So when ranibizumab was the only safe drug available, it was working wonders. It is only that as our experience with aflibercept increased in resistant cases, then we realized that there was a host of benefits that came along: the strength of response, the speed, and the longevity of response. These three things. And this led to reduced treatment burden, patients' visits, costs of investigation and injection, and most importantly, risk, because each injection has a risk of complications. So gradually it became the drug of first choice in all these indications. And this is how this evolved. And naturally, the ILEA for You program has made all this very easy. So initially, I will share my experience with resistant cases where because of the cost factor, we used to use it as a treatment of last resort. This was an elderly person, one-eyed patient with the DME. So we started with, he had already been treated with ranibizumab elsewhere, no response. So we started with IVTA. Initially, he was having some response, as you see. So we maintained him for 1.5 years on 3 monthly IVTAs with reasonable response. But then he started becoming resistant and we had to inject every month. And despite that, there was no response. Every month for 10 months. You see, there is no response even after the injections. So now he agreed to shift to dexamethasone implant. Money was a factor. So he did agree now. And we tried twice, but even at 2 weeks, the patient came back with significant edema and not happy. So after 2 injections and no response, he agreed to aflibercept. So by now we had wasted almost 1.5 years with a very thick macula. And as soon as we gave aflibercept, you can see that the vision improved immediately, and we saw anatomic response which we hadn't seen in 2 years. At 3-month intervals, we injected, and then the next recurrence happened only at 5 months, and then at 4 months, and then again at 5 months. So you see the excellent response we are getting and an excellent visual acuity compared to what we started with. So there was non-response for a long time, and probably if we had switched instead of Dex implant or even IVTA, if we had switched earlier, there would have been a final better visual acuity. And treatment interval can be long with aflibercept, or 4 to 5 months in this case. We injected 5 times in 2 years, and the response was far superior to Dex implant in duration and effect. And it has become, for this reason, the drug of first choice for any case of DME for me, including pseudophakic patients. Now, this was an elderly gentleman who, 4-5 years back, again, we started with IVTA, moderate response. He was not coming back for treatment. Took again at 5 months after first IVTA, and then again at 6 months only. And then he was lost for 4 years. And now at this time, with my experience, I insisted on aflibercept. And there was an immediate visual response. He was very happy. He refused to take a second one when he should have. And he came only at 7 months after the first injection, agreed to take. And you see there is a remarkable visual improvement and also anatomic response, but by now there has been collection of hard exudates. So intermittent treatment leads to ultimately poor visual and anatomic prognosis. We started with 612N6 in 2016, ended up with 624N12, even though the macula is flat. So we should have switched early. If a certain agent, which was IVTA, was not effective, switch early for better response, better outcome. This was another gentleman who we tried, again for cost reasons, we tried first ranibizumab, then IVTA, but vision was deteriorating from 612N12 to 660N24. So at this point, we tried Dex implant and finally agreed to aflibercept. And you can see that with the immediately after aflibercept, the vision improved to 612N12. And we thought now we can maintain this vision with IVTA. So For almost 2 years, we then injected him only IVTA, but he had lost significant vision by June 2019. So at this time, he again agreed for aflibercept, and within 2 injections, he was back to 6, 9, and 6. So now he was willing to continue only with aflibercept every 2 months with reasonably good vision. After 1.5 years of this continuous aflibercept, we decided to try a combination therapy, which led to some anatomic improvement, if you see, but not much objective visual improvement. So now he's back to 2 monthly aflibercept only with reasonably good vision, as you see, 6, 18, and 8, with which he is satisfied. Definitely, post-combination therapy, the average thickness of the macula has reduced, but it hasn't translated into significant visual benefit. So here you see some cases will not have complete resolution. Even after 5 years, he continues to require treatment. And the DEX implant and aflibercept individually may give similar anatomical results, though even in anatomical result, I find that aflibercept gives a better response. And even with equal anatomic result, the functional response or the visual response is much better with aflibercept. And the patient says, no, I would like to continue with that drug rather than the other drug. So most of my patients have then switched from dexamethasone finally to aflibercept with longer treatment intervals, even a year or longer, and better visual results. Possibly combination of dex implant and aflibercept may improve the result. Early intervention may translate into visual benefits as well. This is another person who needs very good near visual acuity. He had been treated with ranibizumab before coming to us, so we gave aflibercept with immediate visual response, repeated it, and you can see that he has excellent visual acuity 9 months following the last injection. And so he refuses to take injection, though the anatomy is not good. And then he agreed to take only 1 year after the last injection, September to September, and again with excellent visual result. And then again, we injected only 10 months after the last injection. So 10 to 12 months has been the interval of treatment with excellent visual result, irrespective of the anatomic result. So visual results are superior to anatomic results and long treatment intervals are possible. This is to show that one patient we treated with ranibizumab, the response was not good. He agreed to aflibercept. We gave him 3 monthly injections or almost monthly. And you see that then he has not needed injections for 2.5 years. And then recurrence at 2.5 years at which we gave him an injection. This is a patient with a vitrectomized eye. Vitrectomy was done for vitreous hemorrhage PDR. And subsequently, several years later, he developed DME. And we could give a aflibercept at an interval of 2.5 months to 3 months with good visual result. So it remains unaffected in a vitrectomized eye, which several studies have found that the response is equivalent to steroid in terms of duration of effect in a vitrectomized eye. So with all this experience, we realized that it's better to use aflibercept as a first-line drug in treatment-naive patients to get the best response in shortest time and to avoid these fluctuations in the anatomy, which leads to long-term poor prognosis because there is damage to the retinal cells as long as we are waiting for response. And treatment reduced burden leads to reduced number of visits, costs, risks. Each injection has a risk of endophthalmitis. So this is a real-world study which supports the idea that treatment-naive patients given aflibercept will have a final better visual outcome than after we have given it in trying other agents and recalcitrant cases. So this is to show a few cases of treatment-naive. More recent cases, as you see, this is 2021, where we just start with aflibercept. And you see the excellent visual response at 5 months following the last injection. And the patient doesn't need any more. Again, a single injection and 6 months later, patient is 6/6 N6 without further injection, 1 injection. Now this again, treatment-naive patient, anatomic results, not very impressive, but look at the visual results. And so the patient refuses to take an injection. He says, I'm able to do my work well. But anyway, we were able to convince them to take more frequently. But I find that though the anatomy didn't improve, even with monthly injections, he's as satisfied with his visual results. And probably we can do with less frequent injections and maintain the same visual outcome. Again, to show another lady, though the anatomy is not showing much change, the vision is And she is very satisfied and continues to come for the injections. Thank you.
Thank you, Malika, for showing a lot of your cases of aflibercept. Let's have some panel discussion, because you see what I am enthused is about this disproportionate between anatomy and the BCVA, because all of us want to have are dictated by OCT monitoring. You see, most of our injections are dictated by OCT. So if, like you said, in a couple of last patients, especially treatment-naive patients with the aflibercept, there was a disproportionate between visual versus the anatomy. And you said the patient is happy, so that does not, honestly speaking, make me happy, because I have to somehow pay attention to the anatomical results also. So how happy are you if the vision improves but the anatomy does not improve with aflibercept? Maybe we can start with Hemant Murthy or anybody else also.
So very nice talks. I think both the talks were very good.
Wonderful pictures, actually.
Thank you.
All very nice, all good cases that showed us that there is a disproportionate increase in vision. You see the anatomy. I always try to look at vision. I think vision is the priority from the patient's point of view. I think that is the most important. He's not worried about how the OCT looks. I think he's going to be worried about his vision. So I give the injection. In the next, I don't find any change in the vision or OCT. I say that is the vision that he's going to have, because diabetics don't get an absolutely normal looking OCT in a lot of patients. So I think you reach a stage wherein you have no further improvement in the structural OCT, but vision is pretty good for the patient. And that's when I think I take a back seat and say, let's accept this as the best for that patient.
No, I agree, Hemant, but I think Nishant had shown that you see why the posology of multiple injections, because vision may continue to improve as well as the anatomy. Nishant, your take on this, that how do you approach such patients? You see, where vision has improved, but anatomy has still not kept pace with that.
So, so I think this is a very interesting thing, because, as I showed you from the Vivid Vista as well as the DRCR network studies, that, that even after 5 injections, people were continuing to improve by about 1 Snellen line in about 15 to 20% of people. Now, obviously, there are certain compulsions, patients not following up, DNAing, cost, etc. What I found, if in an ideal world, yes, would I want to continue to treat them, at least find stabilization of vision and OCT over 2 consecutive visits and give at least 4 or 5 injections? That would be the ideal scenario for me, but I think none of us work in an ideal world. What I found very interesting with Malika's talk is that, very few papers actually comment on reading vision. They look at best corrected distant vision, which is a logMAR vision. And like Malika said, that if my patients can see and continue to be functional at work, they're going to be happy. And she saw that though the vision was 636, there was that disproportionate N6, N8, N10, which you wouldn't, I don't know whether Malika's opticians are giving that a bit of a magnification effect with the kind of reading glasses, or, there is that magnification that comes in when you give a +3, +3.5. But that kind of disparity, we have seen that in CAT and IVAN, we saw that disparity between distance vision and near vision, and reading speed is something people talk a lot about as far as kind of improvement in vision. So I think when you look at this one, but Malika's talk, I think she kind of has given me an insight that, listen, Nishant, look at the reading vision more and ask them, are they functional? And make that part of your kind of reading vision was not part of my decision-making kind of algorithm, to be very honest, Dr. Lalit Verma. Exactly like you, I look at the OCT. My worry with something like Malika's patient, that they're looking very nice now, but when you look at those huge cysts, you always worry that 2 years later, are they yet going to be seeing N10, N12, or are they going to be at N36? But, we don't really know the near vision data for intraretinal fluid. We know the distance vision, and we know that intraretinal fluid is a bad idea. But Malika, how did you come about this kind of idea of concentrating on near vision and gauging functionality? We'd like your thoughts, because that's something quite novel that you're doing.
I think she said that patient's employment was such that he wanted more of near vision. No, Malika?
Yeah, actually, excellent point you brought up. Even I didn't focus on that, the disparity between distance and near vision. See, actually, we always have been since I'm practicing in RP center training also, we always were checking the near vision. Because most patients, even elderly retired patients, their job is reading. They want the newspaper. And similarly, the person who's working as a clerk, he needs his reading vision. So they are all concerned only about reading. Most of them are not bothered about distance vision. They give up driving easily, but they cannot give up reading. So if they are happy, they are happy only when the reading vision improves. So it automatically happened. I never focused on it consciously. They come and tell me that I'm able to read, I'm happier, my work is better. I didn't do it purposely. It just happened.
Ritesh, you see, let me come to you. Traditionally, most of us, in DME, center involving DME, non-tractional, we start with anti-VEGF, we give a couple of doses, and we see the response over, say, see the BCVA, see the OCT reduction, and then shift to steroids. So what Mallika, a couple of patients, initially were resistant cases, what she was talking about, she had shifting from, anti-VEGF steroids and then came back to aflibercept. You see, this is not the traditional thing which majority of us have been doing. So your, comments on that. You see patients who are not responding to DEX and had a wonderful, tremendous response after starting aflibercept. Not only anatomy, but the vision also.
Dr. Verma, I was exactly doing what Dr. Mallika's cases were shown before I started adopting protocol T into my practice properly. DEX was my rescue agent if the patient was not responding to ranibizumab. It's over the last 2 years wherein the DEX use has gone down and aflibercept has come in more. And yes, patients who have with DEX, there's always this concern if you're doing it in a phakic eye, cataract will develop. Once you do a cataract in a diabetic, the edema will worsen. So all those concerns are not there with aflibercept. And that has predominantly made aflibercept slowly becoming more a drug of choice in bad diabetic macular edemas. And yes, this shift has happened. I have a couple of patients.
No, I agree. You see, let's not talk of pseudophakic eyes. Let's not talk of cataract versus this. I am talking of, because Mallika's initial 4 or 5 patients, in fact, not 1, not 2, not 3, who were not responding to, anti-VEGF, then DEX, and then suddenly aflibercept and anatomy comes to normal and vision improves.
Yeah,
Yes,
I have seen similar.
So, that is why now I have stopped going via the DEX route. Now it is.
You see, I wanted to bring this point only. Whether this, you see, 1, 2, 3, that step ladder kind of pattern, what a lot of us have been doing, including myself, that we start with anti-VEGF, whatever, and then shift to DEX implant. And we quote a lot of studies in a lot of webinars that you see Praveen Dugal said this and DEX implant. So now should we change the posology? Either we start only with the aflibercept, and if by chance patient does not respond, then we go to DEX, or we do not bring DEX in between and we shift a lot of these patients who are on whatever drug they may be, whether Beva, ranibizumab or IVTA, shift straight to aflibercept. So that was my concern.
I would go with the first one, sir, where you start with aflibercept as for patients with poorer vision and then move on to DEX.
Because a lot of patients, Ritesh, come to you who are not treatment naive. So in treatment naive, I agree with you, and Mallika has very, very strongly said about this thing that today the number of the treatment choice is this. Ajay, your take on this? This particular step, I want your opinion on this step ladder kind of approach.
So I think what Mallika has brought out is very remarkable, that patients who are not responding to IVTA have responded to aflibercept, because that is something which we people have been thinking, especially her cases had cystoid macular edema. And whenever we have cystoid macular, I was trying to look at the hyperreflective dots where they may be more steroid responders, but I couldn't see in these pictures very clearly. But what I saw was that patients with cystoid macular edema responded to aflibercept, and I think that is very, very important. If you look at the data of PAT survey of the American Academy as well as India, what difference was found is in the US PAT survey last year, it was seen that people actually shift from an anti-VEGF to an anti-VEGF. While in an Indian survey, many of them may not shift from an anti-VEGF to an anti-VEGF, they'll shift to a steroid from an anti-VEGF. So what Mallika has brought out is that actually aflibercept might be a better agent to shift at. And one of the talks which I heard at Retina last year, a person who was presenting the aflibercept data, he said, if you were asked to choose one agent, he said, invariably I am injecting Avastin as the first agent. By the time the person starts understanding and believes in an anti-VEGF, and my next injection is actually an aflibercept. By the time the patient has made up his mind, and therefore we inject aflibercept. And the reason they said in that panel discussion was possibly as what has been brought out is the placental growth factor inhibition, which I think was brought out because it probably increases the reperfusion. So that is a very, very important factor, I think.
The other point was, you see, the VRSI survey data which got published in June of 2021 in IJO. I just had a look before I came to this webinar. So majority in India still start with ranibizumab. So that is the reason I, after hearing to Nishant and Mallika's talk, I think we need to have a resurvey and need to work harder, because the strength of figures what Mallika showed and then this potency of aflibercept even over patients with steroids may tilt this balance, which is 49 to 50%. In fact, all of us majority start with ranibizumab, especially in DME. So
I have a question for
is there a need to have a resurvey, or you see, because the data which Mallika and Nishant presented, I think force us to reconsider all these things and maybe have more webinars elsewhere also, because why deny the best possible drug to the patient? Dries?
No, I totally agree with you. I think maybe the data was collected at a time when Eylea for use scheme was not implemented. So probably now, if we have a resurvey, we may be getting a different kind of data. Like you said, that Eylea for use scheme is totally changed it because economics is very important to our non-insured patients. So I think you're totally correct on that one, sir.
Can I ask a question
Scheme is one thing. Scheme is one thing, but drug is another thing. Eylea for scheme, like I told very honestly, you see, we had 10% Eylea before this scheme came. Now we have more than 70, 80% Eylea in our operation list. Yes, Ajay, you wanted to ask something.
I have a question to Nishant. This reperfusion means actually reduction of the capillary dropout area. So I have not looked at those studies. Nishant, can you tell us whether those reperfusion data actually shows on the unfast images a reduction in capillary dropout or non-perfusion on Octa on a DCP plexus, or it is just what is the data about?
So this data was actually fluorescein angiogram based, Ajay. So this
is not
is not an Octa, this is not on fast images, this is a fluorescein based, and it was very kind of simple. It was, is there any evidence of non-perfusion? Not how big, not how small. If there's any capillary dropout, there was non-perfusion, yes or no. And the reversal was also the same, that there had to be no kind of areas of non-perfusion. It was completely perfused. And then also in 2 years, you were getting 50% of people were getting at least one quadrant reversal. And in the temporal macula as well, you're getting about 40% people getting complete reperfusion. That means there's no CNPs noted at all, which is quite incredible. Now whether that was sustained, if you stop the treatment or did it reverse, we really don't know that at this moment.
Yeah, because if you demonstrate a reperfusion, it means angiogenesis.
Absolutely, and I think that's what they said.
And that is remarkable. And the other point I wanted to make out for Mallika was she showed in one of her cases where she was injecting on a monthly basis, which probably answers Dr. Lalit's question, is that particular patient had an anatomical scrotal flattening.
Absolutely.
When the patient injected on a monthly basis. When the patient said, no, I'll get injection after 9 months, the vision improved. The anatomy did not improve, but a patient where the vision and anatomy improved required more injection.
So therefore, I brought in Nishant at that time because he said the posology is that you continue to inject also. So therefore, you see, I wanted balance between what Mallika said and what Nishant said about the Europe this thing. One last, question about the intermittent kind of treatment. There's a lot of patients in our country, if they have small benefit, they stop coming. You see, Mallika also raised that point, to avoid fluctuations in this, gain, whether anatomy or see. So Devulal, what is your take on this about, intermittent treatment as well as fluctuations in the gains?
Intermittent treatment is something that's not good for the patient and neither for us, because both ways, like the patient is unhappy and ultimately comes and tells Dr. Saab kya fayda kya hua. So I think that is something we need to be careful about. And maybe some patients, like Dr. Nishant was saying, that 20-30% of the patients might be doing good at a extended interval of injections, but not all of them will be benefited with this kind of an intermittent sort of a treatment. But of course, that is something that is real in our
yeah, that's a real world. I think there are subsets which will remain intermittent also. Hemant?
Yeah, no, my question was to Nishant. You've seen this with aflibercept, that there is an improvement in perfusion. Has there been any study on any other drug, any other anti-VEGF showing reperfusion? Because then it would imply that it is PIGF driven. Now, that's why.
So we've seen this with kind of, if you remember, Michael Stewart had presented some data with wild field angiography in CRVOs, where with ranibizumab also he showed peripheral improvement in non-perfusion, but that was very reversible. So as soon as you stop the injections, that kind of changed completely. But it was more in the periphery and not in the posterior pole. The thing is that these were not these were 45-degree fields, right? So this is not looking out with a kind of optos image. So I think this is more relevant to us. Some non-perfusion right in the periphery may not be that clinically meaningful, but this was more kind of, right kind of next to the disc or in the kind of macular area. If that reperfuses, then that might have long-term implications.
Because that would change our management, because I would probably prefer, most of them would start preferring aflibercept as a first drug of choice. So I think
Hemant, that was probably brought out in that symposium in Euretina last time, with that placental growth factor probably has a role. Yeah.
With sorry to interrupt, but with respect to time, can I request
Nikhil, don't worry about Nikhil, because Nishant, the other point was about, because I believe the most powerful analysis is by Cochrane.
Absolutely.
Which is in favor of this. I had one small question. You showed 3 graphs, even with aflibercept. You see that red line and dark blue line.
Correct.
So what is your take on that last line, red line, where the graph does not go up?
So I think, my take is that, sometimes after 2 injections, you also get impatient. The patient also gets impatient. Should we add a steroid? Like you said, that we tend to escalate between add something or should I do something a bit different? And I think if you just stick the course sometimes with, maybe a 4th or 5th injection, you will see that person sweeping. And if they get that 1 line of improvement, on Snellen or 5 or 6 letters on ETDRS, that's much better than we were ever seeing before. So rather than taking out your laser, I think at 3 injections, maybe my mindset and a lot of ours were like, 3 injections, we start taking a call as to what to do next. Maybe I've now, because with the Eylea for You program, you got the flexibility of 5, since the 4th and 5th are free, they're committed to taking that. Nobody wants to leave a free injection. So normally once you've given the 5th, you see that turnaround. And I think that's what that red line shows us, that even the patients you think, ye to kuch nahi hone wala, ye to dabba case hai, after the 5th injection, they do turn a corner and, you can kind of have some hope there. Because as Malika said, sometimes adding a steroid doesn't really do much to it. Protocol you showed that, brolucizumab is not licensed for DME. And even if it were, whether we'd be comfortable using it in these kind of eyes is a question. So I think just continue injections. So it's nice to know that even as a patient out of second year not doing well, you can tell the patient, listen, you might turn a corner after the 3rd or 4th injection.
So I think we will move on to the next section of AMD. And maybe if one line conclusion, that with Nishant's very powerful presentation, as I had enumerated about BCVA, area under curve, perfusion status, as well as DRSS, and Malika's 11 cases which she presented, and this economics which Bayer said earlier for you, maybe today we can have a rethink, all of us, not only this panel, but all of us, all retinologists, that maybe that aflibercept should or may be preferred as number 1 treatment for center-involving non-tractional DME patients. Are we unified in this? Anybody?
Yes, sir. Not unified. The ASRS PAT survey recently has shown 72% of the physicians across the world are
I'm aware.
choice for DME.
That's right.
Yeah. I wanted that this 72% to perpetuate into India also. You see, India still, believe me, at even our center, let me admit, a couple of months back, our number 1 choice has been traditionally, ranibizumab, chalte aa. So now the more the webinars we do, the more the strength of data and more the personal real world scenarios come. I think this has to get established and percolate down into the masses. And maybe as Ritesh was saying, we or others were saying, we can have another survey after this Idea for You program is launched.
That's right.
So thanks everybody for this great discussion. Now we move on to the next common problem, which is AMD. And let's request Ritesh Nirula to tell us about very important thing, because AMD is different than DME, primarily because here VEGF load is higher and people are looking to reduce the treatment burden. New kids are on the block also. Everyone claims that we can increase the interval from Q8 to Q12 to Q16. And I'll request Ritesh to tell us about how to use this treat and extend regimens for better patient outcomes. Over to you, Ritesh.
Thank you, Lalit sir. So my purpose of my talk today is to talk about treat and extend, or the proactive regime when it is considered for neovascular AMD. These are my financial disclosures. Now, when I think about TNE or proactive regime, the thoughts that come to my mind is it to reduce the number of injections? Then the counter thought is reducing the number of injections really good? The second thought is it to reduce the number of visits? But then the question comes, why do you want to reduce number of visits? How are you going to benefit from it? So when we talk about number of injections, Anchor, Marina, which were the baseline trials on anti-VEGF, they started off with 2 years study of monthly injections, and they showed beautiful responses with almost 96-97% eyes stabilizing, 40% eyes improving in vision. But even with view 1 and view 2, where there was a fixed regime happening with aflibercept either monthly or 2 monthly, this was giving amazing result, best efficacious result, what we can say, but requires a lot of injections and requires visits every month. Is it possible to sustain it in long term? Maybe in a trial setting, yes. In a real world, this may not work out true. Now, to get this down, the researchers were smart enough. They knew this will not work or hold for a long period of time. So they thought, okay, let's try and see with reduced number of injections what happens. So they moved on to a 3 monthly or a quarterly injection and a PRN based treatment regime, which we are also comfortably using. The moment they went down to quarterly injections, the visual acuity improvement went down, the stabilization data went down, and they realized that the patients are not doing as well as they were when they were more frequently being treated. And the reason they attributed when they tried to do a subgroup analysis was the patients in which they divided the patients amongst those which had persistent fluid and amongst those which did not have fluid. And those which had fluid did not do as well as patients who became dry. So a dry retina is needed when we are talking about neovascular AMD. And the drier it is, the better the visual acuity results are. PRN, though, gave us as good a result almost as compared to the monthly injections. Even the stabilization rates were pretty good. The CAT study, which studied ranibizumab and bevacizumab comparison monthly as well as PRN, also showed improvement very comparable in PRN to monthly regimes. Though the drying was slightly less when it came to PRN compared to monthly in case of ranibizumab. Again, they could make out that patients who were on PRN had some amount of fluid left vis-a-vis those who were monthly being treated with anti-VEGFs. So PRN gives us the advantage with more or less similar visual gains of fewer number of injections. But there is a problem with PRN. The problem is that these patients, if you're considering them for PRN, you need to strictly follow them every month. You want to make sure that each month the patient comes in, you see the OCT. If the fluid is coming back, you give them an injection. So you are reacting to the OCT. This is what is called as the reactive approach. You see the OCT, you see the fluid, you inject. Now, but it gives good results. So why not just continue with it? The problem is the disease is not a finite disease like DME, wherein you at a certain stage are able to reduce the number of injections, are able to achieve a plateau. Herein, a lot of trials have shown that when these patients are followed up for a long period of time, patients do tend to go down in their slope. And this going down in the slope typically happens with patients who, with period of time, start to reduce their number of injections. So with PRN, when you ask the patient, keep coming monthly, he does it for a year, maybe a 2-year period. The fatigue sets in, they start coming less frequently, and the slope starts to go down. And what has also been shown is when you eyes which had this fall in visual acuity, when you try to restart them, they do not gain as well as compared to those who were maintained earlier on uh, continued injection regimes. So, because, as I said, this is all because of a lot of issues working around a patient's treatment. There is cost of the therapy involved, but we very often forget that all these patients are old patients. They have caregivers who need to come with them. There's a burden involved there also. They need to take a break from their job, come get their parents. There are travel consideration. Treatment anxiety does set in. So all this lead to a lot of non-compliance when it comes to PRN or the more number of visits you ask for. And just skipping on, that's how the difference comes from randomized trials to real world. The kind of visual acuity improvements that was seen in randomized clinical trial vis-a-vis the real world evidence is much less, because you are not able to follow up these patients that frequently when it comes to long term. And again, emphasizing, neovascular AMD is not a finite disease. It will need monitoring management throughout. I have one of my senior colleagues, Dr. Talwar, he actually says, जब तक तुम जिंदा हो या जब तक मैं जिंदा हूं, हम मिलते रहेंगे. So that brings us to proactive treatment. Proactive treatment is wherein you plan your next injection, you keep extending the schedule, and before even the OCT starts to show changes, you are treating those patients, which is also called as the treat and extend regime. So this is how typically a proactive or a treat and extend dosing looks like. After the initial loading dose, you ask the patient, you slowly increase the interval between the next follow-up and the next injection from 4 weeks to either a 2 weekly increments of 6, 8, 10, and 12, or you can even do a 4 weekly interval jumps from 8 weeks to 12 and then 16 onwards and so on. And at any stage, if you see fluid coming back, you tend to reduce or step down in your treatment interval. And so with treat and extend proactive regime, one can reduce the number of injections. One can also reduce the number of visits, and the visual acuity gains can be as close as possible to the fixed regime. So you're not losing out anything in terms of visual acuity. So this is based on the fact that the VEGF levels the change in the VEGF level is before the changes in OCT or happens on visual acuity. So if you're able to keep the VEGF level suppressed, you may be able to achieve a better OCT and in return a better visual acuity. So why is aflibercept such a useful drug when it comes to treat and extend? There are multiple reasons for it. One, it has a much higher binding affinity to VEGF compared to other molecules. Number two, it has a greater potency compared to other molecules. So stronger binding, stronger potency. It also has actions against PGF as it was being discussed. And it also has a much longer intraocular half-life. So some molecule which is more potent stays for much longer in the eye, becomes a useful tool when it comes to extending a treatment regime. And this was shown very nicely with the Altair study, which was based on aflibercept, wherein they compared two kind of interval adjustment from 2 weekly jumps to 4 weekly jumps. Patients after the initial loading dose, 8-week injection, then they were either kept in a 2-week jump arm or a 4-week jump arm. And the criteria to treat was based on if there was no fluid. Extension is if there was fluid present, the intervals were shortened. And they also had this arm of maintenance where they talked about tolerating some amount of SRF, that is no increase in central retinal thickness of greater than 100 microns and no change in visual acuity, which they said was what they were tolerating. And the Altair study did show that the vision acuity gains achieved in year 1, but then subsequently maintained by week 96 with fewer than 4 injections in year 2. So you could reduce the number of injections without losing much on the visual acuity. And also the study showed that 60% of these patients were able to maintain an interval of 12 weeks or more, and about 40% patients reached even intervals of 16 weeks. And out of the patients which achieved this visual acuity interval, most of them, almost 86%, were able to maintain those intervals. So it's not that just once you have reached the interval, you can then maintain it for a long period of time. This gives us an advantage in a disease which is not finite, that you can keep probably continuing with those treatment interval for a long period of time. 16 weeks means roughly 4 months. There have been doctors who have been talking about in trials about going up to 20 and 24 weeks also with certain set of patients. This is much more than what was seen with the other newer molecule on the block, which is brolucizumab, wherein the number of patients who could extend beyond 12 weeks were much less compared to those with aflibercept. Only for so that's where the difference comes from the brolucizumab too. And which was much more obviously compared to ranibizumab, where the only about 22% patients were actually able to extend compared to aflibercept. So amongst extending, aflibercept had the highest number of percentage of patients, followed by brolucizumab, followed by ranibizumab. So this what trials have shown. Also, the real world studies have also shown similar results. Patients in real world studies have also been able to extend and maintain or even gained in visual acuity on extension arms also. Also, the number of clinical visits by any of the treatment regimes for caregivers was significantly reduced when the patients were on TNE compared to PRN. So to summarize, neovascular AMD management, it's aimed not just at visual gains, but also at reducing treatment burden as we are dealing with a long-term disease. And treat and extend approach herein gives you a beautiful way to do that. And one can achieve a lot of patients, about 40% or more on intervals of 16 weeks, and about 60% or more on intervals of more than 12. Just to show how the TNE regime is carried out, I'll just quickly share 2 cases of mine. This was a 62-year-old female, a professor, with type 1 neovascular AMD, and under treatment since 2017. Her presenting visual acuity to us was 618. She was before that also on a kind of PRN with ranibizumab. Her problem was that she wanted to read well. So that's what her main issue was. And each time her PRN was happening and with ranibizumab, she used to improve and then go back. When she came to us, we started her on aflibercept. Initial loading dose, she improved to 6/6 partial. Initially, this patient, I also began with PRN. So you see, initially the fluid went down and then it used to come back, and she got an injection at interval of 8 weeks, followed up, did not give an injection, fluid came back, injected, again followed up, again injected. So roughly about 8 weeks, the fluid was coming back for her on PRN, but she was on monthly follow-ups. She was a very regular patient. Then slightly longer interval happened at 9. The fluid came back, went away, came back, came back, and then again gave injection, went away. But her problem was each time it used to go down, her visual acuity used to drop. She used to become 6/9 partial, 6/12, N8, and always that anxiety whether I'll be able to come back to my reading vision well or not. So till this continued for almost a year, when we discussed, see, importance for TNA is you need to spend time with your patient, you need to talk to them about it, you need to make them understand how it is going to work. And once it works well for patients who are able to understand it, and they're smart enough to detect even changes at home so that they can come back if there is an issue with their vision. So in 2019 December roughly, I shifted her, planned and shifted to TNE. Initially re-gave her loading dose, dried her completely by March 2020, and then slowly started to extend. But each of these visits were now injection visits. So moving from 4 weeks to 6 weeks, then 8, 10, 12, 14, 16, 18, and now I've extended her to 20. And this was a 2-weekly interval jump. Her next visit is scheduled somewhere in April now. So from May 2017 to December 2019, she had about 32 months with us. She had about 30 visits and 16 injections. From January 2020 to December 2021, she had 11 visits and 11 injections. So that is how TNE helps us and works. It reduces both the visit burden, also controls the injection burden. The corollary to this, and is another case, a male patient who again presented with a vision of 618, started with aflibercept, after improved in vision to 6/9, and then was put on TNE. So this is how he went initially in the loading dose period, 4-weekly interval, dried up SRF, and then I started to extend from 4 to 6, 6 to 8. The moment I went to 10, the fluid came back. So this is how you kind of customize it for your patient. When it came back at 10, I went back to 8 and is now maintaining him at 8, 8, and 8. At this stage, there is a kind of an intraretinal fluid which has come back, and the patient was given a very strict follow-up. In this, I also did between a monthly PRN kind of an OCT at this stage, but that was very similar. So I just followed it up for another month. So that was because of this small intraretinal fluid which came here. So when we come to talking about effective treatment of AMD, it's important, apart from deciding on the injection, we should be very proactive in terms of what kind of a regime suits best for our patient. For a patient who I feel will not understand TNE, I would rather keep them coming to me monthly. But for a patient with whom I can discuss well, explain them TME and can reduce their visits, and I can really optimize their treatment burden by using a proactive approach there. Thank you.
Thank you, Ritesh, for a wonderful talk. I don't know how much time is there. Yeah. So we will have discussion after. I think let's go to Debulal cases also about his experience. But I think what Ritesh has brought out is that he started very nicely about injections versus visits. And treat and extend has the propensity to reduce both number of injections also and the number of visits also, with a reasonably closer, to the randomized controlled trials, the gain in vision. But very important thing which he told was that you need to individualize. And for that, I think you need to talk to the patient so as to maximize the visual results for that particular patient. And the compelling data from Altair, 60%, 40% on Q12 and Q16, that again is very compelling compared to newer kids on the block vis-a-vis Rani, I think he said around 20-22%, and brolucimab around 35 to 40%. So these are the couple of key learning points from Ritesh talk. Let's hear some real world cases, and after that we'll have some useful discussion. Debulal.
Yes, thank you, sir. I'll be sharing my slides. So I hope my slides are visible. Yeah.
Yeah. Please carry on. Please carry on.
So this would be an extension of where Dr. Ritesh left off, and he made a couple of very pertinent points. So these are some issues that we are going to look in this presentation also. So basically, when we think for ourselves, it's basically the efficacy that we are talking about. We are talking about the monitoring burden that we have. We are talking about the treatment intervals and how to get these patients to maybe a proactive kind of a regimen, because this is something, treat and extend is something that not many Indian patients understand as of now. And of course, these patients, most of these patients, for me at least, around 20 to 25% of the patients are only on some kind of Mediclaim or insurance umbrella. So having said that, from the patient's perspective, it is the concern about vision improvement which drives the patient and brings back the patient to us. And of course, they are concerned about frequent treatments and people having to bring them in, because these are mostly elderly infirm patients who need some help from a relative or a caregiver. So basically, it's a place where both the physician and the patient meet together. So we need something that's effective. We need lesser injection visits, and also we would like to have lesser monitoring visits. So just to share a little bit of data, I'll be sketchy here because this is under review with the journal. So just to give you a brief idea about some of our experience. So 120 eyes with neovascular AMD with more than 12 months follow-up. Now, 55% were treatment naive and 44% were actually switches from other anti-VEGF. 67% of these eyes that were switched had improvement from baseline visual acuity that had at the time of switch. Not to say that the naive eyes didn't do well. They actually did much better because they started off earlier. But even the switch eyes, which had many injections between them, and so they also improved with the introduction of aflibercept. So the average time to next injection in the switch patients was I should clarify here that the switch patients were on a PRN regimen, all of them. So that was more than 3 months, and which is what Dr. Ritesh actually was mentioning, that many of these go on to 3 months or beyond. And also the vision improvement was like I mentioned, noted in both naive and switch patients. So just to kind of give a picture of the full cohort, it was 0.63 to begin with. This is of course logMAR, baseline visual acuity, that is Snellen converted to logMAR, and at final follow-up it was around less than 0.54. And also the CMT improvement was there across the cohort, 400 plus to something around less than 350. So a few cases which would kind of tell us what happens actually in real life, which all of us have faced. So this is a lady who came in 2014. I started seeing her, and 636 vision in the right eye. She came in at this, and she had actually had a drop in vision for more than a month or so, and had received advice for anti-VEGF elsewhere also, but she was kind of doctor shopping, and she wanted to just come in and get some advice, and so she was not willing to take any injections. Said that okay, I'll live with my left eye for the rest of my life. And for the next 3 years, actually, she was doing good with a little bit of drusen and maybe a shallow PED here. So, and she was maintaining 6/9 vision, was on antioxidants and M charting, and very smart lady. And then she came with this huge PED and SRF, and vision had dropped down to 6/12. And this is actually, just a month after this visit, which was in the month of June, and this is July. So, so we explained that you need a aflibercept right away. But she said, well, I'll need some time to think about it, because she wasn't really, aware what was going to come. And then this happened, and she had this artery rip, and she came back. And this time again, it was the same story. We asked her to get the injection done, and because of her daughter, who happens to stay in the West, she actually called me up and said, "Aaj injection aap lagaiye." So that's what happened, and actually she started doing better. So first month after first Eylea, this was on a loading dose, and we gave 3 loading doses, and the fluid started going down. And by 3 months, she was up 6/12, and then gradually we started treat and extend, and we extended 2 weeks at a time, and little scared to extend too much in the first year. So, but she was doing 6/12 with 8 to 10 week intervals. And by the end of 2018, she was on 12-week intervals. And next year, we thought, okay, we'll go to 16 weeks. And this is what happened when we moved to 16 weeks. And then we injected the same day, and she started doing better in a month. And vision had gone up from 636 to 618. And then we settled for 8 weekly injections. But, this fluid was still there. So I was a little anxious. And but somehow she came back after 8 weeks only, in spite of us asking her to come after 6 weeks. But next time the fluid was little better at 8 weeks, had gone down a little. And so we kind of went ahead with 6 weeks, went ahead with an extension of 2 weeks. And so she was doing 6/12 at that point. So this is what continued throughout 2020. And she actually gained a little bit of vision. And she was doing 6/9 part with a little bit of distortion. But, after this visit, she actually came back 6 weeks later with this fluid coming back here. And she said she couldn't see properly. So actually, there was, fluid that we could see on the OCT. And we injected her on the same day. And, this is how she is now in this year. And she is basically now on 10-week, interval now. So we are little scared to extend her beyond 10 weeks, because she is one-eyed, And just to, sort of tell you how many injections she is needed in 4 years is that she's needed 21 injections in 4 years. So it's important to kind of titrate, and it's important for the patient also to be intelligent that 12 weeks ke bulaya to tabhi jaunga, whether or not I have decrease in vision. That is the kind of patient you don't want with treat and extend. So the other case, the next case, actually, this is how the patient presented to the GOPD one fine day, and vision was 612, and the GOPD consultant actually advised same-day retina consultation. But as happens with our patients, they move around, maybe take a little bit of a walk and come back, and this is what happened. After 2 weeks, actually, patient came back for the retina consultation, 460 vision with RP rip. And as you can see, this fibrovascular PED has kind of, ruptured and vision has gone down. So we injected on the same day, and little bit of improvement after the first injection. This is after the second injection, and this is after the third injection. So these were loading doses. And then we actually, after the third Eylea, we actually started, giving her every 8 weeks, basically. So the fluid was practically the same with this 8-weekly injections. And the vision has actually gone up from 460 to 612 now. And so we were kind of emboldened to try out 10 weeks. And then because the fluid was, I thought the fluid was, increasing at 10 weeks. So I asked her to not to go beyond 10 weeks, but somehow, she had COVID and came back after 12 weeks. And actually the fluid was, kind of little lesser, it seemed like, and the vision was also stable at 612 part. So we injected her on that day, and she is currently on Q12 weekly interval. Vision is 6/9 part. The fluid has surprisingly gone down a lot, and there's hardly any fluid when she comes. And she received 7 injections in the first year, and in the next 6 months, she's received 2 more injections. So that works out to around 9 injections in 18 months. So, and just to remind, kind of, this is where she started off. So a lot of improvement, and not too many injections also, considering what her kind of disease was. So next case, this is a naive gentleman once again, and so a huge fibrovascular PED here, and this is after the first injection. Already you can see there is a marked decrease in the PED height, and the SRF has also kind of gone. And so we continued with the loading dose, and this is how, like, the patient was doing 6/18 part, and patient is actually on a Q12 weekly injections, and this is another one-eyed patient. So why I mentioned this one-eyed thing is that we are not scared to inject aflibercept in one-eyed patients. Another one-eyed lady who had undergone PDT with ranibizumab in 2015, she was doing okay till 2018 post the combo therapy, and when she came back with this fluid here, and we injected her with an aflibercept, and she did well till 2021. So you can't really kind of predict for each and every person what is going to be the next time when she or he is going to bleed. But because she is a one-eyed lady, so we were initially on a 1-monthly checkup, and then I told her that okay, the maximum I can give you is 6 weeks, and that she's been very diligent with her follow-ups. And thankfully, when she came with this, we injected on the same day. And as you can see, she has been 6/6 all this while. And even now she is 6/6. And she had a recurrence in September again, where she got another Eylea injection, and she is now dry, and she's 6/6 now. So that being her only eye. Now, let's talk about a couple of switch patients. So this is a patient who actually had been showing in our
sorry to interrupt, sir, but we are running short of time. If you could sum it up in the next 30 seconds, thank you.
So, as you can see, this patient actually had come after 18 injections, and this is how he looked after the first Eylea. Came back after 4 months with this fluid, and it was the same story. 3 months, no fluid after the next Eylea, second Eylea. So currently on Q12 dosing for last 12 months. So to conclude, in real life scenario, aflibercept is effective in naive and switch patients and can offer a longer injection-free interval to the patient. Thank you for your kind attention. Stop sharing.
Thank you, Dr. Debilal. we have had some excellent presentations by Ritesh and cases by Dr. Devulal. Let's have around 10 minutes of discussion on this, and I will set the ball rolling by saying that you see, Ritesh said very nicely that AMD, unlike DME, not a finite disease, and we have to continue to manage these patients virtually lifelong. And under treatment is virtually a rule in this country that and therefore to balance everything, treat and extend regimen is the way to go. I'd just like to ask how many of you, how much percentage of patients of yours are ultimately under treat and extend? Hemant?
Now, first of all, good talks by both of them. I'll just touch a bit. We all know that treat and extend does well. I think Ritesh brought out a very good point, a very pertinent point. We have two categories of patients. One in which treat and extend, you explain to them, they adopt from the word go. The second group, you need to prime them. So first they are initially on PRN, then you show the disadvantage of PRN, then they change to treat and extend. So I have these two categories. Initially, I think after Altair and all these studies came out, I think now my percentage of treat and extend is about 40% of patients.
So counseling, Ritesh said, plays a very important role. You see, you need to talk and talk, because you see, patient may start sometimes doubting all this. But you see, like Hemant, you said, once the patient goes down in PRN, and then he will get, whatever you say, he will succumb to that. But in the initial phases, it may be difficult. Yes, Malika?
So, 2 points. One is that, as the first speaker pointed out, that if you do PRN, you don't gain back the amount of vision that you lost.
Very important. Very, very important in ARMD that Ritesh pointed out, that once the vision goes down, that is the difference between reactive and proactive.
So the sustained study with ranibizumab showed that if you lose 8 letters, you only gain back 2 letters in the first event of recurrence. And by the 6th event of recurrence, you lose 5 letters, you gain 0.5 letter. So by the end of it, PRN 4 or 5 events, you have lost a lot of vision. That was one point. And second is that I have in my patients seen that the polyp regresses after giving aflibercept injections. When I did the ICG before starting treatment and after a few injections, the polyp has completely regressed, never to come back. Not only the disease is...
I agree. The other advantage of using aflibercept has been, you see, in the management of PCVs. You see, whereas when we used to use either bevacizumab or ranibizumab, we were never confident of it. And we always had to resort to combo treatment with the half-fluence PDT and ranibizumab. But with the Eylea coming into picture, it has become a choice virtually in this subset of ARMD patients, or what we call PCV patients.
And the third, to answer your question, what percentage of patients are now treat and extend? I think most of the educated young and middle-aged people that come with their parent, they want treat and extend, because they sit next to me when I'm doing the OCT, or whoever is doing the OCT. They sit next and we show them that, see, now the fluid has come at 2.5 months. So they agree that, okay, now our next treatment should remain not more than 2.5 months. So most of the educated people are on treat and extend. It's only the ones who don't have the financial wherewithal, they are on PRN. So most of the patients are treat and extend.
So one question I wanted to raise, which Ritesh did, point out but didn't elaborate much, was about, he said that dry retina is needed for the best result and persistent fluid an issue. So there has been a lot of fluid debate kind of theory going on. So you see about fluid, what kind of fluid you would like to tolerate? Some subgroup people say dry retina is the best, and some say any stable SRF with stable visual acuity is good enough. So let's start with Ritesh. Your take on this, because you touched this point but didn't elaborate much on this fluid debate.
Another 10 minutes would have gone, sir, if I had gone on that.
yeah. And so, because this fluid debate was raised with aflibercept, in fact. That is the reason I thought I will raise this.
So personally, I don't like fluid. I would prefer to have a dry retina. Only in cases wherein I have, on a trial, seen that over drying has caused a drop in vision, that I have been tolerant of some fluid when that has come back, so that the patient maintains visual acuity. So as far as I am concerned, to call it a stable SRF, it has to have a stable vision over 3 injections, fluid less than 100 microns or 50 microns over 3 injections, and patient asymptomatic, a very tough call to get it in large percent of patients. So that's a very strict
So
criteria.
let me have, you see, around 7-8 people who are present here about this tolerance of fluid, because here is where the the new kid in the block, Rolsimab, shouts too much that eradication of SRF, even as sub RP fluid also. So how much fluid are you, like Ritesh said, ideally there should be no fluid. But very big but is, if the Ritesh said 3 visits or less than 100 micron, is it tolerable, or you want to try another drug? Ajay?
So what I
very
want
brief
to point
answer,
out,
very brief
brief
answer.
answer. I just want to point out 2 things, sir. We have to understand that in AMD, the origin of fluid is from the choriocapillaris and from the cellular destruction within the retina when it is an intraretinal fluid. I will not tolerate any intraretinal fluid. However, for a subretinal fluid less than 100 microns, I would tolerate, also because that if I make it totally dry, that's what I believe. I know you have been advocating totally dry retina, but this is my gut feeling that if we have a totally dry retina, we don't have long-term studies, the fluid probably acts as the nutrition to the area there. And if the nutrition is totally gone away, if the choriocapillaries are the only source of nutrition to the photoreceptors there, we are going to push these patients greater towards GA, geographic atrophy. And I think we have to lose out. So for me, a little fluid, I think, would be better. We don't really have long-term answers, but
AG and Dries, your take on this?
Yeah. My thing is I'll follow the guidelines what Ritesh has said, and second thing, I'll also take into consideration the patient complaints. If the patient says I am getting metamorphosia, the lines are not straight, I'll definitely go on to a switch with the other drug. So
I totally agree. I think the patient symptoms also are paramount. So I think less than 100 micron is easy to say, but we're not really going to sit with calipers at each visit. So I think
can you believe it? Nowadays patient can read his OCT. You see, before you go there, patient says fluid to high smell. Fluid to high smell. Yeah. So why are you not treating? That's another. I will come to Devulal because he has rich experience of using aflibercept also and the new kid on the block also. You have published a lot of data also. So what is your take on this, about this fluid vis-a-vis switch or not to switch, or do you tolerate that fluid?
All of us agree, like it's one is any increase in fluid is something that's I find ominous. The other thing is in our patients, it's very difficult to let go any fluid because most of these patients tend not to do well in the long term. But having said that, with aflibercept, I think the percentage of patients who are on a proper follow-up and proper injection schedule, they actually do very well. So with aflibercept or switches to aflibercept from other anti-VEGFs, so we have wonderful results. So I think, but personally, I don't like fluid of any kind practically.
Yes, Nishant, you were wanted to say something.
Just 2 points. One is that, I think all clinical trials have shown that a little bit of subretinal fluid at the fovea, whether it's CAT, IVAN, VIEW, is actually shown better vision than people who had complete dryness. Dr. Arora's point of RPE cell loss is very well thought out, and I think that's thought as a physiological response. The third question is, sir, that if you don't tolerate fluid and you're using Eylea, then the choice becomes that you have a drug which has got significant side effects and may remove the fluid, but the con side is that the side effect profile is something you've got to take on board with. So would you tolerate a bit of fluid or tolerate a bit of inflammation? The toss up between that, and I think I would always tolerate a little bit of SRF than rather a bit of vitreous cells. Because our options
let me, because time is running out, let me conclude this very exciting webinar. A lot of discussions, a lot of great presentations, and a lot of good cases. That as far as DME is concerned, all of us, I think, raised our hands that we should propagate that aflibercept becomes #1 drug in all these patients of non-traction central DME, and that I think everybody agrees toward that. And whereas AMD, what Ritesh said, treat and extend is the best kind of regimen. And again, the data of 60% and 60% Q12 and 40% Q16 That again is compelling, but very big but is you have to individualize the patient, talk to the patient, and because these are the patients ultimately who do very well with treatment extent kind of regime. Thank you, ladies and gentlemen, for this exciting, yes.
Thank you.
Thank
you.
Thank you.
Before we conclude, can we request all to please smile so we could take a
screenshot? Wait, Nikhil. One thing is there that you see this information about DME, it has to percolate down. And I'm re-stressing again and again that this has to percolate down. Why? Why all of us are shouting that this becomes number one for management of DME? And that can be done possibly with the help of Bayer Group, doing more webinars and doing a kind of survey that what is your treatment of choice today? Yes, Nikhil, all yours.
So one more thing, the VRSS survey had only 115 responders out of the 815 members.
Problem is it got published in IJO. It is published in IJO.
But it's a very small percentage.
Yeah, I agree, because publication is a different. Everybody starts quoting.
And last thing to say is that, one thing is we learned a lot about the role of ILIA and DME, but we also learned from Lalit Verma how to chair a meeting and how to moderate it. This is something I learned from him every meeting we have.
I try to bring out the best.
He's the ultimate.
Thank you.
With Goa behind him.
I request all to please smile as we take a screenshot in 5, 4, 3, 2, 1. Thank you so much. With this, we conclude the session. For the next session, we have Dr. Arvind.
Thank you. Thank you, Lalit. Thank you, everyone.
Thank you. Thank you, everybody, for great discussion.
Thank you. We have Dr. Arvindra Gupta, who is going to be the moderator. But before we move forward, let me also tell you this session has been supported by CIPLA, and we thank CIPLA for their unconditional support for this session. Over to Dr. Arvindra Gupta, sir.
Who else has joined in?
Sir, we are checking. Dr. Ritesh Narula is here. Dr. Saumil Seth is also with us.
And Dr. Chaitra. There are three speakers, no?
Yeah, so Dr. Saumil has joined in. You can see him. He's saying hi to you as well, sir.
Hi, Saumil. How are you?
Hi, sir. How are you? Can you hear me?
Yeah, I can hear you.
We are just going to be checking with Dr. Chaitra, but we can get started with Dr. Saumil in the meanwhile. We've got information. Dr. Chaitra will be joining at 3 p.m. So can I request Dr. Saumil Seth to please start his screen sharing and check if everything is okay?
I guess so. Is my screen visible?
It's just, yes, sir. But it's not in the presentation mode.
Yeah, that's okay. You want to give an introduction or something, or should I just begin my presentation?
I think Dr. Arvindra Gupta is going to be introducing the subject, and then we can get started.
Sure.
On behalf of CIPLA, I'd like to invite Saumil and Dr. Chaitra for this interesting session on what's the buzz on anti-VEGF biosimilar. CIPLA, now, apart from Razumab, we have multiple companies which are coming with anti-VEGF agents. And one of the companies is CIPLA, and other, along with Intas, is Reliance. So we'll be talking about our personal experience and the role of biosimilars, how we take new biosimilars into our practice, what are the side effects and the advantages of using these biosimilars in our practice. With this, I'll like to invite Dr. Saumil Seth. He is a prolific vitreoretinal surgeon at Bombay. He'll be speaking about will biosimilar find their place in retina. Dr. Saumil.
Thank you, Dr. Arvindra, for the kind introduction. I'm Dr. Saumil. I'm from India. As you can see the circle in the background. I'll be just loading my presentation now. Is my screen visible to everyone?
Yeah, you are visible.
Yeah,
screen is visible.
Yeah, I've just put on the presentation view. I think it should go on shortly. Okay, is that clear now?
Yes.
Yeah, so good afternoon all. I'll be giving a brief introduction about biosimilars and will they find their place in retina. It is actually a war of biosimilars that we have in India. We call it the attack of the clones. It's because clones are what biosimilars are. So you originally had the parent molecule and the horizon was absolutely wide open, nothing there on the horizon. And now the horizon is too crowded with a lot of biosimilars coming in. So let's see where actually the game of biosimilar clones actually began. You had the parent molecule, which we call Lucentis. It was actually the Rani of all Zumabs. Rani in India or in Hindi means the queen. So it was a queen of all Zumabs, which was manufactured by Novartis in Switzerland. And then the same molecule was sold as Eccentrix, manufactured again by Novartis in India. I will just come to shortly as to why it was sold under a different brand name. We had the first biosimilar, which was called Razumab, which was manufactured by House Intas. We then had Ranezurel, which was manufactured by Reliance. And now we have the latest in our armamentarium, that is Vizumab, which is manufactured by House Cipla. So as you know, the game of clones, or rather taking an analogy from the Game of Thrones, all of them have a certain sigil or a motto to their house. Let's see how each one's motto reads. Eccentrix, yes, made with Swiss precision. Obviously, it's made in Switzerland by Novartis, but it is priced like the Rolex. As far as Reliance is concerned, in India, we say we may be reliably unreliable, but we want to make money out of everything. In case of Intas, yes, we make it good when we make it first. And in case of Cipla, which is the last to enter the market, we make it good and we catch up really fast. So the bottom line behind all this biosimilars is that they are made in India. So we don't have to, we can do away with a lot of import duties. And you know that India infrastructure and labor is cheaper. So the bottom line behind manufacturing a whole lot of biosimilars is they're going to be cost effective. As against 6 approved biosimilars in US and 35 in the European Union, we have 68 biosimilars that have been approved in the Indian market. There are so many other biosimilars that have taken cue from this and are in the pipeline of getting manufactured by companies, as you can see here. So in this Zumba fight of the Zumabs, as what I would call it, what stands out more important than being safe and effective is cheap. So I have put cheap at the topmost priority as compared to safe and effective. Now, why so? Because in India, cost is a big issue. The government does not pay for the insurance for the injections most of the time. So does the insurance also does not give reimbursement most of the times. So in India, we say something is better than nothing. Rather than taking no injections or not affording a costly injection and going blind, at least we take up something. Let's see whether it measures up to those standards. So just giving a perspective onto the most important aspect, the cost effectiveness, and which is why the biosimilars are here to stay, is you see Eccentrix in Indian rupees is around 18,500, which would be somewhere around 250 to 300 US dollars equivalent. You know that is actually not the cost of Eccentrix. Abroad, it is sold at a much more expensive price by under the name Lucentis. It is around, I think, 1,500 to 2,000 odd dollars. So 5 times the price reduction and changing the brand name to Eccentric still won't measure up to its competitors, which are the biosimilars. So you have Razumab, which is 11,000 approximately Indian rupees, Reliance 11,000 rupees, similar. And now you have the cheapest one on the horizon, which is around 8,000 rupees, which is approximately 110 US dollars. So these companies have also introduced schemes now so as to compete with the most effective competitor in the market. Now, why is cost so important? Because unlike cataract, which we do one time, or LASIK, which we do one time, retinal diseases spring up time after time, and so do the injections. So in this presentation, I may have no financial interest for myself, but I have full financial interest of my patients. Now, if you consider diabetic retinopathy and you consider protocol S, we all know that when you give injections, your vision remains 6/6 as compared to laser PRP, where though your vision may not be altered quantity-wise, quality of vision suffers because of poor contrast and restriction of field of vision, which is the collateral damage associated with laser PRP. So the quintessential Mahabharata test, or what we call in India, if the patient were your mother or your sister, what would you actually do? Yes, I would definitely go for the injection therapy, because not only I want the vision to suffer quantitatively, my quality of the vision should also be unaltered. So if I take 9 injections in a year of a biosimilar at 8,000 rupees per injection, I would land up with 72,000 a year as expense, as against 9 of eccentrics, where I would land up with 171,000 per year. Obviously, it's more than a 2-time cost difference. So because of the cost effectiveness, I can keep calm and keep taking anti-VEGFs, or as a doctor, keep giving anti-VEGFs. As far as AMD is concerned, we had initially the fixed dosing interval regimen of monthly injections for 12 months, which was shown by the Anchor Marina trial. At the other extreme, we had fixed interval dosing at 2 monthly intervals, which was given by, let's say, 6 injections on average per year. You see the marked difference in the visual outcome. A 10 to 12 letter gain versus a -2, or a sheer maintenance of vision. If we cannot do with 12 injections on a monthly basis, we follow what we call as a middle path, where we have the treat and extend regimen, which approximately amounts to 9 injections in a year. If you consider the original parent molecule or eccentrics, that comes to 171K, which was similar to what we talk about in diabetic retinopathy. If you take a biosimilar, that is 8,000 per injection, comes to 72,000 a year. Again, less than half the cost. So in AMD also, as and when required, we can keep calm and keep giving anti-VEGFs. Let's come to the other two aspects, safety and effectivity. I'm taking them both together because they are something to do with the molecular structure of the biosimilars. Now, the biosimilar ideally should be a fingerprint match of the parent molecule. And this is a rigorous process because it passes through many stages. Unlike a generic molecule, which is nothing but a replication of the chemical formula, a biosimilar is a complex proteinaceous drug. You can draw an analogy by comparing a generic molecule with a cycle and a biosimilar with an aeroplane. So when you have biosimilar as compared to the parent, the necessary criteria should be that the primary structure of the protein should be similar, and validation technologies can confirm this. So from primary, secondary, tertiary, and quaternary structure gives rise to what we call as the final biosimilar molecule. If you have to again draw an analogy in layman's terms, primary structure is like the alphabets. If they are woven together in words, then comes the sentence, and then finally comes the paragraph. So where do biosimilars actually differ? Biosimilars differ from the parent molecule because of variations in their quaternary structure and also the configuration of the sugar molecules that binds them together. Also, there are certain additives which are added to keep the molecule stable, and that is where they actually differ. Now, based on these parameters, the configuration of the sugar molecules, the quaternary structure variation, and the additives, you can have various scenarios. The first scenario, and I feel which is a necessary scenario for the biosimilar to actually work, should be biosimilar should be equal in safety and efficacy to the parent. That simply means that the molecule has been replicated in a proper manner, and that is what we expect out of any biosimilar. So that's why I've called it scenario 0. Scenario 1 is where the biosimilar is better than a used parent molecule. It may be equal to the parent molecule in a treatment naive lesion, but when you have used the parent molecule over a long period of time, you will require a slight change in the molecular structure, and you will end up probably with the better effect. So when biosimilar is better than a used parent because of tachyphylaxis, that scenario 1 is where biosimilar scores over the parent molecule. Scenario 2 is when you have used both the molecules in the same lesion multiple number of times, and you yet feel that the biosimilar is better than the parent molecule, probably because of superior pharmacokinetics, it remaining in the vitreous cavity for a longer period of time, and so on. So that would be scenario number 2. Let me come to the scenario number 3, or the final one, where we call the molecule as a bio better rather than a biosimilar. This has happened in the past, as you see with these examples. So the new thing on the horizon now that these biosimilars have to look out for is how they can be bio better. When I say bio better, a naive injection of a biosimilar should be better in terms of efficacy and safety as compared to a naive parent molecule injection. With that, I conclude my session. Yes, biosimilars are here to stay. They will find their place in retina, especially because of the cost effectivity issue. Thank you.
Thank you, Somil. Your talks are always enlightening and entertaining. You put on so much effort in your talk and make it so interesting. Two questions. Are you using Visumap in your practice? And what's your experience in regards to that?
So I have used quite a bit of Vizumab now. I think I may have used over 50 odd injections. In fact, I have done even retreatments of patients with Vizumab injections, and my experience has been really good so far. Side effect wise, I haven't found a single case of even minor post-operative inflammation as of now. As far as effectivity is concerned, probably it is a bit too early to say how it will fare in the long run, but the early reports are very promising. The result that I expected Vizumab to have akin to the parent molecule, that is Eccentrix, I have found those effects to be there.
I'll share my screen and give my talk, and then we'll come to the discussion.
Sure, sir.
Yes. Can you see my screen?
Not
Can you
as
see?
yet.
Yes, sir. It's clear. You can go ahead.
Yeah. I'm Dr. Avnindra Gupta. I'm practicing as a vitreoretinal surgeon in Delhi and Faridabad. I'll be talking about biosimilar facts and myths. What Somil has told you, biosimilars are a complex molecule and a sequence of amino acids. And that's why if you have a sequence of amino acids or a monoclonal antibody, then you will have a large molecule which will be very difficult to produce in comparison to a generic molecule like aspirin or ramipril, which is a chemical compound and is easy to manufacture. Now, before starting this, you have to understand what are biologics. Biologics are recombinant therapeutic protein. That means it's a sequence of amino acids that prevent and treat or cure disease. So, uh, if you have a sequence of amino acids that cannot be produced by in a chemical mode or by a factory, it has to come by an cell line, that is an E. coli. So, a vector is introduced into the cell line, and the cell line produces the sequence of amino acid or the required protein, which is then purified. Biosimilars are a biologic that is highly similar to the reference product with no clinical meaningful difference in terms of safety, purity, and potency. If you see ranibizumab is an Fab fragment, has a molecular weight of 48 kilodalton, has a dose of 0.5 milligram, and if you see it's a Y-shaped monoclonal antibody which has two Fab domain and two FC domain, and the this variable segments bind to the CDR cells, which are the receptors on the retinal pigment epithelium, and they block this CDR cells, causing an anti-VEGF effect. So once these CDR cells are blocked, the normal vascular endothelial growth factors are not able to bind on the CDR cells, thus causing giving the desired effect of anti-VEGF. If you see how the biologics are prepared, the gene of interest is created. The gene of interest is introduced into the vector. In this case, the vector is usually bacteriophage. A cell line of E. coli is there. The vector, the bacteriophage infects the E. coli cells, and these E. coli cells are grown into an culture media, and because of this gene, it secretes antibodies or the cell proteins which are secreted into this culture media. Now, E. coli cell line is different from the innovator product. So here is the one difference. The second difference, what Saumil pointed out, was upstream and downstream purification are different for different companies. And this is where the immunogenicity or the factors or the purification of the whole cocktail, which is released by this E. coli into the culture media, is done. This is somewhere around 64 processing which is done, where the impurities are separated, and we get the final product of anti-VEGF or the antibody into a small vial. The major myth about biosimilar is approval process, the evaluation of similarity, naming the new biosimilars, issue related to safety and immunogenicity of the biosimilars, scientific rationale for extrapolation of data across clinical indications and interchangeability. Coming to the myth, the reference of the product and biosimilar are different. Biosimilars and originator products are almost similar till the quaternary molecules. The primary structures between a biosimilar and the reference product are almost same. And if we see this peptide change and analysis from the innovator molecule Lucentis to the biosimilar, you can see the peptide chain are almost, the spikes are almost similar. It's almost the mirror image of the innovator molecule. So the fact is the primary structure of a biosimilar is almost identical to the reference product, as the amino acid sequence influences the clinical properties of a biological product. The difference of from the innovator product is the cell line of E. coli is different, and the upstream and the downstream purification process is different. Immunogenicity is not extensively assessed as part of evaluation of potential biosimilars. All biologics, including biosimilars, may elicit an immune response. Monitoring immunogenicity is an important part of a clinical program and post-approval assessment of biosimilar. If we see the incidence of inflammation in cases of ranibizumab, if you see in Marina trial, the inflammation was 2.6. In Focus, it was as high as 11.4%. So the original molecule can also cause immunogenicity or sterile inflammation, which can mimic like endophthalmitis in initial phase. This is a study from ophthalmic epidemiology where severe ocular inflammation following ranibizumab or aflibercept injection for age-related macular degeneration, a retrospective claim database analysis was done, and they found that the risk of severe ocular inflammation following treatment with ranibizumab or aflibercept was low. That was 0.64 events per 1,000 in ranibizumab and 1.06 events per 1,000 injection, meaning thereby any biologic, whether it's an innovator product or it's produced by another company, can cause an sterile inflammation. So no biologic is absolutely free from sterile inflammation. This is an ASCRS report where they have reported spikes in aflibercept inflammation. And from May 2017 to February 2018, 143 cases of inflammation associated with aflibercept was reported to American Society of Retina Specialists. In 13% of these cases, patient lost at least 2 lines. So you can see with ranibizumab, there was an inflammation. With aflibercept, also there was an increased incidence of inflammation at different periods of their process till date. So every batch has to go for the test why there is an inflammation in this batch or the previous batch. The newer brolucizumab, the ASARS to its member concerning 14 reported cases of vasculitis. After brolucizumab injection of those 11 were designated as occlusive retinal vasculitis. There was an 4% percent patients developed intraocular inflammation, and 1% of the patient developed retinal artery occlusion in Hawk and Harrier trial. So the fact is all biological, whether it's ranibizumab, bevacizumab, aflibercept, or brolucizumab, can show inflammatory reaction. So don't worry whether you are using biosimilar or the innovator molecule. Every molecule will show some kind of inflammatory reaction. Initially, when some of the biosimilar products were introduced into the market, we had inflammatory reaction, and there was a lot of hoopla about this inflammatory reaction. But gradually, over a period of time, all the companies has developed, and we have not seen any major inflammatory reaction, whether it's with vizumab or razumab or ranazurral biosimilars. Cipla has launched a biosimilar with the name of vizumab, and this is biosimilar ranibizumab. Our experience is we have used in 12 cases. These were a combination of AMD, DME, and BRVO. Our early experience showed that there is no evidence of post-injection inflammation, and there was a resolution of edema comparable to other biosimilars. We have done a study which we call as a CSER study, that was clinical efficacy and safety of ranibizumab. That was another biosimilar with Intas. Our experience with world's first biosimilar. In this, the study design was the primary outcome was the mean change in visual acuity and central foveal thickness from baseline to 1 to 3 months. The secondary outcomes were safety of the drug and systemic adverse event during any of the follow-up visits. It was a single-center retrospective study at Center for Sight between October 2018 to September 2019. Institutional Ethics Committee approval was obtained. Both treatment naive or previously treated with other anti-VEGF steroids or laser therapy were included in the study. Patient with less than 3 months follow-up, dense cataract, corneal opacity, ocular inflammation, previous vitrectomy, uncontrolled glaucoma, history of MI and CVA were excluded from the study. If we look at the results, the number of patients enrolled were 153. The injections given were 231. And there were treatment naive patients were 121. The previously treated patient was 32. The mean logmark CDVA of all the indication improved significantly from 0.62. This is 0.62 to 0.42 at the end of 3 months post injection, and the p-value was highly significant in this patient. If we see the central foveal thickness was observed from 405.68 microns at baseline to the end of 3 months, it was 271. So this was also statistically significant, proving our point that biosimilar has a good effectivity in all the disease like AMD, diabetic macular edemas, and branch vein occlusion. This is the same result on bar chart. You can see the starting vision. In all the patients, the vision improved over a period of time at the 3 months interval, 0.6 to 0.32, 0.64 to 0.55, 0.49 to 0.21. And the central foveal thickness, if you see, has reduced dramatically in all groups, DME, CNVM, and retinal vein occlusion. Because of their lower cost, biosimilars reduces the healthcare cost, more accessible and are affordable. Biosimilars have advantage in developing countries like India, where insurance companies do not reimburse for anti-VEGF agents and compounding pharmacies are rare. So the use of Avastin is lower as compared to, or because of the incidence of cluster endophthalmitis, the use of, we are worried about using Avastin. Insurance company can have significant saving of 15 to 20% due to multiple injections. And government can save on health expenditure too. So to conclude, biosimilar ranibizumab is safe, effective, low-cost therapy in patients with chorioretinal vascular disease, such as diabetic macular edema, CNVMs, and macular edema secondary to retinal vein occlusion. The data showed a rapid improvement in CDVA and central foveal thickness in most of the eyes, with efficacy observed as early as 1 month and maintained till 3 months. The drug was well tolerated with no new safety issues over a period of 3 months. Thank you very much for your kind attention.
Thank you so much, sir. Just to let you know, we've got Dr. Chaitra Jayadeva who's joined us.
Hi, Chaitra.
Hi, how are you?
Any questions from the panel about?
We don't see any questions from the audience, though. Dr. Saumil, do you have any question?
Hey, Dr. Abnendra, your presentation was excellent. Just for probably the knowledge of the audience, I would like to make a statement. Is every successive batch of the parent molecule a biosimilar of the originator molecule or not? Let's say we manufacture Lucentis and every successive batch of it manufactured, is it similar as a biosimilar to the original Lucentis molecule, or is it any different?
I think it should be similar. I don't have a definite answer. That company should be able, because I think why it should be similar to the originator molecule, because the gene, the cell line, because they have a controversy, they had some inflammatory reaction. When they were producing in Switzerland, their product was different, and when they were producing in US, the efficacy was slightly different. So cell line and the conditions also makes a huge amount of difference in the efficacy of the drug.
Okay, no. So what I meant to ask was, if the originator molecule batches are also biosimilars of the originator molecule themselves, then we are quite justified in using biosimilars in the Indian context.
I think that's the idea, Saumil. They do make it, but what happens is during the manufacturing process, initially when we were using Razumab, we had certain issues wherein, we were not having the same, the cell line would be the same, but I think some of the manufacturing processes, the other reagents that they use has brought about some changes. And then there were a lot of discussion, I think, only about immunogenicity, and that also is very specific to, I think, an individual. It does not apply to everybody, whether you're forming the antibodies or not. So most of the reactions or most of the issues that we had initially were due to that. But ideally, the process of biosimilar manufacturing is that it is not a copy, but it's very similar. And the idea is that the sequencing is the same.
With this, I'd like to invite Dr. Chaitra Jayadeva for her talk. Dr. Chaitra does not need any introduction. She is a senior consultant at Narayan Nethralaya and Joint Secretary IOS and also an executive member of Vitreoretinal Society of India. Dr. Chaitra, with your presentation.
Thank you, Dr. Abnendra. Today, basically, I'll be speaking a little bit about the other new biosimilar that we have, which is Vizumab. We've used it in a couple of patients, not too much experience, but we have some because we got the drug a couple of months ago itself. So here's my talk on that. I will be talking about the evidence and the initial experience that we've had with this new biosimilar. I have no financial disclosures. Now, what is Vizumab? It is a ranibizumab biosimilar. The indications so far that's being used or it's being approved for are for neovascular EMD. So what is the evidence that we have? What is the phase 3 study that has been done? The study's aim was to evaluate the efficacy and the safety of this biosimilar in patients with neovascular AMD. The study period was between July 2018 and November 2019. It was conducted across 16 centers in India. The study objectives were primarily to look at the efficacy of the intravitreal injection in basically preventing vision loss as determined by the proportion of patients who lost fewer than 15 letters in visual acuity at week 16 compared to the baseline. And the secondary objective was to evaluate other efficacy parameters, the immunogenicity, the safety, the tolerability, till up to week 24. So the inclusion criteria were all active, primary or recurrent subfoveal lesions with CNV secondary to AMD in the study eye. Both genders were included of 50 years and above, and the BCVA using ETDRS of 2040 to 20 by 320 in the study eye were included. There were, of course, several exclusion criteria, including previous PDT or TTT or subfoveal focal lasers, even juxtafoveal or extrafoveal in the study within 1 month prior to the randomization, uncontrolled glaucoma, intraocular surgery, recent or any concurrent intraocular condition in the study eye with a history of any idiopathic autoimmune associated uveitis were excluded. Of course, endophthalmitis in either eye was a major exclusion criteria. Coming to the results, now the proportion of patients who lost fewer than 15 letters in visual acuity at baseline was comparable with the innovator. If you can see here, this is between the biosimilar and the innovator. It was comparable, and the difference was from baseline to week 16 and week 24, not statistically significant between the two treatment arms. Now, going on to the secondary outcomes, the change in the central macular thickness that was assessed on OCT itself, the difference between the two treatment arms again was not statistically significant either at week 16 or at week 24. So this basically shows that the reduction in the central macular thickness was quite comparable between the two groups. Now, going on to the safety assessment itself, the safety profile of this biosimilar was in line with the safety profile of the known innovator ranibizumab. No subjects had to be discontinued from the study due to the treatment emergent events. The immunogenicity assessment was also done. All samples were analyzed in the study, and they were negative for anti-ranibizumab biosimilar antibodies or anti-ranibizumab antibodies itself. So there was no apparent immunologically mediated safety or efficacy concerns reported in this study. So now going over to our initial experience, this is a 76-year-old male with decreased vision in the right eye of 6/12. The left eye had poor vision due to long-standing macular hole. This was his scan on August 2021. You can see the PD, you can see the SRF as well. In 1 month of the follow-up itself, the patient's vision also had improved. The quality of vision had improved. You can see a collapsed PD with the resolution of the SFD. The patient was advised 1 more injection, but he's lost to follow. There's another patient, 72-year-old female, decreased vision since 1 year, CNVM with bleed. The first Vizumab was given on 16th August 2021. We wanted to have a close follow-up. So this is the first visit scan, 6/120 vision. This is on August 16th. We called her on August 24th, and you can see the difference already. The intraretinal fluid has come down. Subretinal fluid also has come down quite significantly. The vision improved to 6/96. And by the second injection follow-up of September 22nd, you can see the disease is stabilizing with the vision at 6/75. This is the third case, 52-year-old female diabetic, decreased vision in the left eye, 6/9. This was a presentation on October 2021 with a PAD, SRF, and SHREM. On 10th of November, the patient underwent an intravitreal Vizumab. This was on follow-up on 24th November, about 2 to 3 weeks later. You can see resolving PED, SRF, and the SHREM. The vision had also improved to 6/6. So to conclude, the USP of this particular drug is the efficacy and the safety has been proved. It is a single-use vial, it is affordable, and it is DCGI approved as of now for AMD. And importantly, it comes with an entire pack, where including with an Amsler's grid. So it becomes like a standalone pack for private practitioners or medical retina practitioners to be able to use it. So to conclude, Vizumab has comparable efficacy profile with that of the innovator. It also has no significant adverse events when compared to the innovator. The safety profile during the study for Vizumab was in line with the known safety profile of the innovator. The immunogenicity samples were negative, so there was no major concerns as far as the immunologically mediated issues go. And Vizumab therefore can be considered as an alternative to the innovator ranibizumab. And thank you so much.
Sir, please unmute yourself.
Thank you, Chaitra, for your nice presentation. I'd like to ask to the panel, how do you go ahead and counsel your patient? Do you tell all about the biosimilars, what are available in the market, and you tell the innovator product, and you also tell about the idea? Or how do you proceed in for counseling your patient once you have a treatment naive patient with you?
So I'll go first. Basically, we have counselors actually doing the job for us. Not necessarily that we'll be counseling, but what happens after whatever the counselor has told them, they'll come back and tell you, doctor, you tell me which, because they finally have confidence with the doctor. So this is where I think it's a little difficult for us to take a call, because it's not easy for them. We need to keep in mind their financial situation, the fact that some of them are even one night. So I basically weigh the pros and cons. I put it on the table. The difference is because of the R&D. The difference is because of the company that's producing it. Actually put it on the table and say, like, for example, supply is manufactured here, the drug is made here, so that's why the cost is a little lesser, because it's a biosimilar, which is a copy of the innovator. Therefore it's probably cost less, because their primary question is the more expensive drug the more effective or the more safe? That's their primary question. Unlike in a cataract where you go for a premium IOL, I don't think here it's about that sort of premier that we're talking about. We're talking about efficacy and safety, and I think finally also the durability, how long you can keep the patient between injections. And that I don't think we can still say with super confidence for any one particular drug that we have right now. So it plays all these facts on the table, and then I think I just encourage the patient to take the final choice, because I don't want the patient to come back later and say, you asked me to take this drug and now I'm not responding. It should finally be their decision based on the facts that we're giving.
Saumil, your answer to this.
Yeah, so continuing from there,
one point Chatra very nicely mentioned. A patient has a concept ki costlier the drug, better the action, and one drug will work for them. So you have to put into the mind ki it's not the cost, the effect will remain the same, and costlier drug does not mean ki one time you will get a permanent result. Saumil, how do you counsel your patient?
So I think Chaitra has very clearly explained how she would go about counseling. I'm going to take it a little bit further from there. So she ended with, okay, the patient should not come back to me and say that the drug has not worked. I will say this upfront to the patient, that if the drug does not work, it does not mean it's because it's a biosimilar. If it has not worked, probably the parent molecule or the original molecule will also not work. In your case, your disease is of a different kind, and probably we'll have to switch you on to something. So she mentioned something about going less expensive from expensive. I would like to go absolutely the reverse and take a cue from the Avastin or the bevacizumab that is sold in India. So that is the other side. It's the cheapest molecule available. I would tell the patient to go one step up and avoid all the potential side effects that comes from giving a molecule that is multi-allocated and given as a multi-divided in multi-divided ways. So they have potential side effects in terms of safety. They have the chance of infection more than this. So if they can stretch their budget just up a little, they can have absolutely the same safety as what the originator molecule would enjoy. So it's a win-win both ways. You're compensating for an over expensive molecule. At the same time, you're giving a patient a step up from a less safe to a more safe molecule.
Do you consider the patient profile into the consideration whenever you are advising which molecule to go on? Like some patient says, no, मैं तो महंगा वाला लगवाऊंगा. But do you then counsel seeing the profile of the patient, you say no, go for the cheaper one because the number of injection matters more as compared to the cost of the injection?
I think patients for me are two kinds. Either the ones who have insurance or the company pays for them, or the ones who are paying out of their pocket. And I think the ones who are paying out of their pocket also, initially when they come in and they don't realize the extent of the disease requirement, most of them do tend to opt for the more expensive or the innovator molecules. And I know eventually their enthusiasm wanes off once they start realizing, mujhe abhi aur lena padega, you know, every month I'm going to be needing it. Then they come down to the stage like, just give me the safe drug. Give me a drug that you know is going to work and is safe at the same time. It doesn't have to be the most expensive. So the enthusiasm I have noticed started coming down. There are very few people with, say, for example, PCV, wherein I actually insist that, you know, go for the higher molecule because your success rate for the disease is much better. Other than that, I really don't push them based on their financial, you know, situation or the profile.
Saumil.
Yes, so I agree completely with Chaitra. The important thing here is that approximately from the disease, we'll know the number of injections that the patient will have to take. When I say number, I do not mean 5 or 6 or 7. It's like they'll require more than 2 or 3 injections for sure. And if that is the case, I tell them beforehand that this is approximately the budget that you're looking at in terms of the multiplicity of injections. So it makes more sense to take multiple cheaper injections than take one expensive injection and can't afford the remaining, because the duration of effect of all the injections is the same. So that goes down very well with the patient.
So you explained to like AMD, it's a practice that we explain to all our patients that 3 doses are mandatory. So in both in branch vein occlusions and in diabetic macular edema, do you counsel the patient for the concept of loading dose or you say PRN basis?
So it's mostly for, other than AMD, I don't practice loading doses for anything. It's only for AMD because somehow I feel with the loading doses, their disease stabilizes much better. And even the recurrences or the severity in which they come back is not as bad as one who has taken one injection and then disappeared. Of course, with COVID, we've had major issues, but now things are settling down. So for RVO or DME or for that matter, even myopic CNVMs, I hardly ever do a loading dose. Myopic CNVMs wonderfully resolve with just one injection. And these patients tend to know the minute something is wrong, they're back. And even if you can't see it clinically, you already know that they're going to need the injection because the patient is symptomatic. So I think other than AMD, no loading at all, none of the others, but clear explanation, clear message has to go to them. They're so used to cataract, like it's a one-time thing. They're like, okay, after this injection, I'm going to be fine. No, we are not replacing anything here like a cataract with a lens. So this is a disease pathology and we don't know the timeline for each patient. So that is something I make them understand. Takes time in the first visit, but I think by the second and third visit, they more or less resign themselves to the fact for repeated injections.
Saumil, what's the practice in Bombay?
So it's very similar. I think Chaitra, every time she answers, she reduces most of my works. I have just a few points probably to add. So yes, the loading dose concept applies in my case also only as far as AMD is concerned. It does not apply as far as BRVO, CRVO, DME, or even myopic CNVM concerned for that matter. The other important aspect that I highlight even in the loading doses is that if they have a certain amount of budget set aside for an injection, and if I give them an option, if you want to go for a very expensive one because you heard good about that injection or because it's an imported molecule, even you can opt for the second or the third injection to be a cheaper molecule because they are for maintenance rather than, you know, probably the loading. And I tell them upfront that if you feel your first injection has given you a drastic effect and the second and the third haven't, it's not because you've downgraded your molecule, it's actually for maintenance. Because they sometimes feel that because they switched over to a cheaper molecule, the effect has actually lessened. The wow factor, the 70% improvement that was there in the first injection, doesn't roll over onto the second and the third injections. So this is very important to counsel, because after the second injection, then they'll want to switch back and they'll probably blame you that you've not given me the right injection.
Very, very, very valid point, Saumil, what you have brought in, that wow factor comes with the first injection, not with second and third injection. And that should be the important point of counseling. Many patients says after second, third injection, I didn't get any benefit from the second and third injection. But we have to tell them the graph that it goes up like this and then it maintains itself. Coming to
I
the
have one
switch.
question. sorry, one question.
Yeah.
Do either of y'all switch drugs during the loading dose itself? Now, we don't see a wow factor always with 70% in all our patients. Unfortunately for some of them, even the first injection itself doesn't, even in a treatment naive, doesn't give you the wow effect. So do you switch over right from the second injection of loading dose itself?
I don't switch. Whatever I start, I continue with that drug, and until unless I'm convinced that this drug is not working, then I'll go on for the switch. So initial my counseling is he will continue with the same drug over a period. Many patients over a period of time tell me that they are not able to afford, and then they want to shift to a lower molecule or the cheaper molecule. Then yes, I'll shift them to a cheaper molecule. 2 or 3 of my patients whom I shifted from eccentrics to Razumab, they consider the cost factor. They shifted back to eccentrics and they said ki the kind of benefit what I am getting from eccentric, I am not getting from a biosimilar. These are only 3 patients in my long list of anti-VEGF where they have complained that I'm not getting the kind of benefit what I used to get. Maybe that's one of the costing or a concept that the drug which comes from outside is a better drug as compared to our preparation.
That's our mentality. We like everything foreign.
Yeah.
We like everything imported. Just like IOLs, everybody's like, is the imported drug better?
Yeah.
Saumil, what do you do? Have you ever switched over to a new drug, another drug during loading?
Yes, I have. And the major determining factor is the cost again. It's the cost that actually drives the remainder of my injections. The second important factor being the fact that if upfront with the first injection, I realize that the effect hasn't been that great. I'm talking especially about cases of DME where I'm changing the molecule altogether, may not be the molecule in the same category, maybe another type. I would want to switch either during the second or the third injection. So I'm not very stringent as far as the loading doses are concerned. As long as I see an effect, I will like to continue with the same molecule. But if I don't see the desired effect, which is very subjective again, it's based on a lot of parameters, and probably that discussion is an altogether different tangent. So I would like to say that if I don't see the desired effect, yes, I would switch.
Now, fourth question, what I like to, how do you make your decision to switch? Switch to which molecule? Switch to the innovator molecule or switch to a different molecule? So that's my question to both of our panelists.
So that's actually a little difficult. It's not a choice between innovator and biosimilar really. It's about the efficacy. If somebody is not responding to a particular drug, I will switch to anything else they can afford. That's number one. And the second reason for a switch would be financial. So non-responsiveness and financial constraints. Those would be my two. Unfortunately, so many times we've even upgraded or gone to a higher version molecule by the innovator, and it's not been an assured success, because then the patient comes back to you and say that, you asked me to switch to a more expensive drug, but it's not given me the expected response. So need to be very careful when we actually even doing the switch, need to explain to them that just because it's a more expensive drug, it doesn't mean that you are going to respond.
No, have you switched from the biosimilar to the innovator molecule anytime?
Yes, many times. And I write it there to my counselor saying that the patient is not responsive to this. Please consider this. And even when we're writing to the agencies, whether it is CGHS and ECHS and ESI, they are giving, right now they're only approved for biosimilars. But many times when a patient is not responded to a biosimilar, when we write a letter and say that this patient, despite 3 injections or 4 injections, has not responded, kindly give the innovator, they do give approval. So that option is there, and it helps.
No, do you find the difference once you have made a switch?
Yes, of course. Of course. See, we also have tachyphylaxis. After some 7-8 drugs, I think we need to shock it with another molecule. So it does make a difference. They have responded. Patients are very happy.
Saumil?
So that's correct. Unfortunately, I cannot write a letter. I'm not in an institute. So if I have to switch, so either they switch the drug or they switch the ophthalmologist in my case. So we are private practice, and this is how the thing is. But for me, it's more of a switch into a different molecular class altogether. If I'm using ranibizumab, I may switch to aflibercept. If I'm using ranibizumab, I may switch to a steroid, and so on and so forth. But switching between biosimilars and the parent molecule solely depends upon the affordability of the patient.
Saumil, you raised steroids. Now, are you combining steroid with anti-VEGF in many of the cases? Like if you give IVTA with anti-VEGF, then it might increase the duration and can give a wow effect. And patient with a very small amount to pay will have a longer duration of action, especially in pseudophakic patient and post-operative patients. What's your experience in that?
Yeah, so a combination would be my go-to alternative if either one of the molecules hasn't worked. Usually it's the anti-VEGF that hasn't worked, and
No,
it's a combination
do you
with
combine
steroid.
anti-VEGF with steroids?
Yes.
In single injection?
In a single injection, I will combine triamcinolone acetonide with any of the anti-VEGF injection in the proportion of 1:1 and then take 0.05 milligram. That comes to only 1 milligram of triamcinolone, as against most of the people who tend to give 2 milligrams. But 2 milligrams would probably, go to 0.05 if you take the steroid alone and not combine it with an anti-VEGF. In my practice, I found 1 milligram to be of good efficacy without causing significant side effects. So this is what I usually go to if my anti-VEGF does not respond. But then it still depends on the situation. And like you said, post-operative pseudophakic patients, yes, they are more amenable to be treated by triamcinolone. The same applies with refractory or probably large diffuse diabetic macular edemas or chronic CRVs. These are my go-to indications for switching or combining steroids with anti-VEGF injections. In fact, I would combine them right in the beginning. If I have a diffuse diabetic macular edema more than 2 disc diameters with a huge neurosensory detachment, I know for a fact the patient is going to run out of patience in taking those 5-6 injections if I don't switch.
Actually, it's a very not many webinars, not many people commit to this. They combine steroids with anti-VEGF at very first go. In my practice, do quite a lot of mixing anti-VEGF with steroids, especially in vein occlusions and post-operative diabetic macular edemas. And I can tell you it works wonders. And other advantages, you give a period of 3 months to 4 months, where the patient does not have to take any injections over a period of time. And the edema settles down drastically and dramatically and gives a wow effect. Chaitra, your take on that?
So since we're discussing primarily on AMD, I have used a combination of IVTA with anti-VEGF for patients with very large cystic degeneration or cystoid degeneration. The ones with large chronic CMEs, which are just not going, it's worked wonders. There is one patient, he's one-eyed. He comes every 2.5 months. Even if I tell him, no, let's just do the anti-VEGF, he wants the IVTA because he's not only looking at the response on the OCT where, all the cysts just disappear, but his quality of vision. His vision doesn't ever get better with 618. He stands at that, but his quality is so much better. He feels the blurriness, the dysmorphia, so everything is all good. So he's very happy. So I've been using it actually steadily for about 3 or 4 patients. It's a last-ditch effort for. Sorry, it's a last-ditch. I need to use it. Only then I use it. Otherwise, more often it's anti-VEGF, but in combination rarely.
Yes, Soman. Yes.
Yeah, Chaitra, just on that note, will you be ever able to say with a certain amount of surety whether it's actually the anti-VEGF working or it's just a steroid that is working?
So without the steroid, I have never given this patient a steroid alone, but the anti-VEGF never worked somewhere. So given the fact that I don't actually see a lot of subretinal fluid or RP fluid, it's primarily intraretinal fluid. But what happens is this is AMD. We know that the main thing here is VEGF, as against DME and RVO, where we know it's inflammatory and the IL-6 and IL-8 might respond. I have not, and he's also not ready to just go ahead with an IVTA. He knows that anti-VEGF is required. But somehow he gets so much better with the IVTA, he's okay to take it.
And actually, I don't prefer IVTA and AMD patients. Whatever my patients are, DME and vein occlusion. The second thing is ki when do you tend to repeat IVTA if you are using IVTA? What is the duration? When do you tend to repeat IVTA?
Whenever the edema is back, whenever I think the disease comes back, whenever we call the patient back, if I've been continuing and he's responding to IVTA, I don't usually hesitate. It's not like it gives you longer duration like a DEX. IVTA sometimes disappears in 2 weeks. That's why it's so unpredictable. Sometimes it's there for 5 weeks. I've seen it, some crystals lasting till 5 weeks. Sometimes I see a patient in 2 weeks to check IOP, it's gone. And it's not even like a vitrectomized eye, probably liquid vitreous. So it's a little, the problem with IVTA, though it's a fantastic drug, unpredictable compared to the DEX.
But in my experience, it works for somewhere between 10 weeks to 12 weeks. The effect is good. Saumil, what's your experience?
Yes, so 4 to 6 weeks is what I would put it on an average. I wouldn't stretch myself by saying, yes, some people it has worked beyond 6 weeks, but I do not know whether it's a disease pathology itself or the continuing effect of the steroid. I wouldn't say. The same is with Ozurdex. If you see a steroid implant, it also has a very variable, unpredictable effect. It can vary from anything between 2 to maybe 6 months. So what they claim is not actually what turns out to be true in the real world, as what Chaitra said. So yes, I completely agree with her. And yes, I would keep it variable. I would just bank on my follow-ups to see whether they require it more or not.
And when do you tend to repeat an IVTA?
You're asking, I said 4 to 6 weeks on an average. But yes, it depends on the follow-up scan of the patient and the visual acuity.
My problem is ki if I tend to, what my experience is ki I generally tend to repeat at an interval of 3 months. And if I give an IVTA after 3 months, few of my patients have landed with a sustained rise in intraocular pressure. So what I do is I give it, I don't repeat IVTA at 3 months. I repeat at 6 months. Meanwhile, that period of 3 months, I give only plain anti-VEGF. And why I am doing that? Because if you see the Geneva trial and if you see the pressure graphs in DEX implant, you will see there is a spike of intraocular pressure which comes somewhere around 8 weeks and tends to decline by 4 months. That was one of the reasons why DEX implant was recommended after 6 months. So because if you give it 3 months, the intraocular pressure will keep on rising and the patient will land up with an intractable glaucoma, or you will need multiple drugs to treat that patient. So what I am practicing is I will repeat IVT at 6 months, not before 6 months. And
but it never lasts that long, never lasts. In fact, for that matter, even DEX doesn't. And given the number of patients we have given DEX to, nothing lasts more than 3 months. And even if there is a raised IOP, I don't think we can prevent it by giving it once in 6 months. I think they are more steroid responders. So whether you've given it, at 3 months or 6 months, they are going to develop glaucoma if they're steroid responders. So what we do routinely is, for the first time patient, we're giving an implant or an IVTA. When we're not aware, we do a glaucoma check to see whether they have pre-existing glaucoma at all. And if they don't have glaucoma, 2 weeks follow-up to see if there's any spike. If they're pre-existing glaucoma, we actually have our consultants telling us to go ahead if we don't have an option. They say they're well-controlled glaucoma patients on topical anti-glaucoma medications. We're still giving steroids and they're doing well. So I wouldn't space if I'm giving steroids 6 months. I don't think it helps much for any of the conditions, let alone AMD.
With DEX implant, what my experience is ki the recurrence occurs at 10 weeks, that is 2.5 months. And my basic problem with DEX implant was the recurrence was more than the baseline edema. If the baseline edema was somewhere around 300, then the recurrence occurs to somewhere goes down to 400. So the vision decreases from the baseline once the recurrence occurs with DEX implant. And that is not the scenario with IVTA. And IVTA, I think you will not find the IVTA molecule or the crystals of the IVTA inside the eye. But with multiple studies, we know it works for somewhere between 10 weeks or so.
Saumil, what has been your experience? Do you also space it as much?
No, I don't. I said 4 to 6 weeks would be
Yeah,
my
that's
average
all.
time.
For IVTAs, 4 to 6. For DEX, 3 to 4 months.
It will be 3 months. Even for a Nosodex implant, I have never seen most of the implants going beyond 3 months.
Yeah,
That's true. If the disease pathology has come back in a big way, I will repeat it at 3 months. And I'll say sorry to the patient probably, but I have primed him probably even earlier on. If the disease does not come in a big way, I will wait till that time when the visual acuity drops significantly, when I feel I can go in for the next Nosodex implant.
Any more
What
questions?
has been your, have you do any of you all have used Vizumab so far?
Yes, I have. I've used over, I think, 50 or maybe 60. I've lost count after a few Vizumabs, and I found the results to be very encouraging. For me, it is my go-to substitute for bevacizumab. So it's not the other way around. Yes, obviously it has substituted Eccentrics also in a big way, but yes, it's my go-to substitute for, because the price, the purchase price is really, really reasonable, and I think the patient can take that extra step for safety.
I have used somewhere around 15 to 20 vials. The results are comparable.
Absolutely, yes. What
And
about
I think
you, Chaitra?
I just presented a couple of cases. I don't think I have any treatment naive patients so far, but though of course it's only approved for AMD, so I only put up AMD cases. It's fantastic results for DME. Very recalcitrant, DME done absolutely well. I have the cases, though of course I've not put in the PPT. Hard exudates with cross CME. Doing very well. So, I'm of course, it's still new. We don't have too many months of experience, but I'm hoping, that we come out with more numbers. At the end of the day, I think in our country with less access to healthcare and insurance, we have no option at the end of the day to look towards. And we obviously will wait for, biosimilars of higher molecules as well, because we need to treat more and more AMD patients. With DME, I think we're kind of sorted with the biosimilars and the steroids, but for AMD, I think we still need something stronger to go with.
I think Sun is coming with, and there is a biosimilar of Aflibercept which is in pipeline, and maybe within 6 or 8 months we'll be seeing that molecule coming into picture. With any other suggestions or comments from any of the panelists? With this, I'd like to wind up for a very interactive session. Many times we don't have so much of interaction, but thanks to Cipla that they have given us so much time to interact and bring out finer points. Thank you, Chaitra, Saumil, for sparing this time and making this session very interactive.
Thank you, Dr. Avninder. Pleasure to have been part of the session, and extremely good points and questions that you brought forward and made it more interesting for us on a Sunday afternoon. Thank you all, and thanks, Cipla. Thanks,
Before we close, can I just request all to please smile so we could just take a screenshot? Here we go in 3, 2, 1, and thank you.
Thank you. Bye.
The next session would be starting in the next 15 to 20 minutes. Thank you so much. I request everybody to please stay logged in, and as we will get started in the next 20 minutes. Thank you. Dr. Sujata, you can test your presentation.
Yeah, I'm doing it. Just give me 2 minutes.
Can I also check mine?
Yes.
Dr. Sujata, can I check?
Yes, yes. I mean, you can, whoever has, can just start the screen sharing. There's no problem.
Yeah.
We
Is
can
it
see
visible?
Dr. Yes, ma'am. It's not in presentation.
Yeah,
Could
it's
you just put
visible.
it in the presentation mode?
Yeah. Okay.
Yes, it's visible perfectly, ma'am. No problem.
Thank you.
Yes. Sneha, you're there, right?
Share screen code.
Yes, yes, I'm there.
Just take it forward from here.
Yeah, thank you.
I am not being able to see my other windows from if I'm starting the screen share.
You've opened your presentation, ma'am. Is that correct?
Yeah, I have opened it, but this is another window. This is a Mac. So
Is this
I
a
am
MacBook that you're using?
Yeah.
Maybe our
MacBook is,
technical team can help you with that.
yeah, MacBook is something that even we are a little handicapped with, actually. Let me be honest. We've got representatives from the Grover Audio team. Can I request somebody to please intervene and let us know?
I'm just not able to get the background screen.
Yes.
I hope it's okay.
कन्हैया यादव जी,
Yes, sir.
कैसे हो? अच्छा, आपको मैक का ये मैडम को हेल्प कर पाओगे? हम तो नहीं कर पाएंगे, थोड़ा सा डिफिकल्ट होता है.
See, if I'm saying share screen.
Same function होता है इसका भी.
Yes, ma'am. Go ahead. जब आप बोल रहे हो,
See, I have done the share screen, and I'm not being able to get the screen which I have opened.
Okay, so ideally, जितना हमारा idea है, Mac uses a lot of privacy settings, तो वो बहुत आपका data protect करके रखता है, तो कोई भी app को allow नहीं करता है to see any other application.
Ma'am, if I may suggest, last time what we did during such technical glitches, we had shared one email ID from our audiovisual team, and if you want, you can email your presentation to them, and they can play it on your behalf. You can just request them to go to the next slide whenever the presentation is, if that is okay with you.
Okay.
कन्हैया जी, आपका email ID मैडम को भेज देंगे, please.
Send कर दिया मैम chat.
जी. Dr. Vaishali, please check your chat box. He has shared an email ID
It's
with
not
you.
Dr. Vaishali, it's Dr. Sujata.
Okay. Okay.
Dr. Vaishali's presentation is working fine.
All right.
Dr. Sujata Guha's presentation.
Yeah, I'm not being able to share my screen at all. That's the whole problem.
Welcome to the world of Apple. And ma'am, you're not the only one who's facing that problem. It is common. So it's something like the cough and cold for everybody.
I have another cough. I'm not getting able to have the background screen.
You know what? It's a large file. I don't know whether I'll be able to share it. It's a huge one with videos and everything.
Oh my.
All right. Then ma'am, you have to. Okay.
कन्हैया जी, देखो ना, अगर आपके दूसरे कोई हॉल ए से किसी को मैकबुक के बारे में पता है, उनको ला सकते हो यहाँ पर. तो हेलो हाय
सर. हाय. प्रोसेस तो सर उसका सेम ही है.
नहीं, लेकिन वो दिख ही नहीं रहा है ना, तो उनको परमिशंस देना चाहिए ना. तो एक काम करो ना, एक बार या तो नरेश जी को पूछ लो कि कोई अपना एप्पल का एक्सपर्ट है क्या, क्योंकि उनको स्क्रीन ही नहीं दिखाई दे रही है. या तो एक काम करो ना, मैडम का मोबाइल नंबर ले लो, एक वीडियो कॉल करके उनसे सॉल्व कर लो.
ठीक है मैम, आप नंबर एक बार चैट में डाल दीजिए प्लीज.
Dr. Sujata, can I request you to please put your WhatsApp number on the chat itself?
Yes. Yeah.
In the meanwhile, we shall be getting started in exactly 9 minutes from now.
Yeah, I have put it.
Sure.
Yes, ma'am. Hello, Dr. Rohit. Welcome. So we are still waiting for the chairperson and the co-chairperson to join.
Also, our first speaker is Dr. Siddharth Agarwal, and he's also not to be seen. Dr. Rebecca is also not there. Dr. Shetty is also not there. So I believe we're going to be having Dr. Vaishali going in first, followed by Dr. Sujata, and then we'll see where it leads to.
Yeah, we still have 7 minutes to go. Maybe they join.
But that's cutting it too close, especially for the first speaker. We have our convener, Dr. Rohit Saxena, with us. In fact, our moderator is also not yet arrived, Dr. Digvijay Singh.
Digvijay Singh, yeah.
A lot of people are needed. कन्हैया जी हो गया फोन डॉक्टर सुजाता को? आपको कुछ पता है? नो प्रॉब्लम, थैंक यू सो मच सर. यही तो बात है ग्रोवर की, टेंशन ही नहीं होता है. All the experts at one place. Okay, so we'll just wait for the speakers to join in. Since this is the last session for the day, we're not going to be that adamant, but we would definitely like to start it on time. We've got some attendees. Okay, Sneha, I think just wait for the chairpersons.
5 more minutes, yeah.
Especially the moderator. If not, if you have the first speaker, do get started. I mean,
yeah, anyway, the co-convener has joined, so maybe with...
Yes, but Dr. Rohit, could you please switch on your camera? Let us know you're here with us. But I think, Sneha, you'll have to be the moderator as well for this session.
Yeah, no problem.
Keep it on time, and that's all we ask for.
Certainly.
We have the valedictory at 5:30 as well. So,
in Hall A.
Yeah, I'll be moving to Hall A after this, so I'll see you there.
All right. So 4 minutes to go. Dr. Vaishali, we may have to start with your presentation because we don't see anybody else. I mean, we can give some time to Dr. Sujata to get sorted with the presentation.
Yeah, no issues.
All right, ma'am.
Yes.
All right, ma'am. Perfect. Okay, there are some attendees. Let us see. All right. Great. So Dr. Digvijay is here. Welcome, Dr. Digvijay.
Yes. Good evening. I'm here now. Just
Yes, sir. So we have 4 minutes to go. I'll quickly introduce the session and I'll introduce all the chairpersons and you, and then I'll hand it over to you, sir. So you can take it forward.
Sure. Yeah.
All right, sir. Okay, there are. All right. Sujata ma'am is also here, and Dr. Siddharth Agrawal. Perfect. So Dr. Siddharth is here. He is our first presenter.
Yes.
Hooray, ma'am. It's working. Sujata ma'am, it's working.
That's great news. She managed all by herself. Sujata ma'am?
Yeah, it's working. Thank God.
Vaishali, you're the management of Duane syndrome, right?
Yes. Once.
Dr. Vaishali, Dr. Siddharth is already here. So maybe we can start with Dr. Siddharth.
Okay.
As per the schedule, and then we'll see.
Do I come in second then?
I'm just checking, ma'am, who all have joined. I think, yeah, you will be second, followed by Dr. Sujata, because Dr. Rebecca and Dr. Shashikant Shetty have still not joined.
Rebecca may not join. Shashikant should join.
All right, sir.
Rebecca is out. She wouldn't be in an area where she can access. So Shashikant should join.
No problem.
You can play it by that. I mean, start with Siddharth, and if Shashikant joins, then he's there. Then Vaishali.
Perfect.
Good afternoon, sir.
Hi, Dr. Vaishali. Hello, Dr.
Hello.
Sharma. Sir.
2 minutes for us to go live.
Good evening, sir. So I think we're all set. Yeah. Dr. Frank Martin joining?
He should join. He said he would. Dr. Pradeep Sharma is there now. There is no problem. Any
Yes,
speaker,
very
any person not there,
we can cover for that.
We'll have more than our share of information. So that is no problem.
So, all right, sir. In 3, 2, 1, let's have the session. Hello and welcome everyone to the last session of South Asia Academy Ophthalmology Conference. And this session is on strabismus, an eye condition which is common but very important for good vision. We have with us the chairperson of the session, Dr. Frank Martin. We are waiting for him to join, along with the co-chairperson, Dr. Pradeep Sharma, co-convener, Dr. Rohit Saxena, and Dr. Suma Ganesh. We also welcome our vibrant moderator, Dr. Digvijay Singh, and I request Dr. Singh to introduce the panel and take it forward. Over to you, sir.
Yes, thank you. It's indeed a pleasure to be moderating this session on strabismus. And on the panel, we have with us Dr. Swati Fulchale and Dr. Pujari. And I think Professor Pradeep Sharma is the acting chair for the session. Sir, good evening and welcome, sir. Hello. So I think without further ado, we'll move to the first talk by Dr. Siddharth Agrawal on the basics of strabismus examination.
Warm greetings to everyone. Am I audible?
Yes, doctor.
Thank you. So warm greetings to everyone and regards to Professor Pradeep Sharma sir and Dr. Rohit Saxena. I would be speaking on the basic steps of strabismus examination. Now the questions to be answered at the end of the examination is whether...
We go slideshow, full slideshow. Yeah,
right.
That's right.
So the questions to be answered at the end of examination are whether the patient that we are dealing with actually has strabismus, what type of strabismus are we dealing with, refraction, visual acuity, and binocular functions of this patient, and whether I can manage this patient or whether I should refer the patient to a specialist. Now, as is obvious, not many instruments are required for basic examination of strabismus. The examination can be classified into the assessment of vision and refraction, the motor examination of the patient, and the sensory examination of the patient. Now, the most important step, which is often cut short in a busy OPD, is the assessment of vision and refraction. Age-appropriate methods should be used to assess the visual acuity of the patient. In very small children, instruments like the Saocon drum or the preferential looking charts may be used. And in slightly older children, e-chart may be used after proper explanation to the child. The refraction should be performed under adequate cycloplegia, and the cycloplegia depends on the age and the race of the child. The Bruckner test is very useful, and assessing the glow gives us a lot of information, specifically when the glow is asymmetrical or is unhealthy. Now, it is important to observe the deviation under cycloplegia when the accommodative effort of the child has been neutralized. It gives an idea about the static and the dynamic component of strabismus. Once the patient is dilated, the examination of the retina and assessing the fixation of the child should be done at this stage. Should amblyopia be suspected, one should confirm by ruling out other causes of poor vision and make an attempt to quantify the amount of amblyopia. Coming to the motor examination, all three components of the anomalous head posture, the face turn, the rotation of the head, and the elevation or the depression of the chin should be carefully looked for and noted. The Hirschberg tests gives us an idea of the deviation, which is confirmed by the cover test and the cover-uncover test. These will be I'll be showing a video to explain them in the next slide. And these tests are the backbone of strabismus examination. The patient should be made to fix at the specific target while performing these tests. It could be the mount on the spectacle frame of the examiner, as is shown here. The prism cover test is also being covered in the next video. Now, Hess chart is important in concomitant deviations. It is essential to eliminate the compensatory head posture while performing these tests. Motility limitations should be carefully looked for and documented. Limitation on versions should be confirmed by following the testing on ductions. Finally, the Vergen's movements should be checked for. Now, this is a short video to demonstrate the cover test. The examiner covers the fixing eye to elicit the fixation movement in the non-fixing eye, without and with the glasses. An alternate esotropia has been noted. And once the deviation is decided, the direction of the deviation, the prisms are placed in front of the non-fixing eye and increased in amount till the movement stops. And that gives us an idea of the amount of deviation. In larger deviations, it may be useful to use loose prisms and gradually increase the amount of the prism to neutralize the deviation. When the movement stops, we get an idea of the exact amount of deviation. Now, coming to the sensory examination, in patients with diplopia, a well-conducted diplopia chart gives us plenty of useful information. Worth 4 dot tests gives us an idea of the binocularity, and the stereopsis is quantified by tests like the Randot stereograms. The beginners should watch out for gaze incompetence, as is seen here, the V pattern exotropia with inferior oblique overaction. They should be careful about motility limitations, as can be seen in the left eye of this patient, which does not elevate, and specifically for palpebral fissure abnormalities. Similarly, extremely large deviations and cyclic deviations should be handled by experts, and their management should not be attempted by beginners. Finally, one should remember that examination may need to be repeated, and complete examination may take 2 to 3 visits. The examination should be carried out with proper refractive correction in place. And preferably the sensory examination should be done before the motor examination, because performing the motor examination often compromises the fusional effort of the patient. The ophthalmologist dealing with strabismus should understand and be confident about the cover and the uncovered tests, as these are the basic foundations of strabismus examination. One should be watchful for gaze incompetence and motility limitations. Thank you for a patient hearing.
Thank you so much, sir. Do we have the chair? Any questions for Dr. Siddharth?
I think so.
Sir, please unmute. Sir, unmute.
Dr. Martin is here. Welcome, doctor.
Yes. Yes.
Dr. Martin. Welcome, sir.
Welcome, Professor Martin.
Thank you very much for involving. Sorry, I had trouble connecting. We've had a very bad storm and we've got unstable internet at the moment. Yeah, but thank you, Siddharth. As always, you present so logically and yeah, for someone, because strabismus is something that all trainees and practitioners have difficulty in knowing how to manage and how to diagnose. And you've put it forward that have a look at the patient, and head posture so important. You've stressed, and you've shown how just to do basic tests, the cover test, and then to document what you have. So I have very little to add to you. I think it was a great presentation.
Thank you, sir. Thank you.
Right, sir. So I think with your permission, we can move on to the next talk. So we don't have Dr. Rebecca with us. So we'll move on to Dr. Shashikant Shetty, who's going to talk about nystagmus simplified. So a topic which is often daunting when we face a case, but so over to you, Dr. Shashikant. Dr. Shashikant from Arvind Eye Care from the south of India. Are you there, sir?
I can't see Shashikant.
I don't see Sir Shashikant sir has not joined yet.
Just go ahead. I'll
Dr.
call
Vaishali,
Shashikant.
can we move on to your talk then? On the management of Duane syndrome. Dr. Vaishali is from Aurangabad Medical College. This is I think additional professor there, ma'am.
Yeah. Good afternoon, all. Good afternoon, Professor Martin, Professor Sharma sir, Professor Rohit sir, and all my colleagues. I would like to start my talk on Duane's retraction syndrome. Yes, I hope my screen is shared.
Yes, ma'am. It is visible.
Yeah. So, Duane syndrome is also known as, referred to as Stilling-Turk-Duane, because we'll be doing a lot of disservice if we don't mention Dr. Stilling, who first introduced this in the 1840s. And it is also known as a co-contraction syndrome. It is a defective horizontal eye movements with palpebral fissure narrowing on adduction and widening on abduction. It is more commonly seen in females Unilateral cases are up to 85% and involves more involvement of left eye is more commonly seen. In genetics, more research is being now done, and we are getting newer and better options for the treatment management. But sporadic cases are up to 90%, and the mutation is found in the CHN1 gene. So a little about etiopathogenesis. We have abnormal and paradoxical innervation to the horizontal recti because of the maldevelopment of the sixth nerve nucleus at the 4 to 8 weeks of gestation. And later on, there can occur contraction or fibrosis of the medial rectus, and superior rectus may also be involved. The left eye, as already I have mentioned, is preponderance is seen in up to 75% cases, and bilateral cases are around 15 to 20%. So the clinical features are briefly what it is about. So limitation of abduction. There may be in other type, the Huber's classification, that limitation of adduction also will be there. Then there is retraction of the globe. If we see minutely, if we see the interpalpebral fissure here, it is quite narrowed down and the globe is retracted. And then there is altered head posture. So this almost has 15 to 20 degrees of altered head posture, just now as highlighted by the first speaker, that presenting complaints may be of altered head posture. Just a small video. I'd like to show the various clinical features in this case. If we see, this is almost an orthodoents, and when we see there is limitation of abduction, and here there's co-contraction, so there's interpalpebral fissure is narrowed, and again we see the upshoot of the eye. So this primarily sums up the clinical features which are seen in a case of Duane's syndrome. See the retraction of the globe. So if there's a restrictive pathology, a part of congenital cranial disinnervation disorder, and which causes the developmental errors in the innervation of ocular and facial muscles. The ocular associations include nystagmus, congenital cataract, anisocoria, anisometropia, optic nerve hypoplasia, and anisocoria. And the syndromic associations are Goldenhar syndromes, Wilder-Vanck syndromes, and the SALL 1 to 4. So let's come to the types. Type 1, which is the commonest, is where the abduction is limited and there is normal adduction. It may also be called as esoduvance because esotropia is most commonly involved, and there is globe retraction and IPF narrowing, as has been explained earlier. Then the second is a little less common, where adduction is limited, and this can be also labeled as exoduvance, exodrs, where abduction may be normal or limited, but there's globe retraction and interpalpebral fissure narrowing on adduction. Then the type 3 is when there is both the limitation of adduction as well as abduction, and along with the globe retraction and the IPF narrowing. The causes of upshoots or downshoots, as we saw in the video, is because of the co-contraction of the horizontal recti that causes the slippage of the globe under the tight lateral rectus, and it does not follow the Sherrington's law. The most important step is doing the force duction test, which will let us know about the contractions of fibrosis in the horizontal recti. So what are the differential diagnoses? Yes, most commonly is the lateral rectus palsy, the sixth nerve, and infantile esotropia with cross fixation. But in this case, we need to patch the eye and then see for the abduction. So most it is very easily identified. Then sometimes a recovered third nerve palsy may have this disinnervational like symptoms, Mobius syndrome, and congenital oculomotor apraxia. There can be pseudo-Duane syndrome also, when the medial rectus is entrapped in fracture of the medial wall, causing the retraction of the globe. So coming to the main part is what are the indications of surgery. In orthodonts, it is very difficult if there is gross altered head posture, but we have to be very, in experienced hands only, we have to do these because the patient is orthophoric, there's no element of squint, but because of the altered head posture, the patient may demand surgery. Then ESO and exodovants, and in cases of marked global retraction, and when it is cosmetically unacceptable. Medical management is of limited value. Only if there is small deviations, then use of Fresnel's prisms can be tried. So this I have borrowed from the article by Nripen Gaur and Professor Pradeep Sharma sir from Indian Journal of Ophthalmology, and where we have this chart when if it is unilateral and less of only one muscle, it is less than 20 prism diopters, we can just go in for the medial rectus recessions. Whereas if there are the angle is more, then we can go, we have recessions with partial VRT, that is vertical recti transpositions. And if there is bilateral case, then both bilateral medial rectus along with the superior or partial vertical recti transpositions can be tried. So the surgeries are Y splits for recession. If it is the angle is quite less, a single muscle will do. Whereas the Y split for the upshoots and the downshoots are done. Here we see that this child has a upshoot and a small angle, so only a right medial recti recession was done, and then post-operatively she was ortho. And now if we see this pre-op picture of a vertical upshoots, we have the lateral rectus is split up 18 to 20 millimeters midway away from its insertion, and then it is sutured apart between almost 20 to 22 millimeters away, and that will give to a good results of the treatment of the upshoots. In this case, we see the treatment of the downshoots, pre-op and post-op pictures. So what are the vertical recti transpositions? We can do the superior rectus and the inferior rectus to help correct the abduction abnormality. So to summarize, in cases of unilateral ESO-orthodonts, a single muscle medial rectus recession can be done. And in if it is more than asymmetric recessions can be done. Whereas in cases of small, large angles, ipsilateral, medial and lateral recessions are done. Upshoots and downshoots need to be managed with the Y split of the lateral rectus. And of course, each case needs a customized approach, and severe abduction deficiencies can be managed with the vertical recti transpositions. The role of adjustable sutures, like with the experts we have, maybe Pradeep Sharma sir can throw light on it. And thank you all for a patient listening, and thank you for giving me this opportunity to present my presentation in this conference. Thank you.
Thank you, Dr. Vishali, for that wonderful presentation and summarizing a difficult topic in a short span of time.
Thank you so much.
Professor Martins. Dr. Pradeep Sharma sir, any comments you would like to make before we move on to
I think Vishali has done a wonderful job. As you mentioned, it's a very complicated subject to handle, and many people have burned their fingers handling the joint retraction syndrome. So I think what she has mentioned should be kept in mind. We should basically see that it's an ESO, exo, or ortho DRS. Secondly, we have to see how much is the severity of the co-contraction. Co-contraction by definition is always going to be there in a DRS. But if it is minimal co-contraction, then alone you can do in ESO DRS a MR recession alone. But whenever there is a moderate to severe co-contraction, you need to balance the MR recession along with doing a LR recession with Y split. So because the paradoxic innervation has to be kept in mind. In exo DRS, you may get away with just an LR recession with split Y LR recession. But in ortho DRS, which she mentioned was very complicated, you will have to balance the ESO and exo forces by doing an adjustable on the MR and doing an LR recession with a Y split. But the improving the abduction is a second thing that we may use the vertical recti transpositioning, but provided we have taken care of the co-contractions.
Thank you, sir.
Yeah.
Thank you for your input, sir.
With Duane syndrome, I always tell the patient or the parent of the patient that all I can achieve is improve the situation. It's impossible to cure. It goes from all the restrictive conditions, and transposition is certainly. I tried it, and I found that the results were disappointing. That you get a little bit of abduction, but I found that getting near normal abduction was almost impossible to achieve. You've got a great result with your patient.
Yes, sir. Thank you so much.
If there's time, I had a quick comment and a quick question, if that's okay.
Yes, Dr. Saurabh. Yes.
So firstly, thank you for a great talk. I think, this was very clear. And I think as Prof. Martin and Prof. Sharma said, you have to be very careful before operating on a Duane's patient. You just have to set expectations right. These muscles are not normal. When you go in and find them, they are restrictive, they are fibrotic, they don't behave the way your normal tables don't follow. So the fun thing I've always been taught, which I've found helpful, is there can be two kinds of upshoots, as you say. There can be a quick upshoot, and that's a co-contraction. They can also have upshoots in primary gaze, which are because of innervation of the vertical muscles. In those cases, a recession of vertical muscle is better than a Y split or a large recession. The second thing about, I completely agree with Prof. Martin about rectus transpositions. I never do both muscles. If I do, I just do the crouch procedure. I do the SR with a augmentation suture. But I found the results to be not very good. And I've started doing a Nishida instead of vertical rectus transposition, because you're not, doing so much surgery. Then you're just pulling the muscles to one side. And if it works, great. If it doesn't work, you haven't disrupted the vasculature of two more muscles. So just a thought.
Correct.
Right.
Thank you, sir. Thank you for your
Thank you. So I would now like to invite the next speaker, Dr. Sujata Guha from Kolkata, to give a talk on management of Brown syndrome.
Please unmute yourself, ma'am.
Yes, ma'am. Your slides are visible. I'm just shifted to slideshow mode.
Yeah. Am I audible?
Yes, ma'am.
Okay.
Put in slideshow mode.
Yeah.
Yes.
So good afternoon, everyone. And I would like to thank Dr. Rohit for inviting me to this symposium. I will be speaking on a rather unusual strabismus entity, the Brown syndrome, which was described way back in 1950s. Now, the Brown syndrome is considered to be a part of the CCDD complex. So during the next few minutes, I shall be giving a short overview as to how these patients present to us. How do the congenital and the acquired Browns present? What are the treatment options of both, and the results and the complications? So how do these patients present? Most of them, the congenital ones, are asymptomatic. They might present sometimes with an abnormal chin-up posture or a face turn, or they might present sometimes with a primary gaze hypotropia. But the acquired ones are more dramatic. They present with diplopia and pain and tenderness around the trochlea. The hallmark of this disease is limited elevation in adduction and a forced duction test, which is positive. They also could have divergence in upgaze or and a V pattern. They could have a downshoot in adduction. Sometimes there could be a wide link of palpebral fissure on adduction, small hypotropia in primary gaze, and sometimes an audible click when the patient is trying to elevate in adduction. Now, the congenital presentations of Browns are mostly asymptomatic, with only abnormal head posture as the commonest presentation. As I told you before, the acquired presents with diplopia, pain, and they are rather sudden in onset. The conditions associated could be trauma, could be SLE or rheumatoid arthritis, cysticercosis commonly in our country. It could be iatrogenic also. So investigations will include inflammatory workup like ESR, CRP, ANA, and CT or a MRI could be done to look for enhancement and thickening of the superior oblique muscle or the trochlea. It could also give you an idea of the presence of any cyst with a hyperreflective echo inside. Ultrasound could also be useful to detect cysts, especially in cysticercosis. So what are the treatment options? Mostly the mild cases, that is the ones with the restricted elevation only in adduction without any tropia or any abnormal head posture, or a moderate Brown's with a downshoot, do not require any treatment. Surgical treatment is required only for severe Browns. The main management will be masterly inactivity, because spontaneous resolution can occur in up to 75% of patients. This child presented at age 5 with Brown syndrome, bilateral Browns. At age 9, both eyes are not elevating in adduction. At age 17, the left eye has started elevating a little bit. The right eye is still not being able to elevate. At age 28, if you see, the elevation has come. So for mild to moderate Browns, spontaneous resolution can occur anytime after the age 15. Guyton's exaggerated traction test has been both diagnostic and therapeutic, wherein we retropulse the globe to make the superior oblique tendon taut, and then we adduct and elevate in the supranasal quadrant the globe and move it temporally. So in this movement, we can feel the bump of the superior oblique, and sometimes some of the anomalous bands between the superior oblique tendon and trochlea could be broken by this particular movement. Now, acquired Brown's management would be, if it is cysticercosis, it could be albendazole and steroids with gratifying results. NSAIDs, oral and local steroids into the trochlea could be given. However, you must inform the patient that the motility may not return despite a good improvement in symptoms and the head posture. So this is again a patient of Brown syndrome, and the right eye severe hypertropia with right elevation deficit in adduction. This is the pre-treatment. Post treatment with albendazole and steroids, the hypertropia has resolved reasonably well. And this is another patient where we are showing you the forced exaggerated Guyton's test. We retropulse and move the eyes temporarily. Once again, retropulse and move it temporarily, and see the difficulty in moving it temporarily, see the tight superior oblique. And we can also, I'm also showing you the injection of steroids in the superior nasal aspect into the trochlea. So now coming to the surgery, as I had told you, indications would be hypotropia in primary gaze with a significant chin-up posture or a diplopia. The different options would be tenotomy or tenectomy, tendon expanders either with silicone bands, sutures, split tendon elongation, or a surgery in the trochlea per se. The tenotomy was first described for Browns. However, it had a high incidence of superior oblique paresis post the procedure. So this is basically has been abundant virtually now. Most people prefer to do a posterior tenectomy if they at all do a tenectomy for Browns. The posterior tenectomy reduced the instance of superior oblique recession, superior oblique paresis. And when it was first described, they had also combined it with the inferior oblique recession. Now, tendon elongation is now the surgery which is preferred for Brown syndrome. Here we cut a part of the tendon and then put some kind of elongator, either a band or a suture, to elongate the tight superior oblique tendon. The superior oblique is isolated in the nasal quadrant, that is nasal to the superior rectus insertion, and a suture is placed with a slight lag, about 8 millimeters of lag between the two sides of the suture, and the oblique muscle is cut between the two sutures. A modification, this was first described by Naps, the chicken sutures technique, and a modification would be the same surgery in adjustable suture technique. We always do a force traction test after the end of this procedure to see how tight the superior oblique feels. The expanders can also be, instead of permanent sutures, like I had described before, it could be a silicone oil band. The 240 band is used. It could be fascia lata. It could be Achilles tendon, palmaris longus tendon. All of them have been tried with various good success rate in Brown syndrome. Now, currently, a very popular method is split tendon lengthening. Because of the disadvantage of the tendon, artificial tendon elongator, like extrusion, like granuloma formation, a split tendon lengthening has been very popular, is becoming very popular now. In this, the tendon, I am showing you a representative thing, a tendon is lengthened, and then it is cut and fixed by a single suture, as you see the representative animation. Because it is a single suture, chances of extrusion, chances of granuloma are rather minimal. It is a reversible and titrable procedure. Now, trochlear surgery for acquired Browns has been described when you have some trochlear anatomical problem. It is usually done by the oculoplasty surgeons. So to summarize, Brown syndrome is mostly asymptomatic, and it has a very high rate of spontaneous resolution. So conservatively, wait and watch management would be a prudent method of managing these patients. If there is an abnormal head posture and a significant vertical deviation, you can go in for surgery. Tendon expanders, either by permanent sutures or split tendon elongation, can be done for Browns. Medical management like steroids into the trochlea or oral steroids with albendazole can be tried for acquired Browns. Thank you.
Thank you. That was a wonderful paper. You've summarised the management of Browns just so clearly. And I think the important thing, as you've said, is wait, watch and wait, because most of them don't need surgery. And if we look at, if we think, how many adults do you see in your practices with Brown syndrome? You just don't see.
Rare. Yeah.
And I really like the way you described the tendon lengthening, because I don't like putting foreign material into the orbit. I've had problems with, it doesn't matter what I've used. And I think that with as you said, with a single suture, you've got a very straightforward technique and you can reverse it.
Yeah.
And the other important thing you pointed out, and after you've done it, to redo your force traction, because sometimes there can be a nodule along the superior oblique, and then you can go back and look for it. And if you haven't looked, you're going to have to reoperate. So it's a great paper. Thank you.
Thank you. Thank you so much.
Indeed, Dr. Siddharth. I think these are difficult cases, and the decision, to operate or not is always one keeps thinking, and particularly, but I think they're also, quite often missed actually. I think a lot of times people may have certain element of Brown syndrome or may not realize it, or, even as ophthalmologists, they're not always looking at extraocular motility in all patients. So it is something that can often get missed.
Yes.
Professor Sharma, sir, anything you'd like to add, or Dr. Anin from the panel, if anything you want to add before we move on and invite the next speaker?
No, I think I would agree that we would need to follow them up, although I don't see so many resolutions as 75% as claimed by some of the people. I do see them several times, they keep having them, and I have seen adults also having Brown syndrome and they still have it. So the only thing is that as you gain height, the problem of Browns is reduced.
Yes.
So that is something which is there, that many of the times in adults it's missed. Mild browns are always missed in adults because they don't have to look up to anybody else. Children have to look up to you all the time.
Yes.
So that's one reason I see that there is a resolution claimed so much. But yeah, as far as surgery is concerned, my choice is to avoid any surgery on the nasal aspect. And whenever I find a very tight FDT for superior oblique, I do a hanging loop tenotomy on the from the temporal side. So it's like a hang back recession on the superior oblique with a non-absorbable suture, so that I can always reverse it also. That is what is my favorite technique on operating on the temporal side of the superior rectus rather than on the nasal side.
Point well taken, sir. Yeah.
Thank you. Thank you for your inputs, and thank you for the lovely talk, Dr. Sujata, ma'am. So I now would like to invite Dr. Sabina Shrestha from Nepal, from Kathmandu Medical College, to speak about surgical outcomes of strabismus surgery. So the stage is all yours now. You need to share your screen, Dr. Sabina.
I'm trying. Okay, good evening, everyone. So I'm presenting on surgical outcome of strabismic patients. I'm having difficulty in opening my slide, actually.
Right.
I have traveled recently. I just reached Biratnagar in the hotel. So I'm trying to open it. Hopefully it will open.
Yes, something is coming up, I think.
Yeah.
Okay.
Yes, yes.
Can you make it slideshow? So
I'm trying.
okay.
The net here is not good, it seems.
Yeah, just press the F5 key on your computer. That also will work.
Excuse me, pardon?
The F5 key on the keyboard if you have, or you can just go to slideshow from the top tabs.
Yeah.
It's come.
Yes, that's perfect. Yes. So all yours. Yes.
Thank you. Strabismus is one of the common ocular problems that is encountered in our daily practice. It causes cosmetic deformity, functional impairment, and psychological problems. The average percentage of exodeviation in European countries is less as compared to the Asian countries like Japan and Nepal, where the highest percentages of exotropia we encounter. And surgery is the mainstay of treatment in the majority of situations when strabismus persists even after conservative therapy. The study was conducted to evaluate ocular alignment and binocular single vision following the surgical treatment. It was a hospital-based prospective study with a sample size of 32 over a period of a year, conducted in Kathmandu Medical College Teaching Hospital. All patients with manifest deviation requiring surgery were enrolled, and detailed relevant history, comprehensive ophthalmological examination, and full orthoptic evaluation was done, and all surgeries were performed by a single surgeon. And in cases where recession had to be done, it was done with hangback technique, all the recessions, and follow an examination was done on first post-op day, 1 week and 6 weeks post-surgery, and data analysis with SPSS version 21 and p-value less than 0.05 was considered statistically significant. These are some of the photographs pre-op and post-op of the patients. The table shows the age distribution with maximum number 43.8% in the age group 20 to 29. Female is to male ratio was 1.13:1. Regarding the distribution of patients according to age of onset of deviation of eyes, congenital was 43.8%, less than 8 years, 37.40%, and more than 8 years of age of onset of strabismus, 18.8%. Regarding the family history, 43.8% had positive family history of strabismus. Among them, 50% had the first degree relative affected and 50% had second degree relative affected. Regarding the types of strabismus, Manifest exo was present in 78.1%, intermittent exo in 12.5%, and manifest ESO in 9.4%. Regarding the distribution of surgery, unilateral resection was done in 3.1%, bilateral resection was done in 3.1%, while maximum patient, 93.8%, underwent recess-resect procedure. And bilateral eyes were operated only in 2 cases. Mean amount of deviation in prism diopters, pre-op and post-op. For distance, pre-op was 47.19 prism diopters, and post-op it was 7.47 prism diopters. Similarly, for near, pre-op it was 45.09 prism diopters, and post-op 6.31 prism diopters. Regarding the status of near stereo acuity, post-operatively, good stereo acuity was obtained in 6.9%, moderate in 10.3%, and poor in 17.3%, while it was absent in 65.5% among the cases with exotropia. Similarly, regarding the status of binocular single vision pre-op and post-op, it was present in 24.1% post-operatively, while it was present in 3.1% pre-operatively. Coming to the discussion, in the present study, 78.1% of the patients were orthophoric post-operatively, which is different from the study by Sharma et al., where 25% subjects achieved orthophoria. In a study by Glassman et al., median deviation decreased from 30.5 prism diopters to 8 prism diopters. In the present study, it decreased from 50 prism diopters to 7 prism diopter. Near stereo acuity was measurable in 31.2% post-operatively from the baseline of 3.1% pre-operatively in our study, which is comparable to a study done by Lieberman et al., which shows 25% gain. Binocular single vision was present in 3.1% patient pre-operatively, which increased to 21.9% patients post-operatively in the present study. In contrast, improvement in binocular function was seen in 42% of the patients in a study conducted by Metz et al. Gross binocular single vision was achieved in 39.3% of the exotropes and 17.9% of the esotropes in a study done by Sharma et al. Different result in our study we have, where 21.4% of the exotropes and none of the esotropes developed binocular single vision post-operatively. Coming to the conclusion, this study shows that exodeviation is more prevalent in our part of the society, and ocular alignment is attained by strabismus corrective surgeries. An emphasis on early surgery before visual maturation has to be advocated so that we can achieve good functional as well as the cosmetic outcome. But the limitations of the study are it has a small sample size, the number of esotropes were very less, and the comparison between them is not of much significance, the esotropes and the exotropes, and the follow-up period was short. Thank you for your kind attention.
Thank you. That was a very interesting paper, and it'd be worthwhile for you to continue to follow these patients for 5 years if possible, because my experience has been that with exotropia, unless I have an overcorrection immediately after surgery, within 5 years, 50% have drifted out. They just drift. And I like operating on esotropes because I think they got a much better prognosis. Exotropes I never liked operating on, but had to. But because the long-term results I found to be disappointing for me, disappointing for the patients. But I think you've pointed this out that, you can get some BSV, you can get some stereopsis, and the ones who got stereopsis probably had stereopsis earlier before they probably were an intermittent XD and then became a constant and requiring surgery. But I think you've, in a small sample, shown the trend, and I'd really encourage you to follow them for another 5 years and then give us the results.
Okay, thank you for the advice. I'll try to trace them up if I could till 5 more years.
Indeed. I think from the patient's perspective, they're looking at, at lifetime results when they come in for the surgery. That is the thought process with which they come in.
But in my previous study, I had done similar study in the past also. Like those patients I had followed up quite for some time, after 3 years, 5 years also, they were doing good. Only few patients, I had to do the repeat surgery after few years, like after 5 years. But more than that, I was doing the resurgery of the patients done by the other surgeons. But my patients, the ones enrolled in my previous study with around a little bit more than this sample size, around 60, I think, something like that. I forgot actually, but they had better results. I had a longer period of follow-up that time.
I think the key thing is fusion, and stereopsis. And if you have a good level of stereopsis, it doesn't matter what you do.
Yes.
We pat ourselves on the back saying we did the surgery. Actually, they do most of the work. And if they don't have fusion and they don't have stereopsis, it doesn't matter what you do. They'll eventually adapt. And I think it's just best to always tell them before we start, listen, I can give you 5, maybe 10, maybe 15 years of straight eyes. This is going to drift out again. It's all expectation management. But
yeah, usually the patients come before their marriage, no? So what I tell them, okay, before especially in the eyes with no vision, okay, for a few years, 5 to 10 years, I can guarantee. After that, I can't. So before marriage, you do the surgery, that will be fine for 5 more years. After that, I can't guarantee. That's what I have been telling.
The other thing John Lee always used to teach us is, we always tend to, at least in the UK, overcorrect exotropes. So we always say to them, if you like me on month 1, you will not like me at year 1. So we always warn them that there'll be some diplopia, there'll be a little bit of overcorrection. And on the whole, if you warn them, it's fine.
Okay. Thank you.
Thank you. And yes, thanks for your inputs as well, Dr. Saurabh. So I think we'll now come to you for management of fourth nerve palsies. You've chosen a tough topic, and again, a place where expectation setting and outcomes are very important. So over to you.
Thank you very much. And thank you for this very kind invitation. And thank you, Rohit, for inviting and thinking of me, and for your hospitality when I was in Delhi just a few weeks ago. So it seems like a lifetime ago now with, where we are again with COVID. So anyway, greetings from Christmassy London. That's why I've sat in front of my big Christmas tree. And I am going to try and tell you a little bit about fourth nerve palsy and how I manage it. So apologies. Right. Okay. So this is a big topic. Okay. And we all have, there's a lot of variation in how we manage fourth nerve palsy. So just a little bit of overview. So my name is Saurabh Jay. I did my MBBS and MS from Delhi, and now I work in London at the Royal Free Hospital in UCLH, which are in central London, and teach at UCL, which is our university. So fourth nerve is quite an interesting nerve for a number of reasons. Firstly, it's the only cranial nerve that decussates immediately after its exit from the brainstem at the level of the inferior colliculus. It has one of the longest. It says one of the longest courses, so it's very frequently injured. And thirdly, because it is at the back of it's the only one that emerges dorsally, you get a lot of fourth nerve involvement in road traffic accidents. So it does behave quite differently to most other cranial nerves. When we look at fourth cranial nerve palsies, we all know there are 2 distinct groups. The congenital ones, when they have a fourth nerve palsy since birth, maybe they had a head posture, it was just ignored, and over time it decompensates and they come to you. And the history is classically very slow, very gradual decompensation of the symptoms. And then the acquired one will come to you saying, well, I was fine, and then this happened. I had a road traffic accident, or I had a stroke, and the next day I had double vision, and this is awful. So do something. So it's very clear, these two groups, and this is when they're isolated. You can also find them in conjunction with other cranial nerve palsy. So I'll say to all my residents, if you see any cranial nerve palsy, what are you going to test? All the cranial nerves, because you'd be surprised what you'd find. Taking a history, like every patient, is important because they can affect any age, any gender. They can be gradually decompensating, or you can have a sudden onset of symptoms that gives you a clue to the etiology. The main symptom is double vision, especially if it's acquired. It can be vertical, it can be torsional, it can be horizontal, it can be associated with a head posture, whether it's a head tilt or a chin down posture if it's bilateral. And of course, you ask them about the medical history of microvascular disorders, history of any road traffic accident, any demyelination, anything at all that's going on. A family album test, I quite like that, especially if you're not sure if it's congenital or acquired, although your orthoptist will help you. And if they have a higher vertical fusion range, you probably show they're more likely to be congenital. But look at their old pictures and they might give you a clue with the head posture. So we'll start with this 30-year-old man who complains with vertical, who comes to us complaining of vertical diplopia. And you can see there's not much in primary gaze, but as soon as you can see not a lot going on here at all. But as soon as he looks to the right, immediately you will see the eyes swing out and there is a vertical deviation. See, nothing much is happening at all here. Looks to this side and immediately, whoosh, you can see the left eye goes up. So there is a left over right in right gaze. Okay, so when we talk about squint, I always talk about motility and deviation. Motility, and so this is the motility. You can see there's a left hypertropia, okay, and there's a limitation of left down gaze. And this is the deviation. Now, we are very lucky to be supported by an excellent group of orthoptists. So I insist on a 9-gaze measurement for all my patients, especially those with concomitant squint that is different depending on which direction you're looking in. And there are 3 measurements here. Top one is the horizontal deviation, which is not a lot. Okay, the middle one is the vertical, so you can see it's about 10 in primary gaze, increase up to 24 or 30 even in right gaze. And the third is the excyclotorsion or the torsional diplopia, and that also differs in different degrees of gaze. So when we come to this, okay, the important thing is, well, what are you going to do about this? If this is recent and there's a recent event, then you always have to wait for that to settle. And I never operate before 6 months. But if this has been long-standing or decompensated or a congenital fourth, then you can probably do something. And just looking at the diagram of motility, we know this is a left fourth. So what can you do? Well, you can bring the left eye down by weakening this muscle. You can bring the left eye down by tightening this muscle, or you can bring the right eye up by weakening this muscle, and they all have their own proponents. On the whole, if we can, as squint surgeons, we like to operate on the inferior oblique. It's a relatively easy operation to do. I used to do myectomies initially to weaken a muscle. This is the left eye, so the eye is being held up and in, and I'll move the video along. There's an incision just lateral to the inferior rectus, hand over hand until you find the muscle, a little nick in the top aspect of the muscle, and then you pull the muscle up until you see the white triangle. And this is really key. Until you see the white triangle, you should not hook the muscle. Why? Because you really want to be sure you got the whole muscle. You can see it just appearing. It's quite important not to cause any bleeding, because then you're seeing looking for a pink triangle and pink muscle. So you can see just at the end that white triangle appear, and you know now you got the whole muscle, and then you can just hook this. This was done. Yeah, you can see that's the whole muscle. And once you get the muscle, you can do anything you like, really. So initially I used to stretch the muscle and used to take a chunk out of it, apologies, and by about an inch or so, and you just weaken the muscle. And this technique works, but the problem is I found it a little bit unpredictable. You never knew the amount of weakening you'd get. So I moved almost entirely to an infraoblique anterization. So an infraoblique anterization is a technique in which the infraoblique is disinserted. So you can either recess it, so you can put it back, or you can put it right next to the inferior rectus. What you should never do is what you see here. You should never draw it ahead of the inferior rectus, because then you'll cause a anti-elevation syndrome. So infraoblique anterization is quite similar, really. This is the left eye again. This is looking at it from the other way. So again, this same incision. This is your muscle, your infraoblique. You clamp it as close to the insertion as possible, and then you divide it from the insertion. Now here, because it's so tendinous, if you've done it properly, there should be no bleeding at all. And that's when you know you are in the right place. You can see how tendinous the fibers are. And once that's done, you can put some sutures through the anterior fibers and then go right next to the inferior rectus. It's really important to be sure that you look at this blood vessel to make sure you are at IR insertion and not going ahead. Okay. So we still, some of the people who've been doing this for a while follow Knapp's classification for fourth nerve palsy. And this one I just told you about would be a class 1, where the inferior oblique overaction is the primary feature causing left over right most in upgaze. We looked at whether antirization was better than myectomy, and we found that in most cases it was really. We found that the antirization had significantly better postoperative results with no significant complication, and that's really has become my procedure of choice. Okay, so I don't have a lot of choice, a lot of time. I'm going to show you one more case of a fourth nerve palsy. It's a 15-year-old girl, and she came to us again with this double vision, but her problem was in down gaze. She could not read for for a long time. And here you can see her deviation. You see again huge amount of horizontal deviation, beg your pardon, vertical deviation in down gaze, but also a lot of excycler torsion in down gaze. So, and you can see this is from a Hess chart. The main problem is this big weak superior oblique. And here, the best thing we felt to do would be to make this weak muscle more tighter. So we did a superior oblique, and we confirmed that by doing a force duction test. You can see can really push the eye up, and this is a very loose superior oblique tendon. So for this young girl, we decided to make the superior oblique tendon tighter by doing a tuck. Now, there are various ways of doing a tuck. If you can use a tendon tucker, which I don't have, I just use a squint hook, and that works quite well. And what you really want to do after the tuck, so this is before, okay? This is a really loose superior oblique tendon. Once you've finished, you want it to be tighter, so tight that if you draw a line between the two canthi, you can just clear the line with your no tighter. And it's really important, talking about expectation management, to tell your patient they will get some double vision in upgaze. So that's really important to know. So if your patient's a triathlete, or they cycler or the drop down cycle bars, or they paint ceiling, or they're mechanic, then this can be an issue. So it's important to find that out before you start on these procedures. So this is a tricky operation. We don't operate on superior oblique very often. It's difficult tendon to expose. The tendon is quite thin and diaphanous, so it spreads out. Sometimes you can't find where it is. Difficult to titrate the effect. And the one thing I found that really helps me is a phaco chopper. So when you first expose the tendon, there's nothing there. If you just use your phaco chopper just to pick up the first few fibers, you'll see very quickly the tendon appears. And this is, of course, a class 2 palsy. The deviation is much more in down gaze. So those are really the two main surgical procedures we tend to use in treatment of fourth nerve palsy: an inferior oblique weakening or superior oblique tuck. The inferior oblique weakening is, of course, technically easier. It is a self-adjusting procedure. You can get away with doing almost the same procedure for most patients, and it's much more useful when the deviation is more in upgaze. Superior oblique tuck is much less familiar. You know that you are going to cause iatrogenic browns. You really have to very carefully titrate it, and it's more effective when the problem is in down gaze. So do the right operation for the right patient. These are the other classes which I won't really talk about. So thank you very much for your attention, and I'd be glad for any questions.
Super, and that was a great summary again. And you emphasised the importance of looking at photos. Just look at this from baby. Parents don't notice it; they think it's normal, and then your surgical technique. How I always tell my trainees, you don't want any blood when you're operating on the inferior oblique, because I've seen people go fishing blindly, hitting a vortex vein, and that's a disaster. So I think by direct vision, and one thing I've found is just using a top cotton tip applicator to push the globe away exposes the tendon of the muscle beautifully. But they're worthwhile. But can I ask you, if they've got torsion, what do you do?
Thank you, Prof. Martin. So if they have torsion, I have to be honest, inferior oblique is still my go-to procedure because a lot of excyclotorsion with inferior oblique is only when they have a lot of torsion in down gaze. So firstly, you should be thinking, is it bilateral? And if that's the case, you'll be doing a Harada Ito anyway. But on the whole, if they have a little bit of excyclo, the inferior oblique sorts that out as well, I have found.
Yeah. Yeah, well, I agree. That's what I did. Now, the other thing I was pleased you mentioned was Philip Knapp, because that paper of his is a classic, and anyone managing fourth nerve should read that, because he does talk about the one operation is not good for every patient, because if the problem's in down gaze, if you know how to operate on a superior oblique, that's the way to go. If you're unsure, just recess the inferior rectus on the contralateral and bring the other eye up. But I'd recommend that paper to everyone to read.
Yeah, I absolutely agree. And then you say, it's asking the patient, what is your problem? I remember we had a patient all teed up for superior oblique tuck. And just before we got in, I asked her, so what are you doing next month? She's like, oh, I'm a triathlete. I'm like, hang on. So what kind of cycle do you use? And she has this drop down cycle bar. And I said, listen, you will get some double vision after this. If you don't, operation not worked. So, and that led us to change our operation on the day. And that really taught me a lesson, speak to the patient. It solves a lot of problems before they even occur.
Yes, indeed. So Professor Sharma, sir, any thoughts that you have?
I think it's a wonderful presentation by Dr. Saurabh. And I really congratulate him that he has moved from myectomy to anteriorization or recessions, which is what I have been always telling people to avoid myectomy, inferior oblique myectomy. It may appear simple, but it is a problem for the other people when they have to re-operate. So I agree that recession and anterior positioning, and the beauty of IO inferior oblique surgery is that you have so much of range. You can do for a mild inferior oblique overaction, a simple recession, or a moderate, you can do a modified Elliott and Nankins, not a total anterior positioning. Again, the Elliott and Nankin procedure as the total AP is always likely to cause an anti-elevation. And I reserve it only for cases with DVD, dissociated vertical deviations, when I want an anti-elevation. Otherwise, I always modified the Elliott and Nankin by putting the posterior suture 5 millimeters along the border of the inferior rectus. So that is like a recessed muscle anteriorized in that plane, not having the posterior fibers come up. So that causes an anti-elevation. And if you have a 3+ or a 4+ inferior oblique overaction, then in the first instance, I choose to do the Stager's procedure, the anterior and nasal transpositioning, bringing the fibers on the nasal side of the inferior rectus. And that gives you very good correction of the inferior oblique overaction, even if it's a 4+ inferior oblique overaction, a severe supraoblique palsy, for example, in which there is a marked IO overaction. And again, this is causing less anti-elevation than the Elliott and Nankin procedure. So I would suggest that if you have to do inferior oblique surgeries, you have a range of procedures which are there so that you can do. And as rightly suggested, superior oblique tuck should only be done in cases which have a laxity of the superior oblique. And the end result of a superior oblique tuck is always having a slight Brown syndrome to be effective. And you should choose in which cases you would like to give that. So as Saurabh has very rightly said, and of course, if you have a bilateral supraoblique palsy, then the vertical deviation isn't there. It's the torsion which is primarily added up. In a bilateral supraoblique palsy, the hypertropia is annulled by the other eye. So it's the torsion which gets added up. So it's usually a 10 degrees or more of torsion, and always a modified Harada Ito procedure. And if sometimes in some cases we have done an adjustable Harada Ito on one side to give a better control on the torsion. So I think supraoblique palsy is a challenging situation, but it is very gratifying to handle it properly. These cases are really going to be thankful to you. Yeah.
Right, sir. So is there any other questions or comments from anyone? Otherwise, I will then request Professor Frank Martin to close the session.
Thank you very much. Well, thank you again for asking me to be involved. I always learn from others, and this evening I learnt a lot. You really covered some very important areas, from the basic to the more complex, and and strabismus, it's interesting that it's a science, but it's also an art, because with experience you learn. It's a pity that many ophthalmologists, I know in Australia, many ophthalmologists won't see strabismus patients because they're time consuming, difficult, and they'd much rather do a cataract, which is much more remunerative as well. Strabismus surgeons, like we talk about 70, I tell my patients when I'm operating, I've got a 70% chance of getting a stable result for the rest of their life, which means 30% end up having more surgery. Imagine a cataract surgeon saying that to a patient, 70%. They talk 99%, 99.5%. So it's those involved in strabismus take on a challenge, and it makes you think. And I think we just keep learning, and much of what we learn has been from the past. We learn from those who have gone before us, and that's why Philip Knapp was a wonderful man, and he was his experience, and I think Knapp, Parks, and Jampolsky, those three. From the North America, they were the three that made the greatest contribution to strabismus.
Just
Gunther von Norden came afterward. Gunther von Norden was there as well.
Yeah. Just to add on a lighter note, as Dr. Sabina was saying, that many a time the squint surgery is done at the time just prior to the wedding or marriage, and strabismus surgery actually costs less than a bridal makeup. I mean, that is what I found, that when they go for a bridal makeup, that's nothing less than 35,000 or 50,000. And strabismus surgery, they will be paying less than that most of the time, isn't it?
Yeah.
So
it's very undervalued.
Yeah.
Because the patients are very grateful. The number of patients I'm sure you've all had who've told you that you've changed their life by fixing their strabismus. It's a very rewarding specialty to be involved in.
But yeah, I think now we are shifting to early alignment and handling in children so that we can restore not only the motor alignment, but also the stereopsis and binocular vision. And as strabismologists, I think we have come a long way in the past 2 decades, that we have moved to more and more younger surgeries and more definitive aligning surgeries. So I think we should be continuing this pursuit of stereopsis.
Right, so I would like to
thank you very much,
Professor Martin, Professor Pradeep Sharma, the other panelists, and the speakers, Professor Sabina, Dr. Vaishali, Dr. Sujata, Dr. Saurabh Jain, who's at a relatively earlier time in the UK. And so all of you, thank you for joining in, here, and Dr. Siddharth, of course.
Wonderful moderation. Thank you, Digvijay. Thanks.
Thank you so much for inviting us.
Thank you.
We have a quick photograph.
Can I request? Yeah.
Yeah.
Thank you.
All right. So is everybody ready with their beautiful smiles?
I thought it was done.
No, sir. Just a moment.
How will it be shared?
So we shall share it with the Grover's AV team. They can share with the organizers. All right. Smile, everyone. Wonderful. So once again, thank you, Dr. Digvijay, for the wonderful moderation, Dr. Frank Martin for being there and guiding all of us, and all the speakers, co-conveners and convener. Thank you, everyone.
Thank you.
Thank you. Thank you so much.
Yeah.